عشت في الطبيشي وبعدين تزوجت وبعدين
ما أنا دخل في زواجك، لا حول ولا قوة إلا بالله.
لا بس نقول لهم يعني
طيب.
عشان أقول لك قديش ما أحب الشرقية. وتزوجت من الشرقية ودرست في الشرقية في جامعة الملك فيصل، وبعدها انتقلت إلى جدة، ومن جدة على طول على ألمانيا. ما عشت في جدة أي شيء، ما عشت فيها فترة. ومن ألمانيا رحلة العلم والتعلم امتدت على فترة طويلة تجاوزت 12 سنة خارج المملكة، والحمد لله وفقنا ورجعنا. اليوم الحقيقة I made the impossible possible، لأنه في أحد قريب لي من العيلة توفى أول أمس، فما كنت حقدر أجي اليوم الثالث. ولكن كمية الاهتمام اللي لقيتها من الزملاء جميعا الصراحة، وعلى رأسهم الدكتور سلطان التمياط والدكتور الصانع والدكتور القرزعي، لم تدع لي مجال إلا أني أركب الطيارة وأجي وأسأل الله. وكما يبدو يعني الوجيه النيرة هذه، أسأل الله أنه يكون مؤتمر ناجح كما يبدو وظاهر 100%، وشوفة الأخوان والأحبة عظيمة، وخاصة الدكتور عايض عارف الآن يبغى يقوم يخنقني لأني ماخذ وقت من المحاضرات، لكن عاد لا مؤاخذة. نبدأ بالمحاضرة الأولى بالفيديو الأول.
In English يا أبو.
علي بن ناصر.
English. Huh? In English, yeah.
Oh, sorry. We're going to start the first video session, and the first video is an interesting video, which is a reversal of type A and type B Roux-Y gastric bypass distalization for failure to thrive by Dr. Ali bin Nasser Al-Qahtani. So please.
And please, all presenter, we will to time, and excuse us if we stop even the most senior person. We apologize for that, but we have to run it in a proper time so we can finish on the time allowed. Thank you.
Assalamu alaikum. Good morning, everybody. It's my glad to see you all today. So we'll start about bypass reversal. So how can we? So all of us, we know the type of distalization, either to elongate the biliary limb or to elongate the alimentary limb. What if both happen at the same patient? So this is a 35-year-old female. She did at 2017 Roux-Y gastric bypass, and she lost weight, then regained weight after that. She did distalization at 2021, then another type of distalization at 2022. Came to me at the end of 2023 with malnutrition, hypoglycemic attacks, anasarca, and optic neuropathy at the end. So we tried for psychological, medical, nutritional support through 2 months, but unfortunately failed. So decision taken for revision or reversal for intervention, TBN for 2 weeks, and through this endoscopic radiological evaluation done. Can we run the video? Starting by exploring the area, as you see here is the gastric pouch is very small. Then after that, we explore the small bowel. Starting from two fixed area, either ileocecal valve or DJ. From ileocecal, we found the camel channel is 2 meters. Here, the area of jejunostomy, and continue running the biliary limb. On the left hand is the biliary limb, and the right hand is the alimentary limb. We found intraop the two areas of distalization at the middle of the alimentary and the middle of the biliary is amalgamated together. So sharp dissection and separate both limb from each other by sharp dissection, and to identify the anatomy intraop. As you see in the right hand, the area of distalization of the biliary limb. After knowing the anatomy very well, decision taken for reversal. Here at the end of sharp dissection of the small bowel. Then this is the running of the small bowel from ileocecal. This is the common channel. The common channel is 200 cm. Here is the last anastomosis, geniostomy. I also continue running the biliary limb. Yeah, count and be sure there is the continuity to decide. The total biliary limb more than 200 cm. Here the area of distalization at this middle of biliary limb, and I run it till the DJ.
2 minutes.
Then run the alimentary limb from gastric geniostomy. Here is the distalization in the middle of the alimentary limb. And intraop, I'm sure it's not connected to anything else. Till reach the biliary limb and forming the common channel. This is the gastric geniostomy. I transect it because of the gastric pouch is small. We transect the small bowel just distal to the gastric geniostomy and taking, it's like a tongue, posterior extended because it's linear vestibular. We took it sharply by the harmonic away to save as much as I can of the gastric pouch.
1 minute, please.
And gastrostomy done by 2-layer anastomosis. This is, we start by the posterior second layer, gastric anastomosis. Then open the excluded stomach. Then posterior first layer, followed by anterior first layer, and we run the calibration tube to be sure there is no anastomosis, there is no stricture, and to be sure there is we will not take the posterior layer. This is the anterior first layer, and this is the anterior second layer. Then we cut the biliary limb at the end, just before meeting the alimentary limb, and connect it to the, just we cut it from the gastric geniostomy area at the beginning of the alimentary limb.
Okay, we can run it, Dr. Ali, we can let the video
this
run.
This closing the mesenteric defect. That's all. Post-op was smooth recovery. We start oral at day 5.
Excellent.
And was uneventful, and the patient is doing okay. Thank you very much.
Thank you so much, Dr. Ali. Now we will have 2 or 3 questions on the videos because these videos needs also discussion. Dr. Abdurrahman, can we have the mic here, please? Volunteers, we need people standing on both sides with the mics in their hand, please. Get here, Doctor, here, on this side, please.
Question is, did you consider revising or the patient without having to reverse the bypass? Because when you reverse the bypass, they could have weight gain and reflux, and basically revising it by just making the biliopancreatic limb very short and mostly working in the small intestine.
Really, I take from the history, what's the indication for Roman Y? Why especially Roman Y? There was no GERD and there was no hiatal hernia. We reviewed the old operative note. This one reason. The other, there is possibility of revision. We talk open consent from the patient. But really, revision in this patient, she will also have a problem with revise. How much will have anastomosis? So if she need reversal, will be complicated. So now she's young. We reverse the bypass. There is possibility in the future. Maybe she will underwent if she regain weight, and she's mentally stable. Maybe she will have sleeve. But we strictly advise her not to do any more bariatric surgery as to control her weight now is good.
Any more question? Yes, go ahead, Muhammad. What would you do on this as an expert in this case, yourself?
I would have done like Dr. Numeri have said. But it's a good choice what you did, as long as there is no hiatus hernia and you have a future plan, because most of those patients will regain weight. We have seen it in the worst cases of malnourishment after Scopinaro, the short Scopinaro actually, when patients been really underweight, massively underweight, living practically in ICU day in, day out. When we reversed it totally, like you did, within 1 year, they regained the whole weight and an extra 15% on top of it.
So weight regain is a problem?
Yes, absolutely. Now my question is, what sort of indicators that, a patient comes to you with this very bad malnourished,
yes,
failure to thrive, which is a serious business.
Yes.
Sometimes they die without us being able to correct their deficiencies. What is your indicators to take them to surgery? Because you're reversing, so you need good adhesions. Yeah.
There is anasarca and malnutrition, hyperbilinemia, but the most dangerous for me is optic neuropathy. That means it's an advanced case and should be corrected.
But how do you prepare them? The question, how do you make sure they are ready to go for surgery? That's the question.
We start TBN for 2 weeks.
TBN?
TBN. Yeah. Totally TBN.
But what is your indicator?
That you are ready.
That you are ready.
Albumin, for example, or something.
Pre-albumin.
Yeah, we start TBN. We are correct the electrolyte daily, and the most important for me is the albumin. It should be more than 3 or 30.
I think not one element is important.
What you look for before?
I look the whole bunch of series of proteins.
Okay.
One of very important aspect in re-establishing or suturing for healing is the pre-albumin, total serum protein, and I think that is a very important indicator.
Anemias and all these things.
Of course, because I remember I had a case that ended up by multiple fistulas when we operated, trying to save her, thinking that she
because of poor healing.
Poor healing. So
okay.
That's very important.
Thank you so much, Dr. Ali. Appreciate your presentation. A very nice video. Thank you. We'll move to the next presenters. Abdurrahman As-Salim, bilious vomiting, both are on Y. How I deal with it. Good luck. Time, Abdurrahman. ترى أنت بكون شديد عليك.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Actually, it's an interesting case. It was my first time I face it, so that's why I found it's nice to present it. This is a 37 years old male, had sleeve gastrectomy about 14 years ago. His initial BMI was like 64, and his body weight was 82. By sleeve itself, he managed to bring his body weight to 80 kilogram, followed by multiple plastic operations. Now he came back, as I said, 14 years later with severe GERD and weight regain. He was 180, he went down to 80, and now he's 120, and his BMI is 49. You can see in the contrast study that he has a significant reflux, and you can see here in the endoscopy, he has a hiatal hernia and he has GERD. His pH-metry was significant for reflux. So we took him to surgery. And we did basically just standard Roux-Y bypass. We did hiatoplasty as well. We dissected the hiatus. We repaired the hiatus posteriorly. And then we did the 6 centimeter gastric pouch. And we did the Roux-Y bypass. The biliary lymph was like 150 centimeter, and the elementary lymph was 150 centimeter. His common lymph was like 450 centimeter. Just standard bypass actually. That's the gastrogenostomy, and that's the biliary elementary, and then we did the JJ, as I said, like 150, 150. And it was straightforward, actually. We did side to side, and we closed the enterotomy in a transverse fashion. And after that, we closed the Peterson and mesenteric defect in a running fashion, and we did esophagopexy. Now, in the same night, and I usually do my rounds on patient late at night, he had bilious vomiting, and that was striking for me, actually, why he's vomiting bile. So, can you move to, yeah. So, as I said that in the same day, he was vomiting bile. I said, let's just watch it. Now, that's his contrast study. As you can see in the contrast study, that the easy flow of the contrast from the esophagus down to the gastric pouch, down to the small bowel. But in the other control X-ray, you can see that there are multiple air fluid level in the left upper quadrant. On the second, third day, he started to pass gas and started to drink. He stopped vomiting, so he went home. Now, 1 week later, he came back with dehydration, abdominal pain, abdominal distension, and bile vomiting. Now we did a CT scan, and if you can appreciate on the CT scan on the left side, that's the elementary lymph, and on the right side, you can see the dye going into the biliary lymph, and then distally, you can see very tight passage of the dye in the common channel. Now, that's the situation here, that you have dilated biliary, dilated elementary, and collapsed distal bowel. What should we do? Should we continue conservative? We don't have endoscopic facility to dilate it. Should we take him to surgery, and what type of surgery we should do? That's what we found. We took him to surgery, and that's what we found. You can see that at top is the biliary dilated, and on the left is the elementary and the common channel. Let's go through the video. That's what you see here. And I made the drawing so you can understand what's going on. That's the top is the biliary. That's the biliary. And here is the anastomosis. That's the common channel which is collapsed between the biliary and the elementary. On the right is the biliary, and on the left is the elementary, and in between is the common channel. So, knowing that the dye is passing through the biliary and elementary, we discussed actually with colleagues, and we decided just to do biliary common channel JJ and new anastomosis.
1 minute, Abdurrahman, please.
And I'm almost done.
If you want to fasten, they can fasten it for you.
Just let's show the JJ. And just close the transverse as well, and that was the end of his problem. That's the post-op X-ray. Now 6 months from the revision surgery, his body weight went down to around 100 kg, and his BMI is around 40. Now just want to show one paper actually, that's here, the review with their gastric bypass. The incidence of small bowel obstruction post-through bypass range from 1 to 11%, and 4% are taken to the operating room. And in these 900 cases, the incidence was 4%, and the most common etiology is either internal hernia, and the second common is JJ obstruction. Here, that's what they recommend actually, that if you have the early obstruction, they can go conservative. They don't have to take them surgery, just stay tight on them and they will be resolved. If present late, they have to be taken to surgery. All internal hernias have to be taken to surgery. So the message from that paper, basically, if it's early, usually it's edema and usually it resolves by itself. And here, most the time it's shown up in in scenario, usually the presentation, usually within the first to second week of surgery. This is the different publication of these different papers actually discussing the same issues. And as I said, the internal hernia, JJ obstruction or adhesion are the most common. And that's here, Roux and O. I think Dr. Bimeri will present such case. And that here they hook up the biliary to the gastric pouch. The other one of obstruction is internal hemorrhage. Bleeding within the small bowel, and thank you.
Thank you so much, Dr. Abdurrahman, very nice. Okay, now, question please. Okay, Haris there, then Ali, then Abu Ali. Dr. Haris there. Can we have another mic, please? Mobile mic or in the room? Go ahead, Haris.
Thank you for an outstanding presentation. So this is a scenario, as I do about 80% Roux-en-Y bypass, that I would always worry about. If I had a patient who had done a Roux-en-Y with a 150 centimeter alimentary limb, who's vomiting bile on that admission, I wouldn't send them home.
You will?
I wouldn't send them home on that admission. I'd be pretty concerned. If they were spewing up bile after a Roux-en-Y, I'd want to hang on to them and study them while they're in. So I just was curious to know, I know it settled down after 2 or 3 days and you sent the patient home and he came back. What was the rationale for sending the patient home?
Because he was drinking, he was passing gas to the abdominal distension is gone, and he was tolerating or intake.
Okay.
And I was thinking of there's some residual bile in that elementary limb that came out post-op.
Okay.
Okay.
And then the second question is, the time I have seen bile reflux is if you have a post-op obstruction distal to the JJ, so port site hernia, common channel. Usually with a JJ anastomotic stricture, if it's a technical stricture, you don't usually see patients vomiting up bile because it's before the BP limb connects. Maybe an intersusception, possibly?
We run actually the whole small bowel. As I said, we closed the Peterson, just for the time I did not show the rest of the, but we closed the mesenteric defect and we closed the Peterson defect.
So what do you think is the cause of the vomiting bile?
Yani, if you see that common channel, you'll find like acute angle between the JJ and the common channel, and that's what basically the cause.
Okay. Abu Ali, Dr. Haidar, and then Badr.
I will say, I want to learn from this case how to avoid it next time.
That's the same question I was being asked before, actually, by Hiba. I would dig actually into the references, and what they recommend actually, maybe not to close in transverse fashion, close it in a longitudinal fashion. Do it instead of closing it transverse, close it longitudinal, and try to go backward, not anti-mesenteric borders. Try to go down and put stay sutures before and after. That's will align, put things in one alignment.
What would you do, Dr. Haidar, to prevent?
Two things.
Okay.
I will not divide the mesentery, number one, so that it will not come down and kink the common channel. Number one. Number two.
Divide biliary from elementary?
Yeah, when you do loop technique as you did, you raise the small bowel, did first gastroesophageal.
Later on.
Yeah, when you finish, you don't do division in the mesentery. Number two, of course, you do, usually the operator will be on the left side of the patient, right side of your hand, and that's what make it is in straightforward rather than to fall down and make the kink. But I think in this patient, it was the patient has bile reflux, number one, and that is technical issue. We should admit this. This is a technical. It's happened in early, not in delayed. Yes. So I think this is the case where I need to learn how to avoid it, because this is mine. This is what I can avoid it and don't do it next time.
So you said two things. One is what?
One, don't divide the mesentery, small bowel mesentery, so it will not fall down.
Second?
It will keep that. And then, second, to make it straight from the left side of the patient,
okay,
not on the transverse.
Any comment, Abdurrahman?
I would agree with him actually,
but you say that right, that you will align it and you have to position your stabling, the closure stabling, in a way that is not kinking or causing obstruction distally.
The traction basically we divide, and I was always doing that technique, and that's the first case I see it. But usually after we divide it, I hook up the whole loops up and then put them next to each other, and then, but I do it on the right side, not from the left side.
So again, don't forget the enterostomy. You need to take care also, because this is part of the structure.
How many, before I listen to Dr. Walid, how many of you have these issues before in his practice? I had also. Okay, so we have good number. Okay, Abu Muhammad.
Yeah, so it's a technical problem. When we put aside the internal hernia and we talk about the jejunal anastomosis, a question is coming up and people are advocating using a smaller stapler to prevent the interception that happens from a 6 centimeter jejunal anastomosis. So they're saying use 4.5 centimeter anastomosis. I think we see more of stenosis that happens from that because of, again, technical problem of applying the exact 4.5 centimeter in that, and I've seen it happening and referred to me so many cases of this sort. It's better to do an
mesentery?
An
go down
anti-interception stitch, just proximal to the jejunal anastomosis and make a wider anastomosis. And as Dr. Ashurfa have said, I would advise, from what I've seen, is to have an aligned anastomosis and not the one that have caused the kinking. So what you had is actually pure technical problem.
Okay,
thank you.
We will, Badr. علي صوتك ما نسمع.
It's working or not? If you make for example, the jejunal from distally, why don't make it proximally? May that prevent the structure? Because I have a case also that's in our early experience with one while that was 2017, because we did the jejunostomy, it was distally, and we have a structure because of the while we are closing the jejunostomy. Then after that we started only doing from the proximal part, like doing the jejunostomy only from the proximal part, rather than going distally. Do you think that's, and since that time, after that experience, one case, we didn't have the same issue?
Well, the other thing actually, they do it, they don't bring the bowel up, and they don't do the anastomosis, the gastrojejunostomy first. They finish the JJ down, and after they finish the JJ down, they go bring up the loop to the pouch, and then they do that after. But that's, when you do it down, it's much easier to bring the bowel in a proper alignment.
Okay. The last question, أبو كريم ما حد أعطاك الدور، ليش طالع كذا؟
أنا الرئيس.
طيب روح يلا نسوي ضيف علينا يلا. يلا يا عم.
Sometimes you have a perfectly done jejunostomy, and then when you close the mesenteric defect, that will cause a kinking, especially between the angle between the alimentary limb and the jejunostomy. So what I've been doing now, after seeing several of these cases in my practice, is that the alimentary limb, if I see it kinked, I would stitch it to the mesentery of the other alimentary limb that's coming proximal, so that I would eliminate this kinking. So
that's what's been said.
It's very important that we evaluate the situation after closing the anterior trough.
That's what's been said actually in the literature.
Thank you for the comment.
Try to stick the two loops together so you'll maintain the alignment.
Okay, last comment from Ahmed.
The point of Heather, I think, should be taken.
Thank you,
keep the loops up so you'll be able to manipulate it in a better status than bring it down.
Last comment, Dr. Ahmed Khalil.
About the division of the mesentery.
علي صوتك ما سمعنا. أعطي المايك هناك بسرعة يا شباب. المايك.
About the division of the mesentery, I think it's an important step. With my respect to Dr. Haida, when you divide the mesentery, the jejunostomy will relax, and you will take, as Dr. Walid said, the anti-tension suture. It has a name, I forgot it. Proximal and distal. But the division of the mesentery is of paramount importance, as the Swedish study, which has done more than 20,000 cases, and they call them the kings of bypass. They said it's a part of their procedure, division of the mesentery.
Thank you for the comment. Thank you, Dr. Abdurrahman, for great talk and great discussion.
Yeah, now I call to the podium Dr. Osama Taha, glad to call him up. What can you do when the pancreas is shattered during revisional surgery? مرحبا دكتور أسامة.
Good morning, Dr. Walid. Thank you, Dr. Ayed, Dr. Ghamdi, Dr. Birzai, everyone, and organizing committee and scientific committee for inviting us to such a great conference. The last couple of months in 2024, actually, it was very dramatic. I had this patient. She's 26 years old. She had a sleep before. BMI of 37.6, medically free. She was about to marry in a couple of months, and she was seeking to dress a nice dress in her party. So the decision is to go just for re-sleeve gastrectomy, and we do re-sleeve. We don't do routine re-sleeves. We do re-sleeves if the CT gastric volumetry is more than 650 cc. The first operation wasn't done by us. 2 weeks post-operatively, patient started to complain off and on attacks of abdominal pain, some fever, dehydration. She cannot tolerate food. CT pelvic abdominal with double contrast was done, shown non-significant finding with clinical improvement in response to some medications on hydration. And then a serious CT has been done, and we found some mild pelvic collection and basal atelectasis, and we thought that it's residuals. There is no leakage, there is no extravasation from the gastric, from the stomach. 10 days later, she began to deteriorate again with the same previous picture. Follow-up CT showed irregular gastric mural wall thickening and adjacent bowel loops with evidence of smudging of the surrounding fat glands and evidence of a gastric fistula that does not also leak any of the contrast. So we a follow-up CT, some collection, left pleural effusion, and then an endoscopy. The endoscopy was so decent enough, he couldn't go beyond the mid-stomach, and he found the fistula, and he cannot go through the fistula. The fistula was closed, and then we decided to go in, and this is the last endoscopy, the fistula, and he cannot even reach the pylorus, and we don't know why. So the decision was to perform laparoscopic exploration, and this is what we have found. Actually, it's sorry for the quality of the video, yet this procedure takes about 9 hours. It was very hectic. The stomach, the liver, the pancreas was one big mass. I tried my best actually to identify the anatomy. We managed to deliver the stomach from the liver, and I was trying to go through the lesser sac. And we do a dual approach. This is the endoscopy. This is the leakage area. Endoscopy coming from the stomach. So I have decided just to take this mass all off and do a gasophagogynostomy with Roux-en-Y configuration, because this was so hectic for us, and we found that there is no hope to reconstruct the stomach. I will leave you with this nightmare a little bit. Then we deliver the esophagus, we open the hiatus, we deliver the esophagus, we took everything out, as you see here. And then while I'm dividing this mass from down there, I found that during our dissection we have shattered the pancreas, the body and tail in one side and the head in the other side. And at that moment, actually, I was thinking that this will be my last case in my career, actually. So I took some rest, actually, and just to think. I get out of the OR, and I said that, okay, I will go for the Roux-en-Y configuration, leave the pancreas now, just to give myself a little bit to save time, and to save the anesthesia time, and to give myself a little bit some time to think what should I do. So I made some calls with my seniors, the hepatobiliary surgeons, and some of them said that just take a stapler on the body and tail and leave it. And some of them said just do a Duncan procedure and do a pancreatic gynostomy and put drains. So you see here, I don't know if you see it. It was so chaotic. This is the pancreas, this is the body and tail. I took this stapler and I said, I thought that this stapler has nothing to do. I dissect the splenic vein and artery from the pancreas just to make sure that there is no ischemia to the spleen, and I deflate the abdomen and I inflate the abdomen again, and the spleen was okay, the body and tail was okay. So I did the Roux-en-Y, give myself some time, And then I took the elementary limb actually and did the Duncan procedure. Now I finished the Roan Y, and then I took the body and tail as you see here.
1 minute.
Sure. And I did a hand sewn pancreatic jejunostomy. And then post-operatively CT, no leakage, pancreatic juice in the drains. We left 3 drains, shooting amylase and lipase. Patient underwent for sure some pancreatitis. And then patient admitted to the ICU, TPN, parenteral nutrition. After we relaxed it a little bit and the drains become dry, drain began to get turbidity, and post-operatively CT suspected grade 1 leakage and minimal air fluid with collection. So I have decided that I will never go in again. I have nothing to do. I finished what I can do in this case, and then I went very conservatively, and the decision to go for another endoscopy just to see if we can see any leakage, to put a double pigtail, to put a stent or anything. And this is the endoscopy, and the same endoscopist, very decent also. He didn't get beyond the pancreatic jejunostomy once again. So he said, okay, Osama, I will write what I have seen. The pancreatic jejunostomy is obstructed, and at the same time, the contrast with us, I found that the patient parameters becoming better and better, and I decided that she has to eat and drink. She ate, she drank, she went finally. 1 week later, the patient was discharged safely from the hospital in good condition. Actually, 2 weeks back, it was her engagement party, and we were invited, and the take-home message here that do your best with the patient, whatever happens. And actually, when the patient is good, you will be good. If the patient is bad, you will be bad. Thank you so much.
Thank you.
Thank you, Dr. Osama. It's a predicament what you were in. It's a position I would never like to see any surgeon to be in. But what made you make the choice to do? You did almost a telescope anastomosis between the tail of the pancreas and the small bowel.
Yeah.
Weren't you worried about the exocrine fistulas that can happen?
Actually, I didn't think in a proper way that time because it took 9 to 11 hours. I was very exhausted, and I followed the advice of the hepatobiliary surgeon that I invited to the OR.
Good work.
Okay. Can you have the mic here for Dr. Haidar, please?
Probably you get the advice
over phone. Telephone.
That is why you did the good what he advised. And I think if he was there, he will not give you this advice.
He was there, but not
inside.
Scrubbed, yeah.
So that's another issue.
What's the issues here? What do you want? What will be done different?
Because the distal pancreas, you can remove them.
Yes.
And I think that will be much better than to keep a patient on TBN and anastomosis leak
and we can leave it.
And we can leave it, of course. That's another issue. And when you do a pancreatic jejunostomy on laparoscopic point of view, it is really demanding skill for somebody doing bowel anastomosis most of this time. So what I believe, if he come and did the anastomosis, probably because he's doing it a lot, he will have better outcome from that point if he is still recommending anastomosis. And the other thing, usually if you have a pancreas like this, the duct is not dilated, the duct is normal. And And at that time also you need to put stent during the anastomosis. And at the other point, the pancreas is shattered, as you have said. So there are many factors not in favor of anastomosis. You understand?
Yeah, it was a nightmare, Dr. Haidar.
Yeah, I agree with you. Yeah. It was not in favor. That's why I think it's good to have him inside with you so that he is also challenged with this case from that point. And I think he will change his mind. I believe he will change his mind.
I tried that.
So different views and different things. Maybe Dr. Ahmed Al-Garzai, I don't know, you do hepatobiliary bilirubin. Can you have the, yes?
No, I'm not doing hepatobiliary.
Okay, go ahead,
But I'm
we
doing
hear you.
distal pancreatectomy. Thank you, Dr. Osama. I think there is many messages from this video. First of all, what I want to say that who put himself in revisional surgery, especially in post-leakage of sleeve gastrectomy, he should put in his mind the danger of pancreatic injury, because the pancreas sometimes it cannot differentiate it from the omentum or from the fat content. So if you don't meticulous in the dissection, the main problem in these cases actually the delayed discovery, not intraoperative discovery. Intraoperative discovery, as you mentioned, either can be done for me if I have intraoperative unfortunate, have high died mortality in 2014 because we didn't discover it till late. Then the question comes, if there is a discover late for pancreatic injury, what to do, even you involve the hepatobiliary, that the goal for the distal injury, even if you put it in the complication that the patient he need to sign, and if there is early discovery, I totally agree with either distal pancreatectomy or a repair.
Okay,
completely agree. Thank you.
Okay, we'll take from Abdullah Zahrani, and then also, go ahead.
Good morning all. Thank you very much, Dr. Osama. I think I congratulate you for this result. This is a very difficult case, and any one of us could be trapped in this. There are options for this. Leaving the pancreas and anastomosis, I think is unfair, but you could sclerotherapy the pancreatic duct and leave the distal pancreas to work from an endocrine point of view. The other thing, it could be excised as Dr. Sharaf described. The last thing which I would prefer is to anastomosis to the distal stomach. Pancreatic gastrostomy.
There is no distal stomach because the patient has done a sleeve before.
Yeah, but sleeve, the distal stomach is there.
Yeah, it's only the duodenum, because we took all the pancreas and the mid segment of the stomach.
Okay, so the stomach was removed. But yes. These are the two options. I think you did well with it, and missing the anatomy there when the time of chronic inflammation is well taken, and it's really difficult to manage. Thank you.
I completely agree. When you are relaxed and out of sight of the OR in not such a situation,
Dr.
there was
Osama
a lot of
Faida,
options.
please.
Yet put
Thank
yourself
you,
in my shoes. Actually, it was really very hard to think properly.
Dr. Osama Faida.
Yes.
So,
yes. Yeah, that you share us this disastrous cases, and I'm sure all as a surgeon we don't like to be in your position. Doing surgery by laparoscopy is our challenge. You mentioned that you did your surgery over 9 to 11 hours. It seems that you are run the show by yourself. Probably your assistant, how expert he is enough to share with you the challenge of this case. At one stage, what do you think that when I have to convert from laparoscopy to laparotomy to handle this case?
Actually, if you are talking about this case has no benefit for converting it to open surgery. Actually, what took 9 hours, not the operating time. What took 9 hours is the endoscopy, the dual approach, waiting for the endoscopist to come in and deflate the abdomen, inflate the abdomen, judge on the distal pancreas, judge on the spleen. So it took a lot of effort because all the teams was working together. Actually, the hepatobiliary was there in the OR, the general surgery, the bariatric surgery, and the endoscopist. So there are a lot of coordination, takes a lot of time.
طيب لا نعطي خلاص التايم مشى بس نعطي علشان الغترة هذه اللي لابسها. We'll give him.
Thank you, Osama.
خلص معي قصة حياتك يعني كلها دقيقة. يلا خلص. يلا.
Try to encourage me. It's not a disaster anymore.
It's great and we appreciate and I hope you will enjoy and you forget everything. But don't think, next time if anybody has this case, I prefer to do any other procedure, not risky. I will bypass.
Yes.
I think this is the safest. Even you are great and it is good in your hand, but still the risk is there.
Right.
I think we go for better.
Absolutely. And I commend you really, Osama, for presenting this case because any one of us can really be in this situation and you manage it the right way you think is right, appropriate at that time. Thank you so much.
Thank you.
Dr. Osama, I appreciate it. We'll move to the next presentation, Dr. Sami Ahmed, gastrobronchial fistula 4 years post-sleeve. What to do? Again, we want to open for discussion because it's what is more important, but also time is important. So please stick to time. Thank you.
Assalamu alaikum. Thank you very much for the organizing committee for inviting us to attend. شكرا للجميع. Gastrobronchial. Okay, next slide. Which one should I do? Oh, sorry. They're going back. Sorry, I have to go back. No. So please restart from the beginning.
Run the video, please.
Not the video. Okay. Thank you. Okay, leakage is a big problem actually in our bariatric surgery after sleeve gastrectomy or other bariatric procedures, and it results always in long hospitalization and readmissions, can lead even in some cases to mortality. Leakage rate in literature ranges between 0.6 and 3%, and it's higher in redo surgery. In leakage cases is very important, the early discovery and prompt reaction, which improves the results, and the complication. Predisposing factors for leakage, as we know, tight sleeve with increased intraluminal pressure, stricture at the incisura, infection, stapler failure, and the time of leakage is very important as well, how to handle it, early or late leakage. Treatment options are various: reintervention, drainage, gastrojejunostomy, stenting, clipping, pigtail drainage. About our case here, from 100 to 2,050 laparoscopic sleeve gastrectomies, we had a leakage complication in 5 cases, 3 cases within the first 3 weeks, and 1 case presented 10 weeks post-op, and 1 case we are going to talk about 4 years after surgery. 34 years old female, post-sleeve gastrectomy, 2012, presented in January 2017 with a chronic cough longer than 1 month and subfebrile at night, was treated by chest physician with antibiotic, and her weight loss was 67 kilogram from 165 kilogram to 98. Clinically, before her respiratory symptoms, she was free of symptoms, and this was the chest x-ray she has brought from the chest physician with her, and she was treated as chest infection. And actually here the message, any bariatric patients has to consult his bariatric surgeon for any problem, even the chest. I thought she has maybe reflux, which has caused this problem. And we did barium swallow actually here. And we were surprised to see the line between the stomach and the chest, which is the fistula. And here you see it better. It goes to the bronchi even. And the CT scan, you see on the left side of the lung, there is an abscess cavity. Ultrasound was normal, and she had leukocytes of 16,000, CRP was 97, hemoglobin 10.3. And we started the treatment actually with percutaneous drainage of the abscess, IV antibiotics, and then the surgical approach. Here we see the pigtail inside, and you see even the fistula.
2 minutes.
Okay. The conclusion, gastric fistula should be considered at any time post-sleeve gastrectomy, even after many years, if the patient develops abdominal or respiratory symptoms. Laparoscopic approach for treatment is a good option.
Okay.
Sorry. Oh, the video, we need the video actually.
Can you run the video from your desktop, please?
Please,
just
can
click on the video. Go back to the slide. No, go back to the slide before the last.
Okay.
Here, just run it. Put the mouse on it and run it. Yes.
Okay, the message actually by such chronic fistula, what to do. We thought stenting would be not sufficient because the fistula tract would be fibrotic, and the tissue would the patient benefit from that. Then we thought the best approach is to go laparoscopically and to deal with it. We see that there is some fibrotic reaction around the area. The omentum is stuck as protective mechanism at the site of the fistula. We dissected all these fixed attachments of the omentum. It was really very hard fibrotic tissue. Maybe a little bit faster, if it's possible.
Faster video, please. Just exit, make it one screen only, not two screen.
Anyway, we will open the fistula in this side. Very hard tissue, posteriorly. No.
They don't know this.
So, what happened? No, this is. Just the end. Just the end. Okay, anyway, you will see before that a little bit maybe. Okay, what we did actually, it has opened. The fistula has opened completely. This is non-absorbable stitch. I was inverting with non-absorbable stitch in the primary surgery. Then Thank God there was still gastric tissue we could resect with a stapler and then over suturing. This is the procedure actually. Sorry for the delay.
Thank you so much, Dr.
Thank you.
Thank you. We'll have one or two questions, please. Okay, Dr. Hassan, we are running out of time.
Okay, Dr. Sami. I wonder, the fistula happened between the pouch, the sleeve pouch, and the bronchus. Does this mean that the pouch was slipped up in the chest to reach the bronchus?
The fundus pouch?
I mean the sleeve.
Yes.
Did it pop up in the chest?
It was stuck to the diaphragm. It was completely on the left side stuck to the diaphragm, and the fistula was from there. It must be actually, we don't know actually how long was this fistula, when was it, when did it start. It became symptomatic actually after 4 years for this patient.
It is evident that it is chronic leakage.
Chronic
leakage, so it took a long time until the leakage reached the bronchus and did the fistula. So you found the sleeve in the abdomen as it is. So it is just the leaking fluid reached the trachea and caused the fistula.
Yes, for sure. Okay. It's a track between the gastric sleeve at the fundus area and the first part of the stapler line actually, and through the diaphragm to the bronchi. When we gave them, after that we repeated the test even with gastrographine, and you see how it goes to the lung and to the bronchi. Okay, and the patient starts coughing even.
Okay.
The second thing you showed it, how did you deal with from the gastric side? What did you do from
nothing? We did nothing. Yes, okay. We did nothing. We did not see any prominent opening or orifice to be closed.
We'll give to Dr. Walid because he has maybe more than 30 cases experience.
You know, I've done a few cases of those fistulas, gastropleural, gastrofistulas is like the one you had. You are lucky if you have enough tissues to resect and cut that fistula. And it has two components. That we should not just remove the fistula and forget about the chest component. So that has to be addressed. Secondly, with fistulas, you can, even long-standing fistulas can be wet. Depending on the amount of gastric tissue available, you can do what's called a loop bridging jejunal-gastric anastomosis, and eventually that will close after 6 months to 1 year. We have seen 3 cases of that sort, or Roux-en-Y even, anastomosis, or actually partial gastrectomy and esophagogynostomy. And those were most of the cases in wet fistulas and abscesses. So that's just a comment I wanted to add.
I was lucky because after 4 years we have some dilatation of the sleeve, and it was possible actually to staple it and to remove it. I came inside for sure for all option open what to do.
Thank you, Dr. Sami. Very nice case. I'll go for the next presentation. Raj.
Now I'd like to call upon Dr. Raj Planimpan.
Hold the mic.
Please to give us a talk on single anastomosis, imbrication, jejunal bypass, a novel staple, less bariatric procedure, please.
Good morning all. I bring greetings from India. So interesting videos about complications. Maybe I'm trying to move away from it to promote a new novel technique of bariatric surgery. So we all know that sleepless has become very popular of late to avoid nutritional deficiencies as well as to avoid post-operative complications as much what other procedures of metabolic surgeries has. Can I have the video?
Technique percutaneously from the left and right of falciform to a liver. Like in any other bariatrics, we take what we call as a high sling liver traction, our indigenous.
Sound is okay?
Percutaneously from the left and right of falciform
It's a video? We don't have. Can you run the video, please? Not from both.
No. Nope.
Where is the video?
Looking.
Huh? Is the video? هذا الفيديو? Why it's not running? Where is the original video?
So basically here what we do is we
okay. Let us go to the next video, Raj, please. And while they are preparing your video.
Sure then.
Okay, so we'll go to the next presentation, please. Haidar Sharafa, please, while we are preparing the next video. Thank you. Haidar will present about revision of RONY for recurrent weight gain. Now the terminology is recurrent weight gain, not regain. Yeah, I'm re-emphasizing, trying to learn. I hope you will not find the slide regain on my slide. يلا يا أبو علي ولا نشيلك من البرنامج. Next presentation, please. You have it ready, or we'll go to the next? I want to finish it here.
1 minute.
Okay, any other questions that we have while we are discussing about bronchopleural fistula, gastropleural fistula, or bronchial fistula? Okay, Dr. Numeri, give the mic here for Dr. Numeri while we are preparing the video.
Thank you. I think the presentation of Dr. Salim was really excellent. And
the
few comments I want to make is that this is not a procedure you want to do if you've not done it before. So like few things about it is, if you have someone with a sleeve leak for 3 months and it has not healed, and you don't have experience with taking care of it, it's better to refer such a patient than to actually try to tackle it on your own. And I think the second thing is, intraoperatively, the goal is to identify the splenic vessels in the lesser sac before you can actually get to the fistula, because if you don't do that, you can end up with a major catastrophic complication in that area. But truly, this is not a procedure you want to do if you have not done it before.
Absolutely. Yes, Dr. Haidar.
And I have 2 cases only, so I will refer the third one to you. So I don't have a lot of experience, but what I understand, these are chronic.
Yes.
These are chronic type of leaks. And the second thing, they are a complex type of fistula. They are not just a straight fistula. So what I believe in this case, it is an gastropleural fistula, and with complex. What we see in the image or in the contrast study is just that part, what you see it in the contrast. But it is a more complex fistula. And the second, you need to do both sides. You cure it from down, and then we'll open again down from up. And that is very important in order to cure the patient from both sides.
Excellent. Okay, well, next video, Dr. Raj.
Yeah, hi. So we do a 3-port technique of all our laparoscopic surgery. So here we do what we call a hiatal sling liver traction, our own indigenous traction of percutaneously hanging the liver up, and then go like a typical sleeve gastrectomy. But then the difference is here, because we are going to do imbrication and not a sleeve, so we got to be a bit careful about not hugging the stomach. So a little bit lateral to the stomach we go. And another big important thing is, in a sleeve, even if you don't do phrenoesophageal, gastrosplenic and gastrophrenic, it will be still a bit okay, but then here in imbrication it's better to make sure all the 3 ligaments are sacrificed and the left crus is very well seen. And then you go to retrograde dissection, go up to 4 centimeter, so that will give us a good 6 centimeter from the pylorus for our imbrication. So once that is done, we pass in a 40 French bougie here, because we are doing an imbrication and not a sleeve. We pass in a 40 French bougie, if possible into the pylorus, through to the duodenum, otherwise just put it in, and then we take a posterior and anterior about some 2 to 3 centimeter from the midline, I mean that epiboloic line. So we sometimes use V-lock, sometimes use barb and regular proline sutures as well. So here we use barb sutures. So the trick here is to make sure that we get the imbrication side below the bougie. Otherwise, if it goes above and below the bougie, sometimes we can have a disparity in the way the imbrication is made, and it can have a kink or a twist. So we do a first layer. First layer looks a bit cumbersome and look bit not very aesthetically good looking, because this is just to make sure that first layer is done to reduce the stomach into maybe around 150 cc stomach. Second layer will make it into a 80 cc pouch. Once that is done, then the second layer we do, but the second layer we make sure it is only interrupted, because there are reports of the slippage of the sutures and the stomach opening up. So we do a second layer interrupted sutures, and this time we use endo stitch to make life much more easier. So the second layer, make sure that the fundus is well imbricated, because we don't want any redundant fundus to be around as well. So around 7 to 8 interrupts. We normally take for all our bypasses 200 centimeter, or loop bypasses. So measure a 200 centimeter proximal jejunum from the DJ flexure. We always do a stay suture as an anti-reflex to avoid nocturnal reflex and de novo GRD. Not exactly, it reduces the post-operative reflex, but then nocturnal and de novo GRD comes down with anti-reflex sutures. Then we do a hand-sewn anastomosis, posterior layer. The trick here is to make sure that antrum is disrupted. The antral mill has to be disrupted so that the duodeno-antral reflex is down. We don't have too much of a reflex of bile coming from the duodenum, and food also don't go much, because a lot of stasis will be there, and food comes down through the gastrojejuno anastomosis. So make about some 3.5 centimeter gastrotomy and a jejunotomy.
1 minute.
Yes, and with that we close the gastroenterotomy, and then all these patients, and we have a 45% excess weight loss in 6 months. The beauty about this procedure is we didn't have any nutritional deficiency in any of these patients, no dumping as well in any of the patients, and we did a very interesting scintigraphy study on these patients. None of the patients have food going through the duodenum beyond 1 month. Around 25% of liquid and semi-solid goes in the first week, around 10% by third week, and by fourth week, no food goes. So maybe you can fast forward this. I'll go to endoscopy view.
Fast forward.
Fast forward a bit.
Close to the end.
Last 1 minute.
Make it in one single screen.
Go to last 1 minute, please. Yeah. So then we have a check endoscopy in all our patients. So that's to make sure that we are don't have any kink or anything. This is the imbricated stomach. So endoscope we get across that. That's into the anastomosis. That's into the efferent loop. Come out and we can get into the afferent loop as well. So that's into the afferent loop. So we are, for all our imbrications, because it's only early cases, we do a good endoscopy for all our patients. Outcome is as good as any other bariatric surgery with zero nutrition deficiencies. Of course, all our patients have supplementation very strongly done for all these patients, and then these patients are pretty happy and then go home in 40 hours after surgery, and within 3 weeks they are back to normal life. Thank you.
Thank you, Dr. Raj. Dr. Nimeri, please.
This is basically a SASI without a sleeve.
Exactly.
Right. So
SASJ, jejunostomy without a sleeve, not a ileostomy.
Sure.
Yeah.
So I think that my concern is with saying that there are no nutritional deficiencies, because even in sleeve there are nutritional deficiencies. In proximal bypass there's nutritional deficiencies, and like my comment is, I would be very concerned when you say there are no nutritional deficiencies, because this is very unlikely. So my comment, my question to you is, there's been studies comparing bipartition where the intestine is attached to the distal stomach versus bipartition when the stomach is attached to the duodenum.
Sure.
And in scintigraphy and upper GI studies, 80% of the content goes to the duodenum if you attach it past the pylorus, and 80% goes to the intestine if you did like attach it in the stomach. So, I mean, how do you explain that there will be no nutritional deficiencies if 80% of the food is going to the intestine, okay, and this could be just like a bypass?
So I agree with that. So there are two hypotheses. One, if these patients are given bariatric and metabolic specific multivitamins post-operatively, follow-up, are strictly following the nutritional protocol. One. Second is, so when we did SASJ as well, the same study of what could be the pathology, there is some kind of a bile reflux back into the stomach. So maybe the intrinsic factors and the iron deficiencies and B12 deficiencies are a little bit less because of that reflex of regular bile as well a bit. Otherwise, always in a bile goes around. This could be the explanation, but long-term studies are very important to understand whether we are talking sense about this or not. Yes.
Okay, thank you, Dr. Raj. Dr. Osama?
Thank you. Dr. Raj, thank you for the technique. Actually, I have two questions. First, what is the added value of this procedure, apart from it's cheaper than the bypass? You don't use staples.
Yeah.
And the second question is, what's your explanation that there is no dumping in such case with 80% of the food, as you said, going to the distal intestine?
So the added value is complications is going to be much lesser because there is no stapling, because the sleeve part is the one which is going to give the maximum amount of complication. We are doing imbrication, and that is the reason why we don't have a stapling around, and intra-abdominal pressure, intragastric pressure is not going to be a big problem for our to have more complications maybe. Second, with regards to dumping, as of now we are not seeing in this 5 patients dumping. Very closely followed up, and we are biased about trying to give the patient very, very good nutritional and diet counseling. Maybe we are escaping it. When it brings down to the same level of managing other patients, maybe we'll start seeing much of a dumping. This could be the only explanation. Yes.
Thank you. Dr. Sami, please.
Again, actually, adding to my colleague what he said, using or not using the staplers, I mean, we should use the benefit of the technology staplers, because they have the benefit that we do and operate faster. And is it why you avoid using the staplers? Apart from the economic part of view, now it's cheaper. Is it safer to use the hand suturing?
So when imbrication started, when we went and did the study on imbrication, comparing imbrication and sleeve gastrectomy, so
even the anastomosis, even the anastomosis, what you did, not only the imbrication.
Yeah, so we did the initial couple of days of constitutional symptoms, nausea and all, are more in a stapleless than a stapled one. Stapled one will have pretty much very comfortable result like what you have in a post-sleeve or a post-OAGB patient. But then coming back to this, imbrication has less complications with regards to the leak than a sleeve, but then very poor results and a lot of constitutional symptoms that made it a failure, and then weight gain regain happened. And that is where we thought, why can't we add a bypass to it, so that we get those benefits of imbrication and the benefits of a bypass coming in, and with a larger pouch of 80 to 100 cc of stomach, with an avoiding of the OG junction leak, which is the commonest complication after a sleeve. So why can't we try that as an option? Along with it comes economy of it. Like, economy is not the whole idea behind it. So making it a stapler is going to be much more productive and reproducible across the globe if the results are equally as good as any other sleeveless procedure or comparable to OAGP.
Okay, thank you.
Thank you. So we'll move for the next. Thank you, Dr. Raj. Appreciate your work. Dr. Sharafa, revision of Rho and Y, recurrent weight gain. Do you have the video, please?
This is my cases mix, and I for almost 30% revisional, and out of this revisional, 4.3 was revisional Rho and Y. And Rho and Y is the most common bypass, most common revisional, and that it's challenging, and most common BMI of 47 with the type 2 diabetes converted to insulin and trial of GLP-1. This is the CT scan as you see, and the pouch is enlarged, and the enlargement, you see how does it look, and this is the way we do it in the OR where we start the operation, and we start with adhesolysis, and the adhesolysis, as you see, just I want you to check, look, this is a true dilatation and enlargement of the pouch. That is not a missed pouch. In this side, you look, there is, the pouch is elongated even beyond the stomach. That is a very important adhesolysis. Is directed adhesolysis. In a way, we do only adhesolysis for the part we will operate on it or we resect. And as the time is consuming, that's why I make it so a little bit faster. And then we try to dissect the pouch from the other side, which is the fundus side. And here is clear, there are two types of dilatation. There is missed part of fundus, and again there is a dilated part of the fundus where you see the adhesion more in that part. And then we start, in this case we did again the resection of the or resizing of the pouch, which is part of the any revision we do it for the Rho and Y gastric bypass. And again we do fundectomy. So both of them, fundectomy, resizing of the pouch, and of course we do the resizing from both sides, from lower part of the or the longitudinal axis and from transverse axis, in order to make the pouch smaller, tubular. And once we finish the stitch, and after that we go and remove the adhesion in the alimentary limb in order to re-anastomose or to do the gastrojejunal anastomosis, which is also another factor adding to reduce the restriction or to increase the restriction in order to have more weight loss. After that we did count the raw limbs, and then we checked it was 150 centimeter, and then we start to do the anastomosis using a stapler, which is linear, and we do usually between 2.5 to 2 centimeter using 30 millimeter stapler. And it is the usual, we do use the linear stapler, as the study doesn't show there a lot of difference between the linear and hand sewing. And again we do the stapling with the between the pouch and the raw limb, the raw limb after we free it, and then after that we check, we do the closure of the stoma using, and this time we use this barbed suture in 2 layers. And then we start to do the next step, which is now the distalization type 1, which is again,
1 minute.
we go and count our raw limb. After we finish, then I remove the candy can of the small bowel, and then I go and shift myself to the left side of the patient and start to count the common channel. And here, by gastric bypass, in order to have the maximizing the distalization, maximizing the hypoabsorptive procedure, and of course to avoid the micronutrient deficiency, which could be a result if we do overcome this counting. And as you see, sorry to make it fast, because they told me it is only 7 minutes. So
No,
it is 7 minutes. So I count the.
Go to the last, yeah.
Huh?
Go ahead. We'll go. Maybe you can fasten to show the
هذا بعد كل
samosas.
هالفاست نعمل فاست والله كثير بعد. So now what I do, I just make after I finish all the counting, and then I start from the jejunal anastomosis and count how much distalization I need to make, and then I make the anastomosis, the another GJ anastomosis, and then I close the stoma in 2 layers, and then I close the chair, and then we divide it is also a loop technique or loop way how we do the raw NY or revision of the raw NY. And of course we do methylene blue, we confer hemostasis and remove all the specimen, and that will conclude our operation. And this patient has a very uneventful post-operative course and with minimal blood loss, and he was discharged in second post-op, and he has a good weight loss and improvement in the type 2. So revisional raw NY gastric bypass is safe, feasible, challenging, effective, but multidisciplinary. The lesson, we should do all the things in order to achieve a better weight loss.
Thank you so much. Thank you, Dr. Haidar. 1 or 2 questions, please. Yes. Go ahead. Mics, please, there. Okay.
Assalamu alaikum.
Alaikum salam.
Thank you, Dr. Shrafa, for this outstanding video. As usual,
لا شكرا والله.
In this distalization, what's the length of your common channel at the end?
We make it 300, the common channel. The raw limb was 150. So the total was almost 400, 450.
And the billion.
Well, this patient, we follow him, I think, 18 months till now. See, the follow-up is our problem. Okay. But that is why this video, I make it only because these are definite number. 2 weeks, 3 months. That's why I...
Mike. Make it short, Abu Nasser.
Short. Already, in our cases, distalization only of distal bypass. Actually, in our hands, in our patients, since we did it in 2008, we have unfortunate, very low weight reduction of the peripancreatic limb, 1 to 150 centimeter, to assure that the common limb like 4 meters. So in our observational resizing banded bypass with elongation of peripancreatic limb with extra 1 to 1.5 meter, we have excellent result in weight reduction, minimal micronutrient deficiency and hypoproteinemia, better than distal bypass.
So
he's saying to add banding to distalization. Yeah. Would you do that?
I think what I did, and whether BBG or gastric band. So we were in the era where we suffer from bands. So that is why I do revise everything. So you cannot, we cannot say revision only by distalization will add better or less. If you do revise all, i.e. the pouch, secondly you do fundectomy, thirdly you do gastrojejunal anastomosis revision, that means you make it small, you distalize the things and you maximize the distalization, i.e. the total elementary limb will be only 4 meters or more or less at around that. Then you are safe from point of micronutrient, and then you maximize the distalization.
Okay.
Actually, in that guy, we should not go more distalization.
Thank you, Dr. Haider.
Now, God forbids, what happens when everything goes wrong? Do you give up? I hope not.
And go home.
Yes. Good morning. Assalamu alaikum. This is an interesting case. A 63-year-old female patient. She was obese, diabetic, hypertensive, and chronic kidney disease. She did laparoscopic sleeve gastrectomy 2 months prior to be admitted in our hospital. Complicated bile leak. Both endoscopic stent was done at that hospital by intervention radiologist. They did a stent for her 6 weeks prior to, and they did also an intervention drainage by they applied big tail. Then her BMI was 58. Next. We brought in then PPI infusion, antibiotic, nephrology consult, and TPN. She was stable. Her labs with a normal limit, other than renal profile was deranged. This is the gastrography. We cannot see complete stomach, so we did a scope for her. CT scan, there is big tail in it. She was stable. Then this is the scope. We can see completely open stomach. After we removed the stent was not in good position, so we can see the big tail during endoscopic picture. So completely open staplers after sleeve gastrectomy. By the way, I present this in FCMINA, but this is interesting, that's why I present it here. She after 30 days from admission, TPN, IV antibiotic, ID consult, so we decide to take her to OR to manage the patient. That is a surprise. When we enter inside, can we start the video? Let me go back, please. Can we start
the video? Play on the screen.
Okay, this is what we see. It's completely a lot of adhesions inside. We try to visualize the stomach. Here we can find completely open stomach. This is the posterior wall of the stomach. A lot of pus, a lot of adhesions, momentum. So we find now the stomach completely bile leak. A lot of adhesions, but with liver. This is the big tail. This is the big tail. We could find the area. So we can find open stomach now. So we just follow it until we. Now we try to do distal gastrectomy. We injure the duodenum here in that part. So we have to extend to completely remove the D1. And it took us a lot of time to release this. So we did, in part, we removed the stomach. Here we did, distal gastrectomy. Then we went up. We dissected the vessels. We have a lot of problem in the D1, so I have to do stay suture and transect the duodenum until very near to the D2. Then now we went up in the gastrointestinal area, a lot of adhesions. Here is the fistula. We just went above it and we transected. We tried to do the anastomosis here, the distal part, completely total gastrectomy. Now we are working the esophagus almost. We are dissecting the crura part, if it's clear for you. Here is the esophagus. So we completely transected the stomach here in part. Then we tried to do the anastomosis. Unfortunately, we tried a lot. It was not the right decision to go anticolic, so we decided to go. Now here we tear the anastomosis because there was a lot of tension. She was super obese. Then we decided to slit the mesentery. We slit the mesentery to make it a little bit shorter, the mesentery, but unfortunately another disaster. So we decide to go retrocolic.
and we have not a lot of experience with retrocolic anastomosis. So here we are doing opening in the mesocolon just to shorten and reduce the tension and the anastomosis. So after a lot of hours, we spent 12 hours in this operation. So we pass gauze so we can see the bowel. We went to write retrocolic here. When we went to retrocolic, it was easy to do the anastomosis, but unfortunately there's another disaster. After we did the elementary limb here through the colon, it was easily coming without tension. So we did another circular anastomosis with the esophagus. It went smoothly. We did the anastomosis, but still not healthy esophagus. We expected bad things. But now we are going to do the leak test. Unfortunately, here's the anesthesia. He was a new anesthetist. His first day, he perforated the anastomosis after disaster anastomosis. So I spent a lot of time just to find the mesentery, and I did interrupted suture and I closed. I am sure this patient will leak. Now we went to the second anastomosis. In the end, we did the jejunostomy, but I decided to do also feeding jejunostomy. It was very big tear in the enterotomy. I have to do it manually. In the end, it is done. After that, we did I put some hemostasis material in that here. Then I decided to do feeding jejunostomy. Also one of the difficult feeding jejunostomy because it leaks also post-op.
Okay.
We did feeding jejunostomy. And we did put a lot of drains, 2 drains. Then we completed our procedure. Can we go to the next slide? Patient, this is the gastrography, we found the leak, so we decided to put in the 7-day post-op a biodegradable stent because there was leak from 2 areas. Gastrography site of the leak at the anastomosis, we can see large, that's why we have a large leak, so we put a biodegradable stent. We did the gastrography post-stent, there was no leak. We did the scope before discharge, and this is the appearance, completely healed. And 12 hours, you should not do such case alone. You should call your colleagues. The thing, because you will have different opinion, they will help you in the OR, so you didn't spend 12 hours alone. And leak is expected in these cases. Second thing, anesthesia should not be anesthesia who is not, because there's 2 anesthesists. One was expired, the second one he was taking the second shift. That's why he was not expired. His first time to do a bariatric surgery, he perforated the anastomosis. Thank you.
Thank you, Hamad. Yes. You want to ask? Thank you. No, just wait.
Why, I want your honest, straightforward opinion. Why do you think you went through those unfortunate happenings one after another? Were you doing the surgery yourself, or were you training someone?
Actually, patient has a huge leak. I cannot leave the patient without surgery.
لا ليش؟
Well, I didn't get your question.
Huh?
What's your question, Dr. Walid?
ايش السؤال؟
السؤال
ليش حصلت
this unfortunate
events
happening one after another?
in the intra-op يعني.
This is my luck, bad luck. It's not simple case. It's a super obese patient.
Why do you think this unfortunate mishappenings took place one after another?
I don't know.
Not your day.
I don't know.
You were tired.
I'm not tired. I was okay.
Okay.
But the problem.
Abdurrahman, what would you? Why do you think this is happening?
Dr. Abu Khater, excellent presentation, difficult case, and excellent outcome. I don't know why it happened, but I just have a couple of comments. So I do anticolic gastric bypass in all cases, and retrocolic esophageal J in all cases.
Yes, I agree.
So whenever I do an esophageal J, it is always retrocolic. And the trick to finding the retrocolic space is identifying the ligament of Treitz and going 2 centimeters above it in the avascular plane. It's relatively.
It's a very important message. From now onward, any total gastrectomy, and you are going to do esophageostomy, you should not do it without retrocolic. Because when we did it retrocolic, it was very easy. So the wrong thing I did here, I tried twice with different way. I tried to slit the mesentery. I destroyed the esophagus more. So I put the patient in risk of leak.
Sure. And I think the second comment, which was not possible here because you had the duodenal issue, is I prefer to place tube into the antrum, it's easier to manage than a J tube. But if I place a J tube, you need to make sure you whistle it.
Yes.
Make a whistle tunnel so it
This
doesn't
is another
leak.
point also. I should not go anymore, leave the stomach, leave the antrum.
Right. So I always leave the antrum behind so I can put a feeding tube. But really excellent outcome.
Feeding genostomy saved me. Feeding genostomy is very important in this case. You have to do it, whatever there is.
Open from below.
So a very challenging case. I'm glad that the patient did well. So my question is that I use the circular staple technique as well as a linear staple technique. Sometimes if it doesn't reach, the root limb doesn't reach to the pouch or the esophagus, I mobilize the esophagus in the chest and bring it down. I can bring it down.
I agree. In this case, I could not do it. It was matted, liver, central obesity. It was not simple case. Even we give a lot of muscle relaxant, still we did not have a space in this. Maybe this case is a good for robotic, but actually that robotic that day was not free.
Okay.
It's a very narrow area. I always do a proper dissection. In this case, I could not do it alone.
Thank you so much, Dr. Muhammad. Thank you. Appreciate it. We'll go to the last video in the session. Massive upper GI bleeding, post one anastomosis bypass. Dr. Nuruddin Shair.
Assalamu alaikum. Good morning, everybody. Thank you very much for this nice opportunity. So we are representing at the SMC, Specialized Medical Hospital Center, who had no best medical history. His best surgical history was significant of laparoscopic gastric application that was done in 2012. 4 years from that date, the patient underwent into a laparoscopic gastric mini bypass. The patient in 2023, he presented to another facility in Riyadh, where he presented with hematemesis and melena. At that time, the patient was admitted there. He was investigated. He had an upper and lower scope. The upper scope was, excuse me. The upper scope was showing a pooling of a fresh blood in the gastric pouch, as well as some fresh blood in the ascending colon, which made things confusing. So they took the patient for abdominal CT scan and showing a hyperdense hematoma in the gastric pouch. After that, they ran for the patient an RBC scan. The RBC scan was, as we know, it was localizing it to the left upper quadrant without identifiable other potential sources. So angiography was done, and eventually they thought the bleeder was coming from the left gastric artery, for which embolization was carried out. The patient stayed for a long time there. 2 units of backed RBCs were given to the patient, and he was discharged home. Like less than a month from that date, the patient presented back to our facility this time with similar complaint of hematemesis, again melena, for the same duration, almost nearly 2 to 3 weeks from that time. We admitted the patient into the ICU, resuscitated him, and we planned for him the EGD. The EGD was done for the patient, and we'll see it in the next slide. CT scan, and finally OR, and I'll comment on each one of them. So this is the EGD finding. We have a fresh blood in the gastric pouch as well as in the proximal part of the loop that was done in the mini bypass. No identifiable active source of bleeding was noted at that time. And the CT scan that was carried for the patient, as you can see, there is a spherical shape on the right hand side. There is a sphere of filling with contrast as well as a stable line artifacts communicating with an artery. Now when we did this is on the right side. On the left side we have the hematoma. As you can see, it is showing us with a hyperdense material. Possible extravasation was noted in the CT scan. This is by 3D reconstruction. We concluded that it is a pseudoaneurysm of a left inferior phrenic artery communicating with the gastric, probably remnant. And here we can see the hyperdense material that we saw there. Now, because of the patient's ongoing requirement of PAC, we decided to take the patient for surgery.
Randa.
Yeah, okay. So you can see here we have a lot of adhesions adherent to the diaphragm. In order to determine the anatomy, we placed a bougie, and the bougie made us clear which one is the gastric remnant and which one is the gastric pouch. After that, we went into the area of the gastrojejunal anastomosis to clarify the limbs, and we identified the alimentary as well as the biliary limbs. Then we ran the whole bowel just to exclude any other potential source of a bleeding. We went back to the area. As you can see, we have a stable line here, very stuck to the diaphragm, and a lot of adhesions were noted at that time as well. This linear structure is presumably at that time was the phrenic artery, and it was, as a matter of fact, concluded or evident by the bleeding that we see right now. We are applying here Ligasure just to establish some hemostasis, and as we are trying to mobilize the area and try to achieve proper dissection in this region, inadvertent gastrotomy was made, and the blood that was pooling inside was gushing from the aneurysm. As you can see, this is the bleeding from the aneurysm. Ligasure was applied again, and as we are applying with the Ligasure, trying to establish hemostasis, and applying also some pressure redressing, goes in the area with suction and irrigation to clarify the potential source of bleeding. Eventually, the Ligasure was, alhamdulillah, capable of just handling the area, and once we clamped it, we never let go, so we don't have another attack of bleeding at that place. So housekeeping of the hematoma that developed there with the pooling of blood, and then we utilized the number 1 silk suture in figure of 8 manner, transfixating the pseudoaneurysm, the left inferior phrenic artery. Here you can see we are pulling the threads, letting go of the Ligasure, the hemostasis is secured, and now we are stabilizing the knot with a micro grasper. And here we can see in the last clip how the field looks like after we have applied the transfixation. Here we have also the gastrotomy site, which was handled and closed, but not shown here in the video. So just to give you an idea, one of the literature reviewer is a Funakoshi, he did a great analysis and study of around probably 20 cases of inferior phrenic artery relating from abdominal source, most of which are relevant to abdominal surgery, pancreatitis, trauma. Interestingly, all of which were managed by embolization case. But to be honest, the take-home message of this presentation is that you have like a stable, we deal with the stables all the time, and the stables themselves, they are not benign, foreign bodies. They are related most of the time to other complications such as erosion, fistulization, leakage, etc. are all possible. So in this study we see here it's a meta-analysis incorporating around 4,000 patients over 17 randomized controlled trials. They concluded that suture reinforcement or reinforcing the area of the stable line is associated with decreased risk of bleeding, leak, or overall complications. These are my references.
Thank you.
Thank you very much.
Thank you so much. Okay, Dr. Shakir, please. One more question if we have, and then we will conclude with Dr. Walid.
What about considering dealing with the aneurysm with the coil or embolization instead of going back to surgery?
That's right, because in our circumstances, the patient had already underwent embolization, but it was to the right gastric artery in his previous admission, not in our hospital, somewhere else. The second thing, in our facility, it was out of service due to maintenance. So we don't have the machine working. Otherwise, we could have utilized it. Surprisingly, I found in the literature, many people who have encountered such a complaint or such a presentation of a patient, they are putting the embolization inferior to surgical approach due to the patient's probably other associated factors of vascular arteriopathy or something like this.
Thank you. Thank you, Dr. Nuruddin. Appreciate it.
We're moving to the next session, inshallah. Thank you.
Now we'll move for the next session. If we can call Dr. Sultan Al-Timyat, Dr. Abdullah Zahrani, and Dr. Walid Abu Bakr chairing next session.
Just a short announcement, please, for everybody, for especially the people who are leaving. There is a barcode at the entrances for you can scan and you can register. Okay, it's 30 minutes now. So, but you just need to know you need to add beside your name whether you want Da Vinci or Hugo. It's important.
When you show up at the robots by booking, but the learning center is open for people who want to learn suturing, etc., dissection. We have about 14 stations for learning, especially for residents. I encourage everybody to try.
Okay, we start the second session. It's my great honor to call for Nasreen Al-Faris to present the first talk. Nasreen, our partner and our international ambassador. Strict.
ولا يهمك.
Okay, you have only 10 minutes.
I'm already ready for your strictness today. I will not ask for extra time.
Okay.
Do you want us to start? Because apparently everybody doesn't, either they're not interested or they don't want us to start.
Just a second, please. Please, come forward, please. We're going to start the session. The break will be after the session.
Fascinating. And people are not interested in this session.
عن سنين عرفت فيها. اللي بعده أعطيك إياه. Okay. This is very important session.
أتعبتوهم بالفيديوز. يروحون يناقشون الحالات، ما أعطيتوهم فرصة يناقشون في الفيديوز. يروحون برا يتناقشون فوق على القهوة بالحالات، ما لومهم.
Okay, please, Nasreen, start.
You want us to start? Okay. So I'm going to talk about clinical obesity, a new definition to guide in your practice. And this is basically, I really don't have any disclosures for this talk. This is based on the Lancet Commission that we just recently published, where we redefined obesity. This commission really got a lot of international press interest because of its implication and what it can do in changing guidelines later on and doing things. For instance, here in Saudi Arabia, we are now redoing the Saudi endocrine guidelines for obesity, and we are using the Lancet Commission for this. Some of the commissioners are in this room, and I appreciate them being here, Dr. Phil Shower and others. And the commission basically, why do we need to redefine obesity? That was the question. So for a very long time, the WHO, the American Medical Association, Endocrine Society, IFSO, ASMBS, everybody has been screaming for a very long time that obesity is a disease. Yet, no matter how much we scream, I don't know what happened, but I don't have a video perfect. No matter how much we scream, it really doesn't make a difference because no one is acting upon this definition. It is the only chronic disease with no coverage in private insurance. And when you look at universal health systems like the system that I work in, we don't know where to start. Why? Because the problem is just so huge. More than 1 billion people in the world are diagnosed with obesity. When you go to private insurance, insurance will say we cannot treat everyone. When you go to universal health care, for instance, here in Saudi Arabia, I've heard this on and on and on again, you cannot tell me that 70% of my population is sick. This doesn't sound right. You need to do something else. You need to have another conversation. They don't say the same thing about type 2 diabetes. They don't say the same thing about hypertension. But when it comes to obesity, this conversation is always there. So,
spelling.
This is not moving? Okay. And these are the things, these are the numbers in Saudi. So why redefine obesity? Because we know that BMI is flawed. And as long as it's flawed, what do we do? What's next? So we had this commission. The consensus development process was made of a globally representative multidisciplinary group. There were 58 experts from all around the world. We had academics there. We had people who were scientists. We had public health specialists. We also had patient representative groups with us. So in the and we had World Health Organization officers where were we from? We were from all over the world. So every part of the world was represented. From the GCC countries themselves, we had 3 different representatives from the GCC countries. So we really were very well represented from this part of the world as well. So when you look at obesity, for instance, and this is just showing you someone with a BMI of 31, for instance, which by classification has obesity, and other people who do have actually excess fat, but someone who doesn't really have any ongoing disease, and the other person who really is having ongoing disease. So basically this shows you how BMI is really, just when looking at BMI, you really have a flawed perception of what's going on. We look at excess fat as a whole spectrum of obesity, and then what we were proposing, or what we proposed in this commission, is to start looking at obesity in two different tracks, one calling it preclinical obesity and one calling it clinical obesity. So with preclinical obesity, these individuals will still have preserved health. The ones with clinical obesity are supposed to be basically prioritized for treatment because they actually do have an ongoing active illness. So what we're talking about is if anybody who has, this excess fat, who has causes of or risk to have this adipose tissue expansion, genetic, psychological, or so, should undergo primary prevention. Those with preclinical obesity should be monitored because they have a chronic disease. Basically, and should have prophylactic interventions. They should have risk reduction for them not to develop other complications and other diseases. And those with clinical obesity should be acted upon now and urgently. And this just shows you the difference between preclinical and clinical obesity that we suggested. We do have BMI thresholds for everybody based on ethnics and age, and then we take another measurement, waist circumference, waist to hip ratios, where we suggested, so other measurements that really do predict health rather than BMI alone. And then when we look at pathophysiology, we know that it is really linear, where you start with alterations in cells and tissue and then end with clinical obesity to end organ damage. So we want to monitor you in the very beginning so we really prevent that clinical obesity of happening. And if you have clinical obesity now, we want to get you treated. So how do we do that? So this is just showing you a schematic of why it is a clinical obesity, the pathophysiology. I'm not going to go into this, especially after watching videos. I know your brain is in that technical part, not and this part. But it talks about inflammation. It talks about the complications that happen, the pathophysiology of obesity, and what really happens in those individuals that develop the disease, and that leads to the cardiovascular health risk, to the type 2 diabetes, to everything else that obesity actually causes. So when you see someone with obesity, what we suggest is you actually look and see if they have clinical manifestations of obesity. If they're not, if they only have an elevated BMI, then if they don't have excess fat and they don't have that, then basically they don't have obesity. If they do have obesity, then you have to look at it. Do they have clinical obesity, or do they have if they have preclinical obesity? And how do you evaluate that? You evaluate that by signs and symptoms like every other disease. And so we developed 18 criteria for adults for clinical obesity and 13 criteria for adolescents and children. And then what we suggest doing here, let me just move this. So what we suggest doing here is when you see these patients, as I said, in the clinic, so we get these patients, and just to explain the slides, in a very simple way, you may see a patient with a BMI of 29, for instance, that does not meet thresholds for treatment for obesity, so to speak, that may not have the chance to be seen in my clinic, but that patient may have obstructive sleep apnea on board, they may have difficulties getting up the stairs, they may have difficulties of daily activities, they may be suffering stigma, and those individuals will unfortunately have to wait in today's definition to reach that threshold of BMI of 30 to get treated. But what we're suggesting is saying, no, these patients meet the threshold of clinical obesity, so they should be treated. On the other hand, and I'll show this again, you may have other patients who may not have those, for instance, those manifestations, and may be doing very well with a BMI of 33. And you can wait on treating those individuals and say, you know what, these individuals may not have clinical obesity. We can prioritize this individuals with a BMI of 29 over this individuals with a BMI of 33 to get them treated. These are the criteria that were suggested or that were voted for by all the commissioners. And just to point out, all these were voted for by either a unanimous vote or a very high grade, more than 90% of vote over these criteria. Why is type 2 diabetes not a criteria for diagnosis? Because we wanted to make sure that we will not be using a disease as a criteria for another disease, because there is no other disease that is defined by another disease. So you'll find hyperglycemia, but not type 2 diabetes. You will find, difficulties in breathing, but not obstructive sleep apnea, so to speak. So we are avoiding diseases. And then, so finally, this is what I was talking about. This is just a schematic showing you, and I want you to focus on probably the last two here. And you can see, and I'm just going to get closer because I want my pointer, which doesn't work. You can see the last two where you have someone with a BMI of 39.2 and another person with a BMI of 39.2. They both have excess fat. They both have muscle mass that's normal to low. But you'll find the one with BMI of 39.2 may have signs and symptoms of obesity, and the other, this makes it much easier. The other person does not have the signs and symptoms. So the first one is defined as preclinical obesity. The last one is defined as clinical obesity. Who would you take to your OR to operate? The clinical obesity person before you get the preclinical obesity. This doesn't mean that you're not going to treat preclinical obesity, and this is very important, and we made sure to mention that in our consensus, that those people with preclinical obesity may be at high risk of developing clinical obesity, and therefore we want them to get the intervention. But when you come to insurance companies and when you come to governments and speak to them, then you have to have a clear way to prioritize. And although it may not be perfect, this is the way that the 58 commissioners came out between surgeons, obesity medicine physicians, scientists, and patient representatives. This is what we thought it would be. So scope of care, as I mentioned, really it should be on risk reduction for preclinical obesity. It should be on public health policies. And on an individual basis, it should be on intervention plus prevention of development of clinical obesity. On this clinical obesity scope, it should be aimed at remission of diseases. It should be definitely aimed at remission, and those patients should be prioritized. So next steps, and I'm going to end by that, we should implement these for better access to care for our patients, because our patients currently are not getting the right access. We have a lot of patients who have obesity that are left behind, and we have to find a way to get them better access. And then the other next step is that these are going to be, when implemented, they're going to affect metabolic surgery guidelines. They're going to affect medication guidelines, because all these guidelines up to this day still depend on BMI rather than clinical and preclinical. And I'll end my talk there. Thank you so much.
Thank you, Nasreen. Just before I open the floor for questions, and since you are talking about definition, so we are now having, for weight loss, we are having two definitions: excess weight loss, and we are having total weight loss. Do you think this is confusing?
So we did talk with IFSO, right? In a couple of years ago, I think we published in IFSO that we didn't want to use excess weight loss anymore, that we are going to use total body weight loss, and the rationale behind that with the total body versus excess is that really excess did not tell us anything about, again, health risks later on. Total body weight loss was, because we know that, for instance, for type 2 diabetes, you need 5 to 10% of total body weight loss. For MAFLD, you need about 7 to 10%. And so we get more information with total than excess, and that's why we're moving away as well from excess. Okay. Will this be confusing? We will see. We are trying to help rather than deter, so we will see. We are hoping it doesn't get confusing.
Okay, Osama.
Yeah, Phil, you're interested? I just want to ask you one question related to the fact that you have the insurance now going by BMI. So do you think, because we've been writing guidelines, you and I, and we've been working on this, do you think we're going to say, on top of that, please consider these people, or we'd say discard that and go with this new definition? What do you think the way to go without affecting access to care?
So with surgery, it's a little bit different, right? Because the surgeons have been around much longer than we have. And the surgeons have been fighting the fight much longer than we have. And given the fact, and they are more than us. You guys are way more than we are. And yet, given your numbers, and given how strong you are, and given how effective your treatment is, and all the data that you have for your treatment, I'm going to talk about here in Saudi Arabia, we were only able to get insurance companies to cover metabolic surgery following scientific guidelines very shortly, a few years ago. So I am hopeful, I am very optimistic, but I'm cautiously optimistic about what's going to happen. Because again, it's redefining, and redefinition is always difficult. We are having difficulties with anti-obesity medication versus obesity management medications, for instance. So redefining things is always difficult, but we are hoping to try to convince them, and we are actually doing the study now in at least our center to try to comb out how many people in our centers have preclinical versus clinical. Maybe if we calculate the economic burden of that, then we can convince insurance companies to at least get coverage for those individuals. Because where we are right now is zero. We have no coverage for medication.
Thank you very much, Dr. Nasreen. I agree with you in principle. We should be moving now from just the BMI to more approach in treating those obese patients rather than waiting for BMI to impress our eyes, and then that's the time where we start. And I think it is up to us as a clinician and guideliner authority to enforce this in our guidelines, and hopefully we could convince the healthcare givers to provide support for those patients.
That is the goal, hopefully. That is the goal, better access to care.
Yes,
Burak.
Can I ask
Günaydın Burak.
Thank you.
Hoş geldiniz Suudi Arabistan.
With my best wishes from Turkey. I would like to thank Dr. Nasreen for her nice presentation, and I want to decline something about measuring about obesity, because most of the measurements and decisions are made upon some body mass index criteria. But these criteria are depending upon mostly in North European and North American measurements of these numbers are changing. We see that because from population to population, genetic imbalances happen, and some of diseases occur in earlier body mass indexes. I think some more studies should be made on this, and local decisions and local studies must be done on diseases. What's your opinion about that, I wondered?
So I do agree, and that's why in the commission we made sure to look at ethnic cutoffs, and we actually had a subcommittee. I couldn't, because of the short time, I couldn't explain how we did it. We actually had a subcommittee looking at different ethnic shortcomings. It was led by a physician from India that was looking at that, even with waist circumferences and basically, especially BMIs, not only, Asians. Here in the Middle East, I'm just going to say we're Middle Eastern, so we're between Asians and between Caucasians, but we don't really have, we're thought to be at about 28 as starting the threshold for obesity, but we still don't have large demographic data to back that up. But we did look at that as well in our commission.
Okay. Last question, Phil Shower, please.
Yeah, Nasreen, wonderful summary of this very extensive analysis. It took about 2.5 years. I was lucky to be a part of that as well. I think one of the biggest concerns of surgeons and any practitioners who manage patients with obesity is the implications of this for the payers and insurance coverage. How will this affect this designation of clinical obesity versus preclinical? Do you think that the payers are going to primarily focus on coverage for clinical obesity in Is that a good thing?
So that's a very good question. I'll be the devil's advocate here and say, in my heart of heart, I don't want that to happen. I don't want to be the focus to be only on clinical obesity, because I think preclinical obesity should be treated as well. But the honest to God's truth is that if we get coverage for clinical obesity as of today, that is a success, because right now, as I said, we have zero coverage. We have nothing.
Yeah, I think that's a great point. I agree with you. And just to give the audience a sense, we had Eric Ravison, who is part of this commission as well, did an analysis on the U.S. population. About 40% in the U.S. by body mass index have obesity, right? But if you break that down into clinical versus preclinical, about half, about 20% of the 40% actually have clinical obesity. So in some respects, that may make this whole population disease component more manageable from a payer perspective.
Yeah, that's the hope.
Our next speaker is Dr. Hussein Graini. Is a consultant endocrinologist and obesity lecturers in pathophysiology of obesity beyond BMI.
Assalamu alaikum. Thank you very much for the introduction, and thank you very much for the organizing committee for the invitation. In the next 5 to 7 minutes or so, I'll build on what Dr. Nasreen started, and because of the short time, I'll start with the take-home messages. Obesity is a prevalent, complex, chronic, progressive, and relapsing disease. It is characterized by excessive or abnormal adipose tissue that impairs health. This is very important to keep in mind when we define obesity. And the amount of adipose tissue, its function and location are important with regard to health impact. BMI is effective in identifying trends in obesity and overweight prevalence across population level, and as a screening tool as well. But it can under or overdiagnose obesity, and it does not provide us information about the location or the function of adipose tissue. Nasreen already talked about this. So all the major organizations do recognize obesity as a disease, and obesity complicates almost every organ system, and the complications can be metabolic, mechanical, or mental complications as well. Now, most definitions include 3 components when we talk about obesity. So the complexity, progressive, and relapsing nature of obesity, that's number 1. Number 2, the fact that it's characterized by abnormal or excessive body fat. So excessive body fat results in mechanical complications. The abnormal or sick fat tissue results in the metabolic complications. And then the third point, it impairs health, and hence the clinical definition of obesity. Now, when we talk about obesity or energy balance, we always simplify it by calories in, calories out. But in fact, it's much more complicated than that. So in the hypothalamus, we have 2 nuclei that integrates all the signals from the peripheries, the POMC card, the AGRP, NPY, and from then the projections control our behavior and energy expenditure. And in states of energy, positive energy balance, we store fat. So once we fill the subcutaneous fat tissue, we start storing fat in abnormal places, and that does result in complications. Now, keep in mind, adipocytes are not just energy place, but they are very active endocrine organ. So they secrete many adipokines, cytokines that has immunologic and metabolic action. And some of these actions are local to the organs, and some of them are systemic, which results in the metabolic derangement that we see with patients with obesity. This is the WHO classification based on BMI, and as Dr. Nasreen alluded to, BMI has some advantages, which is why we use it today. So it's easy to calculate. Our electronic medical records give us BMI automatically, so it's easy to use to screen for obesity. It strongly correlates with many of the complications that we see with obesity. And again, it's very good, effective if we look at population level. The disadvantages of BMI, it doesn't directly inform us about fat mass itself or the distribution of fat mass. And it does not differentiate between lean mass and fat mass. It tells us about the weight. But what is this weight exactly? It doesn't tell us. And again, it is impacted by ethnic, gender, and age. There is huge variability with BMI. And that's why over the past year or so, there has been a move away from BMI. So EASO established their framework. And more recently, as Dr. Nasreen mentioned, the Lancet Commission, I think they did a great job trying to define obesity, staying away from BMI. And Dr. Nasreen already showed this, and I want to bring your attention to case number 3 and 4. So, for example, case number 4, patient has a BMI of 32, and this patient has high muscle mass. So we would traditionally label this patient as obesity class 1, while in fact this patient does not have obesity. On the other hand, patient number 3 has a BMI of 28, which would put him in the overweight category, but this patient has excess body fat. And this puts him at more risk of complication, and therefore the new diagnosis for this patient would be preclinical obesity. So again, to end my presentation with the same take-home messages, obesity is a chronic, complex, progressive disease characterized by excessive and abnormal adipose tissue. The amount of adipose tissue, its function and location is very important when it impacts health. BMI is easy to use, it's effective for population levels, but it does not tell us about the location of the fat and the function or the dysfunction of the fat mass. Thank you.
Thank you, Dr. Hussein. And I agree with you. I think, to be honest with you, we have to add another criteria other than the BMI threshold we are following to add the clinical obesity. We define it, and that can be added to the indications for intervention, regardless of the level of intervention. Any question and comment for Dr. Hussein? I have Professor Nami here. Professor Muhammad.
Thank you very much, Dr. Hussein, for this elaborative discussion
Muhammad,
about...
get the mic closer.
Yes.
We barely hear you.
Thank you so much, Dr. Hussein, for this description of the pathophysiology. I think, as you have presented, the North Americans, they made their own criterias, and the Europeans, they made their own criterias. I think we have to make our own criteria in the Middle East, supported by research, because really we are lagging behind in research to see what is preclinical, what is clinical obesity in our population. So I encourage you to stress upon research and to collaborate with other research centers from where you're working, so we can do some data and make our own guidelines. Thank you.
I 100% agree with you. And as Dr. Nasir mentioned, we are in the process of writing endocrine society guidelines for using of obesity medications. And we do need to have research coming from our population to incorporate into these guidelines. I agree with you.
Thank you.
Thank you, Hussein, for a wonderful presentation. The reason I called you to present is because we both believe in this, and I want to ask you a practical question. So if a patient comes to you in the office and is a BMI of 37, you want to determine if it is clinical versus preclinical obesity, what would be the basic workup that you would recommend that we do for our patients? Because I think about, in my practice, many patients come for weight loss surgery, and 71% of them would end up with incidental finding of clinical obesity diagnosis at the end. But what would you recommend, just as a basic level investigation for anybody who arrives in somebody's clinic from a surgeon point of view?
Yeah, I think one of the easiest measures that was suggested and the guidelines is weight circumference, waist to hip ratios. That's very easy to do. You can just standardize the process of measuring these parameters and include it in your assessment. In our centers, we do bioimpedances devices to look at different body compositions, but I don't believe all centers have access to such machines. But I think any step you take beyond BMI will be very helpful in a proper assessment of the patient to categorize them to either preclinical or clinical obesity.
Dr. Hussein, obese class 1, in absence of metabolic syndrome, it's difficult to tell or to talk about the fat mass and muscle mass. patient doesn't have any metabolic syndrome. What do you think? Because you have said here that we should show the difference between the muscle mass and fat mass.
Yes.
Not only the BMI.
Yes, yes.
But
correct.
in absence of metabolic syndrome, how can you convince people that it matters? Patient is not diabetic, not hypertensive.
Yeah, this is a very good question. So let's say a patient who is not known to have any disease, for example, and he has a body composition that shows that he has abnormal fat mass. That's your question. How do you convince this patient that he is at risk and he needs to take action? That's, I think, is a very, very good question. And I don't know. That's a very good question, actually. I don't know if Nasreen, if you have any thoughts.
I'm just going to again pivot to our to the commission, and that's why there was a question, and I expected somebody to ask me today, what's the difference between preclinical obesity and metabolically healthy obesity? Because people were confused and they thought that we were talking about the same thing. Now, what the commission does is it takes it a step further, but we're not only talking about metabolic risk. Metabolic risk can be taken into account by, for instance, waist circumference. But what we're looking, when we look at clinical obesity, when you look at the 18 criteria, we're looking at other things. For instance, some of the things that we're looking at is shortness of breath. We're looking at activities of daily living. We're looking at joint pains, which are not metabolic dysfunction. But we're trying to look what we're trying to do is look at the patient as a whole and try to see if this disease of obesity has caused organ dysfunction, whatever organ dysfunction it is, in any other way. We even look at, for instance, increased intracranial pressure. We start from up here and go all the way down to the end. So I hope that answers your question. In a perfect world, I would be measuring DEXA scans on everyone and seeing how much fat mass they have, and if that fat is visceral, if it's dangerous or if it's not. But just to make it, applicable here in Saudi Arabia and applicable in a rural place, wherever in the world, or even in Saudi, just to take waist circumference will tell you a lot about the patient's risk.
Honestly, many people look at Lancet Commission as good step, but in the wrong direction, because we are depriving patients who are, by some definitions, somehow overweight or obese, but we are saying they are not having the organs dysfunctions, but nobody will guarantee they are not almost close to have it, or next maybe year they will have it. We know even the minute you depart BMI, for example, 25, your risk of disease will double and triple. But we don't see the parameters that we are looking that will discover these risks. So this is, yes, it's good things, but we are eliminating 50% of the populations from a category they are originally in, to say, well, they don't have organ dysfunction, but eventually they might have it in the next year or a year after. And we are saying, don't touch them. Maybe we'll tell the legislations or the providers, don't worry about them, they are okay, but later on we'll see. I think maybe we should revise this and look to see another way of looking at it. So I want your opinion and Nasreen's opinion at this point.
Yeah, thank you very much. Yeah, I think what the Lancet Commission wanted to say is, well, let's give priority to those patients who are already showing the clinical syndrome of obesity. They didn't say, let's just ignore these patients or not follow them. So these patients will be clinical will be followed. They will be counseled. But the priority, if you have limited resources, is to be given to those with clinical obesity. Nasreen, I don't know if you have any.
In my presentation, we also said, even if they need intervention, you should intervene. So what we said, I had that slide looking at public sector, prevention, risk, and on individual. And when we look at the individual part, it said to monitor
bring them back to the clinic all the time, see if they develop any organ dysfunction. If you feel that they need intervention, then intervene even before they go to clinical obesity. So as I said, the clinical commission, as you said, it's not perfect, it's flawed, obviously, because we are human and to err is human. But what we're trying to do is to 40 BMI, you don't need anything.
Kilogram effect on your joint, on your other issue. And you are saying, no, wait until he loses his joint and I will start.
We're not saying wait until he loses his joint. We're saying he's diagnosed as preclinical obesity. We're comparing to the other person who has a 39 BMI. You have these two people in your office. Who are you going to prioritize for treatment? You're going to prioritize the first one. You're going to do him first, and then you're going to move from this. We're not saying you're not going to treat this one, but this is a way to categorize your patients, and rather than putting them all BMI of 39 are treated the same.
Maybe regulators will come and say, as long as Nasreen say Lancet Commission, put them aside and let us enjoy our time and giving the priority.
This is what we're hoping they're not going to do, but they may. But at least I can get the BMI of 39 to get prescribed Mounjaro, will I get prescribed Wegovy, will whatever drug I have, where today they're not covering anything.
I was just going to add, I think the operative word here is priority. That's the operative word. Most healthcare systems have a fixed budget. So you have X amount of dollars to treat a population. So you have patient, A with clinical obesity, patient B with preclinical, who gets the treatment? And I think they're saying that prioritize those with active illness, not to ignore the ones that are preclinical, and eventually, if and when they become clinical, they should be monitored very carefully to identify when that occurs, then they get treated.
I think the same point is what you've said. Is I've said it in a different way in my question. I said, will it increase access to care? I think a marriage between the IFSO SASMBS guidelines of 2022, where we said 35 and above should be treated. If you just don't say 40, say 35 and above are considered clinical obesity, that will solve it, because our problem was between 30 and 35. That was our problem. Yes, there will be a 35 BMI or 36 who is really clinically well, and he is a muscularly buffed guy whom somebody will take advantage of these guidelines. But we're not talking about the people who will break the guidelines, because there are many ways where you can just go beyond the guidelines and do things.
Thank you, Dr. Osama, and with this we'll come to the end of this. Thank you, Dr. Hussein, and we'll move to our next speaker.
Our next speaker, Dr. Hassan Shakir, he's a professor of surgery, Ain Shams University. He will speak about discrepancy in the care of patients with obesity.
Thanks so much, Dr. Ai, Dr. Sultan, Dr. Osama, and the organizing committee for inviting me for such esteemed conference and gathering. This slide shows the distribution, according to the World Bank, the distribution of the income in different countries, showing the disparity in the income between most of the nations. And in this slide, it categorized the countries according to the income, from low income to high income, passing through the low, middle, and upper middle income. This is the picture in mind for the people from low income countries, that they are underweight and emaciated. But surprisingly, the problem, of course, is the low in these poor nations, with their consequences of comorbidities, namely diabetes and hypertension. This results in overburden on the health systems, which is basically designed in these nations on the infectious disease and the pediatric diseases. So what are the drivers of transition? Nutrition was in the past low calorie, gained from grains and hunted fish. It shifted now to of sugary beverages, which is now something like addiction. The second factor is declining of the physical activity. The jobs are moving from manual labors to sedentary jobs, so with decreased activity. Also, the mechanization of the domestic work shifted from the manual. I don't know what happened. It's going forward instead of. Sorry for that. Yeah, the mechanization of the domestic work link during the daily curb. The leisure time shifted from the physical activity to less moving activities, aiming thanks to the technology like the electronics and the TV. So this is the picture of the children these days sitting in front of the TV, watching the TV with the consumption of obesogenic food, desirable, and also at the same time they look at the underweight as if he's poor, or on the other side has a serious disease. So some of them try to get more weight to prove that they are not ill or they are not poor. The end result that we see in the same family, we can see an overweight adult and an underweight child, and both are suffering from poor nutrition with associated diseases, and the treatment of associated diseases like obesity and hypertension added to the burden on the healthcare system. Pregnant women, in addition, if they are obese, they got increased incidence of diabetes, hypertension during their pregnancy and care burden due to morbid obesity. What are the challenges in these nations for treatment of obesity? The first is the cost, because the surgical treatment is costly. Staplers and reloads are costly. The complications add significantly to the cost, and there is limited resources in the public sector and of course of the private insurance. So most of the cases are done in private hospital for those who can afford it. Even the weight loss drugs are also expensive for those people. The second is the practice. There is lack of guidelines in these countries for the bariatric procedures, and there is no appropriate training programs and no sticking to the multidisciplinary team concept. Some reuse the disposable instruments, and the follow-up programs is difficult to implement, especially the follow-up with the dietitian after finishing the surgery. There is social demographic disparity or discrepancy between the people for their treatment, even in the high income, the bariatric treatment or the obesity treatment, between the major cities and small cities, as well as between rural and urban areas. So the low income countries try to avoid obesity instead of treating obesity. The preventive measures include some measures from the government and some measures from habit starts early in the childhood, and the proper nutrition in school reflects that on the families and encourage them to have healthy food. The government approach as well is important in subsidizing nutritionist food and also increasing the taxes on the obesogenic food, as this, it was done in Mexico, that they increased the taxes on the sugary beverages, so to force the people to decrease the consumption of such beverages. However, researchers suggest that without intervention, surgical intervention, obesity will continue to increase. So, what are the solutions? First, the cost of the bariatric surgery is relatively cheaper in developing countries. Why? Because the market, according to the McDonald's dollar scale, in Egypt, for example, we have an experience with the unified purchase policy that led to buying these devices in cheaper cost. Second, as the surgeons are getting more trained and gained more experience in bariatric surgery, either through moving themselves by themselves to go to foreign centers for training, or for developing centers in countries. And in Egypt, we have 2 major training centers for bariatric surgery. And also in Rwanda, there is a huge center funded by the European Union. The choice of operation, the surgeon try to go to surgeries with less cost for the surgery and for the post-operative consequences. For example, a sleeve gastrectomy is preferred rather than gastric bypass if possible. Also, they go to less costly operations like the butterfly, although the butterfly results are not high and they are not promising, and the long-term results are not as good as, but still some believe that they are suitable due to their less cost. The also less costly operation, the gastric plication, there is no reloads at all, and no gastric is still considered investigational operation. And now the trials of the endoscopic sleeve gastroplasty, there is no scars, no staples, and it is reversible. It's still under trial. And gastric bypass is reserved for failure of other procedures, or there is a severe gastroesophageal reflux. The weight loss drugs might be a solution for such nations, as the patents on various weight. Now in the market there are available compounded semaglutide. They are cheaper than Ozempic, but it is not FDA approved yet. So the ways to finance weight loss surgery are through the government aid, health insurance companies, charity fundraising, and bank finances for individual patients. In conclusion, obesity is emerging and increasing problems in the low and middle income countries. Switching of type of diet, physical activity, cultural habits contribute to aggravation of the problem. Cost, training, and malpractice are the main challenging programs, appropriate guidelines and protocols for each case. Before I end, I wish to invite you all for the 21st International Congress of the Egyptian Society of Laparoscopic Surgery, which will be held less than 2 weeks from now on the 20th and 21st of February in Cairo. I wish all of you can attend to enjoy Cairo by day as well as by night. And this is the website you can register through, slscongress.com. Thank you.
Professor Hassan, thank you for this presentation. My question for you is, as a chairman of the society, what do you think is the society role? You know the society role to your members, but what is the society role towards the community or towards the population in general? What do you think is your role?
We have in our society, actually, one of the objectives is the orientation to the normal people, not to the surgeon. We have initiated now a page on the laparoscopic procedures for the normal people, and so to let them know exactly what is with and what's against different procedures, different aspects, and also especially for bariatric surgery to guide them to the proper pathway they pass through if they need operation or even if they need treatment of obesity, how to be properly guided, how.
Thank you very much.
Thank you.
Thank you, Professor Hassan. And we'll move to our last but not least lecture, which will be introduced by Dr. Nasreen. titled Unrevealing the Power of Mounjaro for Chronic Weight Management. The time here is half an hour, Dr. Nasreen. So if you can make it 5 minutes.
Are you going to give
15.
them a break? You will have a very nice break.
Sorry?
I'm all for the break. La, I am all for the break.
10 minutes. Okay, yeah. Are you okay? No, I'm saying we'll give you 5 minutes. I was joking.
It's fine. Whatever you want to give me. It's I will work with whatever you give me.
Thank you very much.
I'm good like that. So I'm going to be giving this talk on Mounjaro. I don't know if the slides are moving. The slides are not moving. Is that okay? Okay.
Can we Dr. Nasreen slides?
Okay, there we go. So just disclaimer and housekeeping, this program is sponsored by Eli Lilly. I am receiving an honorarium to give this talk today. Please don't take any photos or videos during the Eli Lilly's regulatory rules. So these are my disclosures for this talk. I really am not a shareholder, unfortunately. But other than that, there's really not much to give on disclosures on the stocks for me. So here in KSA, the FDA approval for Mounjaro or tirzepatide is management, because obesity is not approved anywhere, but chronic weight management for those individuals who have a BMI of 27 and above with a complication of obesity, such as type 2 diabetes or hypertension or whatever, and then, or BMI of 30 or above. Either is really a multifactorial chronic disease, and it is influenced by many factors, including genetic, environmental, physiological, and these actually turn to cause other diseases, can impact diverse range of other diseases. It causes a lot of complications, including dyslipidemia, hypertension, type 2 diabetes, all the way down to PCOS and MAFLD and MASH. So a lot of metabolic disorders that can happen with obesity. Mounjaro is a once weekly, it's a novel drug. I hear a lot of people bunching it here up with GLP-1. It's two receptors. It's novel, and when people ask why is it so expensive, it's because of the novelty of the drug. There's no other drug like it so far. So how do they work? It activates, just like any other drug that works in obesity and work, the GLP-1 receptors, the GIP receptors. It reduces appetite accordingly, and as a consequence, we may see reduced food intake and increased fatty utilization. It does reduce cravings as well, and it gives you that feeling, patients that feelings of increased feelings of satiety and decreased feel when they are on the drug. So the studies that have been done here, SURMOUNT-1 was the largest, the first study that was done on individuals who do have obesity but do not have type 2 diabetes. They may have other complications of obesity but not type 2 diabetes. It was a study that was 72 weeks, milligrams, 7.5, 12.5, and then 15 milligrams over a period of 75 weeks, and then they wanted to see how much these patients' primary endpoint were going to lose weight, and then they wanted to see, the effects, the metabolic effects of this drug on systolic blood pressures. In SURMOUNT-1, it caused about a 22%. Placebo subtracted would be about 20% of total body weight loss, because remember, the FDA mandates, I don't know why these are not working. The FDA mandates always a lifestyle intervention arm. Obesity is the only disease, by the way, where the FDA mandates a lifestyle intervention arm. It doesn't mandate it to anything else. So what we tend to do as obesity medicine specialists, we take that lifestyle arm and we subtract it from the total body weight. Anything, you take away the lifestyle arm, basically they will lose about 20% of total body weight loss. It's really important to know how good the drugs work. So powerful reductions of weight losses in tirzepatide at 15 milligrams. About 60% of patients lost at least 20% of their weight. and about 40% of patients lost at least 25%, and this is all total. Whatever intervention you give, if individuals are going to lose a lot of weight, they will lose some lean mass along with it. You'll find that the lean mass loss was about 10.9% as opposed to about 33.9% of total fat mass. So they're losing much more fat than they're losing muscle, which is supposedly expected with such pressures. Their triglycerides, they did have improvements in LDL and HDL cholesterol. And remember, I told you these individuals did not have type 2 diabetes, but some of them had pre-diabetes, and the rate of reversion back to normal glycemia was about 95%. So what are the adverse effects that happens with these drugs? They're pretty safe drugs. Remember, they're natural hormones. You're not supposed to be worried about these. They target natural receptors in your body. The most common side effect, because it is a gut hormone, so to speak, so it does cause those gut adverse effects, nausea, vomiting, the constipation, the diarrhea, thing to mention. Now, I get a lot of questioning, okay, what if I took the drug and then I lost the weight, and then what happens? So you need to continue the treatment of the drug, and we do have trials that prove this. We have trials with other drugs. With tirzepatide, there's the SURMOUNT-4 trial, and this is basically what everybody wants. And then they say, okay, now you've lost the weight, we will randomize you. Some of you will be on a lifestyle intervention, so they're not going to let them go to the world and do whatever they want. They're still on a lifestyle and exercise, and some of them will continue on the drug. And what happens is what you see. When you take away the drug doesn't work. So if you stop the drug, the people that continued with the drug continued to lose weight up to more than 20%. The people who stopped the drug at 6 months regained weight despite all this. They will not be able to control, because again, obesity is a disease. It is controlled by the brain. It is physiology. It is not behavior. So more, again, same results as SURMOUNT-1. People who lost at least 20% of their weight, about 70% of people who lost at least 25% of their weight, about SURMOUNT-1 and the SURMOUNT-4, and the same adverse effects that happened in these trials. Now, when we talk about dosing, I did realize that a lot of people are talking to me, even in this Congress, they're going up on the dose. They're just titrating up. These doses are available not for titration, but there are different doses that are available. So you have the 2.5 milligram. You give that drug for 4 weeks, and then you titrate it up to 5 milligram. And then what you do is you wait. If your patient is responding to 5 milligram, then that is it. Then you're happy. You don't have to titrate to the 7.5 or to the 10 or so. Those are different doses. If your patient is not responding, then or reaches a plateau, then you use other doses of the drug, because other doses may cause more weight loss if need be. So this is a case actually from my clinic that I'm talking about, and this is a 23-year-old male. He presented to my clinic. He had class 3 obesity. He had a BMI of 44.7, weight history. He had onset of obesity at puberty. His chronology of weight gain, his highest weight was 150, and his father's family. So when I delved into his obesity into his weight history, I asked him about hunger and satiety. He did have excessive hunger and limited satiety. He did have non-hunger eating, so he was night eating syndrome. But he did have sedentary lifestyle. He slept for about 7 hours, so his sleep was fine. He didn't have any circadian rhythm disruption. He ate 3 meals a day with some snacks. Didn't like sugary beverages, but craved junk a lot, which shows you that out about once a month. So he was trying to control what he was doing. He had multiple weight loss efforts in the past. He did multiple diets because he had developed this since puberty. He started dieting at the age of 10 years. That was, again, very worrisome to me, because that means that he had a lot, I've been dieting all my life, because you know that treatment of their obesity is going to be harder because of metabolic adaptation. Because each time they diet, they raise their fat mass point a little bit. It gets higher and higher and higher. So you get into that.
Dr. Nasreen, 2 minutes, please.
Okay. So what we did, he didn't exercise because he didn't like it. He was stigmatized in the gym, which I completely understand. Is this going? Okay. And these are the problems that he had. He had limited functional capacity, didn't have type 2 diabetes. He did know that what I would do with this guy, I would definitely send him for surgery. He is a young man with a BMI of 44.7. He has his life ahead of him. So I did talk to him about all the options, and we talked to him about surgery, especially that he had a strong family history. So I know he had a bad disease. And I did talk to him about medication later on. You will probably need medication down the line because you do have a resistant disease. But at 24 months, I followed these patients for life because obesity is a chronic disease. He came in and he expressed return of hunger. I am hungry again. He had reduced satiety. He had 9% of total body weight recurrence with progressive disease. For 4 weeks, titrated it up to 5, and my goal was to reduce symptoms of obesity. So this is what I ask my patients. Did the hunger go away? Is the satiety back? Do you feel like you felt after surgery or not? If they say yes, then the medication of total body weight loss, and he was still complaining of hunger though, and but no more decrease in satiety. He was fine. So I told him to increase the dose to 10 milligram. It's important that I did tell him to increase the dose to 10 milligram, and they skipped the 7.5 because he was doing fine. With the 5 milligrams, he didn't have any adverse effects, and he wanted to titrate up, and my appointments are very far away, so that was the reason. But we usually do recommend to go 0.8% additional to the initial 5%. So total body weight loss with tirzepatide in this patient was 15.3%. Total body weight loss with combination therapy, surgery plus tirzepatide was 41. This is his graph. I'm practically done. This is his graph. These are the medications. So we diagram at the very end. And he has reached a plateau as of today. He is still on 10 milligrams. And what am I going to do? I am going to continue him on the medication. If he needs more in the future, I may increase to 12.5. But as of today, he's doing very, very well on the 10 milligrams. And I will end my talk there. With take-home points, chemotherapy or pharmacotherapy. It is surgery and pharmacotherapy where we move forward, and I will end there.
Thank you very much, Dr. Nasreen. And we'll have 1 or 2 questions.
I have a question for you about recurrent weight gain. So, do you think we should have a more proactive role in preventing recurrent weight gain, starting patients early and identifying? So
it's very, very interesting. So, it's very tricky, right? Because you can't really predict who's going to have the weight recurrence versus who's not going to have the weight recurrence. For this guy, what saddened me was he had it very early. He had a monitor, and when he told me he was hungry, that's why I was really aggressive and started the medication. And he already came back with 9% of total body weight regain. I would accept that if that was 5 years later, but in 2 years, that was very worrisome to me.
Thank you. Professor Wali.
Thank you very much for a beautiful presentation, Dr. Noghalia. We are applying more and more the Mounjaro and getting very good results with it. Really, it's impressive and fantastic. Is there any definite studies, double-blind randomized study that shows in which group of people it will be more effective? Because we see failures also with the use, and then so I'd like you to comment.
This is a very good question. Unfortunately, no. We do not have randomized control trials. I would love to do a randomized control trial and see what's happening. But still, we don't even have investigator-initiated trials showing post-bariatric surgery. We have for suboptimal weight loss, there's the still don't have anything on tirzepatide. But what I would say is that, the pathophysiology of obesity is very different. It is not one obesity, it is multiple obesities we deal with and work with. And fortunately, we do have other drugs.
Do you think it will go in that direction in doing those randomized studies at one point?
We've been doing this. I've been doing this for the past 14, 15 years, using medication, and we published...
End of our session. I'd like to thank you all for attending, and I think we'll have 15 minutes break. So Dr. Osama is refusing. So put the cursor.
Khadija. I'm sorry.
أنا جاية الصراحة أساس أشرب هنا قهوة ما دريت إنه في جوا قهوة داخل. Go ahead. So it is my obesity medicine certified, and he works for my clinic and will be presenting today the prevalence of clinical and subclinical obesity, importance of age, gender, race, and BMI.
Thank you very much, Dr. Nasreen. I do sessions. So I'll try to be light and be more of an appetizer for what's coming next with our world-renowned experts. So this was the title, Prevalence of Clinical Subclinical Obesity. And I thought at the time there was no one ahead of me, but now that we had Dr. Nasreen already presenting what clinical and subclinical obesity, I'll be very fast in presenting my talk. So if we every country, and you can see that Saudi Arabia has the adult population with obesity on the rise. Now, unfortunately, we're still using BMI as our diagnostic tool to define the population of obesity. And you can see that the children category, although it's sort of like a flat line, it's actually growing. It's growing at an annual growth by around 2.7%. And that's not good, because eventually those are going to turn into, are probably five worldwide, with a prevalence of 78%. Men are at around 12 from the top 20 countries, with a prevalence of 75% with high BMI. Now, the more concerning part is the young boys. So, young boys with a BMI that is high are categorized as the fifth after Togo, Samoa, United States, Kuwait, comes Saudi Arabia. Girls are in 12th place. So through what is obesity and the progress of definition. So in the past, we still say this, that it is the gateway to, you can go in from the Lancet Commission, the definition of clinical and preclinical, and she already went through that today. I'll just say that we're trying to start to change that BMI-centric approach. And we have heard from Dr. Nasreen that the BMI is flawed. And I'll just show you some examples of why. And this is one of them, where you can see someone who had a BMI in patient number 2, BMI of 30, but there's no excess body fat and there's no signs and symptoms. And that would be a false diagnosis of obesity. Whereas in the new category, unless there is excess adiposity and clinical signs and symptoms of disease, that it is. Actually, if you have a patient with osteoarthritis, that qualifies as having obesity, because that's manifestation of a disease in a patient with excess adiposity. So don't think it's just diabetes to manifest or a metabolic disease. It could be, if it was to talk about race, body distribution. We kind of had a heated debate just earlier in the session. But this is one of the studies that looked into how the different body masses may differ with regards to adiposity and the regional distribution of fat. at the same BMI, look at age per se. This was a study from the NHANES data looking at the non-Hispanic whites versus other races, and then taking from the non-Hispanic whites the younger and the older generation. So you can see in the older generation of men to your left, they'll have less, let's say, of legs having fat, more centric truncal adiposity, and when you come to look at the body composition, there's much less skeletal muscles, and this is where we need to collect and perform more studies to look into our population and our region. From the NHANES data, taking people at the age of 30 with a BMI of 25 and comparing different races, non-Hispanic whites to the left, non-Hispanic blacks in the middle, and Mexican Americans. So at that BMI of 25, for the same age, you can see that those who are of Mexican American descent will have more adiposity and more visceral adiposity, as I'll show you later, compared to whites and blacks will have the least. They'll have a little more muscle bulk. Now, we have known from a long time ago, and this study was probably more than 10 years back, where it showed through MRI or DEXA for a certain race, and specifically looking at the extreme of Asians compared to whites, someone with a BMI of 27, Japanese American, would have visceral adiposity at a rate of 23.1%, verified by MRI. And if you adjust it with DEXA, it'll be 23.9. So very, very close. Compared to a white person with the same BMI, they would have a visceral adiposity that's around 19%. With DEXA adjustment, will be 18.5. So it just tells you that don't be fooled by the size. It's actually race-centric as well. And that's a parameter that we don't look into, and we should formulate as a call to action from this session. We should start collecting data. Now, in conclusion, BMI is not the best way to move forward. We need to work on our data. Globally, with the new definition of clinical and preclinical obesity, we don't have any data. I tried to get sort of a rough sense of how my clinic shows as far as the people who come to me over the past week. So because I'm probably biased being an endocrinologist, 90% have diabetes, and it was only 1% who was a young adolescent who qualified as being healthy overweight. I think with more mass screening, we'll be able to get better calculations and estimates. Thank you very much, and I'll stop here.
Thank you. Open for questions.
It's my pleasure to present Professor Phil Shower from United Companies Life, Mary Kay and Tara Bound, Chair Professor of Metabolic and Bariatric Surgery at Bennington Biomedical Research Center, Louisiana University, as Director of Metabolic Institute. He is a past president of ASMBS and the founder of Obesity Week. He has performed over than 9,000 metabolic surgeries.
Well, good morning. It's great to be in Hobart at SMBS, or SASMBS rather. And I do want to congratulate Ayed Al-Qatani and Osama and all the organizers for putting on just really a fantastic program. I'm going to talk to you about how I believe that the anti-obesity medications will actually increase metabolic surgery worldwide in the near future. Now, before I get started, let me get a sense from the audience. How many surgeons have noticed in the last year or two a decrease in your surgical volume? Okay, everybody. Okay, all right. Well, it's going to change. We have to just be patient. And I'll tell you why. It's primarily because we have a phenomenal product that we are making that's called metabolic and bariatric surgery. Now, last year, I had the privilege of actually debating a leading endocrinologist at the largest endocrinology meeting in the United States. And the debate topic was comparing surgery versus medical treatment for obesity. I was privileged to debate Dr. Amy Rothberg at the University of Michigan, and we spoke in front of an audience of 3,000 endocrinologists, and they actually voted on which treatment is best for obesity. So I'm going to give you a little bit of a summary of the presentation, at least from the surgical point of view, and if you'd like to read the paper, it's actually just published a few weeks ago in the Journal of Clinical Endocrinology. Okay, first of all, weight loss, which is the primary endpoint of these therapies. This slide compares the weight loss of all the anti-obesity medications, much more effective, reaching weight loss ranges in the 30 to 35, and for some of our operations, like the SADI, duodenal switch, we can even achieve 40% weight loss. Now, the one problem with the medical data is that it is all short-term. It's usually 1 or 2 year data. There's actually no 5-year data on any GLP-1 receptor agonist thus far. Yet for metabolic surgery, we have data that goes beyond 20 years, like this study, the famous SOS study. And notice how remarkable, whether it's gastric bypass or vertical banded gastroplasty, or even gastric banding, which is a defunct operation now, how durable surgery is. Once you have the intervention, the surgical intervention, the physiologic effect will be there for the lifetime of the individual. Whereas with an injectable, the effect will last you 1 week until you inject again and inject again. So this is one of the major advantages of surgery, is the durability. Now, it's not just the SOS data that we have. Well, I want to compare, surgical therapy with some of the current drugs. So this is semaglutide, so 15%, see how that compares. But notice, again, we just have a couple years data. And then with tirzepatide, a couple years data. Now, they're collecting longer-term data, but we don't have much presently. And then we do have semaglutide at up to 4 years, but notice the 4-year data shows 10%, and that was in a cardiovascular outcome trial. So just see how the medical treatment compares to the magnitude of weight loss and the durability of weight loss that we have with surgery, okay? In addition, we have quite a large amount of data showing that the durable weight loss of surgery does equate to major reductions in these major comorbid conditions, including reduction in mortality, reduced cancer, and so on. So surgery is long-term. Now, we have plenty of other studies, so it's not just SOS. There are over 18 studies with greater than 10-year follow-up with gastric bypass. And you can see here at 10 years, about 30% weight loss, which is remarkable, okay? We don't have quite as much for sleeve gastrectomy, a bit above 20%, but 20% at 10 years. 10 years is remarkable. There's no studies for any anti-obesity medication at 10 years, and there's very few at 5 years, okay? Now, what we're seeing with some of these medications is a remarkable reduction in utilization of the medications long term. Here's a study from my previous institution, the Cleveland Clinic, where they looked at over 3,000 patients who started semaglutide or liraglutide, and over a 2-year period, the overall weight loss was 5%, which is quite a bit less than what's reported in the prospective randomized trial, which is about 15%. And the persistent, for those who were on the drug over the entire year, the overall weight loss was more, but not that much more, 5.5%. And 60%, this is the headline, 60% stopped the medication within 1 year. So if you don't use the drug, the effect is not going to be durable. Continuing the drug, the injectable, within 1 or 2 years of starting it. Now, another thing that distinguishes surgery is the ability for our operation. Bariatric surgery can be in patients with a BMI above 70. Most of our patients are in the 40, 50, 60 range. The new GLP-1 receptor agonists have not been tested in this higher BMI group. And even if they are able to achieve that 15% to 20% weight loss in the high BMI group, they still will leave the patient with severe obesity, okay? So how about safety? All of you are aware of the major trends in safety, and this is data from the United States Metabolic and Bariatric Surgery Quality Improvement Program, where it monitors the 800 U.S. sites showing significant reductions in the past 5 years in mortality, in readmissions, in major organ dysfunction, bleeding, infection, and so forth. Safe as a cholecystectomy or a hysterectomy. That's remarkable. Lots of data showing the effects on many, many other comorbid conditions, including reduction in overall mortality and improvements in quality of life. And so far, metabolic surgery is the only weight loss intervention that has been shown to reduce cancer incidence. That's quite remarkable, and can reduce not only fatty liver disease, but the fibrosis associated with fatty liver disease. Now, how about with diabetes? And there's lots of data here. This is from a study that I was involved with that included our Stampede patients and 3 other sites with follow-up of up to 12 years, looking at the hemoglobin A1C between medical and surgical treatment. The surgical treatment is a composite of gastric bypass, sleeve gastrectomy, and even banding, which dilutes the effect quite a bit. And even so, you see the superiority of glycemic control with surgery compared to medical therapy, recognizing that many of these patients, about 40%, were on a GLP-1 receptor agonist. So surgery is still, long-term, the best treatment for type 2 diabetes. And this, I think, is what's most remarkable. This is from a large meta-analysis comparing surgery to medical treatment for patients with obesity, looking at the long-term effect on major cardiovascular events such as atrial fibrillation, heart failure, myocardial infarction, and stroke. And notice here, surgery was associated with an 18% reduction in atrial fibrillation, a 50% reduction in heart failure, 42% reduction in heart attack, and a 36% reduction in stroke. And this exceeds anything we've seen on the medical side. And on top of that, nearly a 50% reduction in overall mortality, which is probably the most important endpoint of therapy. Now that compares with the one cardiovascular outcome trial that we do have for semaglutide. And this was published just about 2 years ago, comparing patients who had placebo versus semaglutide. And while semaglutide did decrease the overall composite risk of cardiovascular death, heart attack, and stroke, it was fairly modest, about a 20% reduction in risk compared to a nearly 50% reduction that we see with metabolic surgery. So a big difference in there. And quickly I'm going to go through quality of life. Here's a big systematic review of quality of life, 18 different studies looking at various measurements of quality of life long term. You know, these are quality of life looking at beyond 10 years, and the most of these studies show very significant not only improvement in quality of life, but quality of life that is sustained beyond 10 years. We don't have that kind of data for the GLP-1 receptor agonists. And this may be the
the most significant attribute of metabolic surgery is that the cost effectiveness.
2 minutes remaining.
Here are 61 studies, okay, showing that metabolic surgery is associated with the cost savings over a lifetime, okay? So let me just get to the conclusion here. Ultimately, metabolic surgery is cheaper than the long-term use of GLP-1 receptor agonists. If you look at it on a year-by-year cost basis, amortizing over 20 years, you see that metabolic surgery is much cheaper on an annual basis than the GLP-1 receptor agonist. This is what I call my obesity medical treatment versus metabolic surgery scorecard. If you look at each of these major outcome categories, and almost all of these, metabolic surgery is superior to medical treatment. Okay, now, who do you think won the debate last year between myself and Dr. Rothberg? Remember, the audience was 99% endocrinologists. Well, these are the 4 categories regarding the quality of weight loss. Metabolic surgery won. Regarding type 2 diabetes remission, metabolic surgery won. Regarding quality of life, this was remarkable. Thought metabolic surgery was superior. So the audience of endocrinologists favored surgery on 3 out of the 4 major categories of assessment. So basically, metabolic surgery won the debate in the endocrinologist's mind. So we're pretty happy about that. So what does this mean for us in the future? I think the future is very bright. What I think is going to happen is millions of more people are going to be seeking treatment for obesity. And while many may start with anti-obesity medications, for many, they will not be satisfied because of either the side effects, the cost, lack of adequate efficacy, or durability. So I do think that the future of metabolic surgery is very bright, and we're going to see in the next few years a rebound and a...
Thank you, Dr. The floor is open for a question. Yes, Prof.
Yeah. Hi. Phil, thank you very much for wonderful. You almost answered my question with the last 3 slides you showed me. But how do you explain with all this knowledge the drop in number of patients referred to obesity surgery at this? Do you think it's a transient period, or is it something that's going to change, or it's going to continue? And what factors affect the patient's shift to medication? We know since the time of starting of obesity surgery that medications only help in so little and for a short period of time.
Okay, thank you, Wally. I think your question is, how do we explain the recent downturn, right, in demand for surgery? Well, I mean, let's face it, these drugs are amazing. We never had effective pharmacotherapy for weight loss until the last 3 to 4 years. The initial results of the drugs are quite good, and there's massive advertising. You turn on the TV in the United States and up pops an Ozempic or a Mounjaro advertisement, whereas it's impossible to advertise surgery in the same way. So there's a mass media effect. But I think many of us in the audience can probably begin to see some of the limitations of the medications. And we're already seeing in publications a fairly high rate of discontinuing the medication after starting for a variety of reasons. The side effects, the cost, perhaps the patients are not satisfied with the amount of weight loss. So what I'm saying is right now we're in this honeymoon period with these new miraculous drugs, but they're not perfect, and no marriage is perfect, right? We're recognizing some of the warts of the medication, and I think we're going to see surgery is going to rebound, but it's going to take probably a little bit longer to see that happen. Does that answer your question, Waleed? Okay, great.
Phil, can I, just 1 second, I just want to give you my own data, and I support your numbers. First of all, COVID hit. Then after COVID, we had a surge because many patients were not done in 21. So that volume, if you compare to it, in 23, in the US, the drop was 42% between 22 and 23 in volume in bariatric surgery. But that was not solely because of the introduction of medication. I think that was because of the peak in the 22 year, in the year 2022. For us, it's the same. We had a peak in 2022, so we thought this will last. It didn't last. In 2023, we dropped. But in support of your conclusion, I will give you an example. In the US, since laparoscopy bariatric surgery started, until 2022, 2.2 million cases were done, roughly. And in 1 month, in 2023, quarter four, there were 2.2 million prescriptions of GLP-1 or the dual agent, not naming them. So those 2.2 million will continue the medication for a while, but then there will be a lot of people who will drop and come to us in surgery. I see it this year, just like you said.
Yeah.
I see now new patients coming to me that I would not have seen before. And when you talk to them, almost all of them have tried the medication, didn't work with them, and there are patients who tried it and it worked with them. But majority could not do it because of funding or cost. So I think maybe there is the risk, if the prices drop, maybe we'll have another hit. But until the prices drop, I think we're safe in getting our volume back. That's my opinion. I don't know if you support it.
Yeah, I agree. The cost is a big factor, but it's not just the cost, though. There are other factors, too. Any medication, there's never 100% compliance with any medication, and that's one of the limitations. The beauty of surgery is once that intervention occurs, you have that physiologic effect in place for the lifetime of the patient. Helmuth. I don't think your mic's on.
Sorry about that. I'm a better surgeon than I am electrician. I completely agree with you. I think 80% of my current volume have been on GLP-1s. And there aren't any good studies, but you brilliantly showed us what the 5-year outcomes are and the sustained effect we can currently see with our current procedures. I'm wondering where you think surgeons should fit in utilizing GLP-1s, probably oral medications as they come through, in giving us even better results, because I can't think of a better group to work with the future on how to augment our results with judicious use of these medications in a wise way, but there's no studies.
You're right, Helmuth, and we do need to look at these studies, but I think, we surgeons should embrace these wonderful agents, the GLP-1 receptor agonists, and all the subsequent therapies that are coming or in the pipeline. We should use them pre-op. I think in our higher risk, higher BMI patients, we need data to support that use, but I think you can make a good case right now in your higher risk patients. And we should figure out how to use them post-op, particularly in those patients who do not have the expected weight loss, or folks that have weight, regain. And that's a whole new frontier for us to explore, how to use those, what dose, the timing of it. This is a whole new frontier for our field. Embrace the agents, yeah.
Thank you, Dr. Shower. Thank you, Dr. Shower, for this excellent presentation. How do you think this setback or pause in, let's say, in bariatric surgery would negatively impact training, research, innovation in bariatric surgery? And for how long?
Yeah, so that's a great question. So how will this pause or dip in volume affect training, surgical training, right? Yeah. Well, it's not the first time. There have been dips, and many other specialties have had dips, in volume. Cardiac surgery went through a period where it dropped but came back. So I think we have to just be creative. Hopefully this will be a short-term, period. And just, give our trainees the best opportunity we can. Sometimes it's, maybe having more than one trainee scrub on a case so that they all can get the experience. But I think the answer will be that we will come out of this relatively soon, and there may be some programs that are struggling with their volume that may have to shut down for a while, right? So that we don't get to a volume that's so low that's inadequate for training. And that's what we're seeing. Some programs may have 3 or 4 fellows that may have to drop down to 1 or 2 fellows. Yeah.
Thank you, Prof. Thank you very much.
Thank you very much.
Sorry for cutting the questions. We are tight with time. So may I introduce Professor Mario Musella. Please, Mario. Thank you.
Okay, thank you once again, Dr. Azama, Dr. Sultan, for this invitation, this outstanding meeting and amazing hospitality. So, who won in Europe comparing the surgical activity versus the medications, things we were discussing so far? And well, I'll skip through. Well, among my disclosures, I have to say probably the most important is that I am a surgeon, so this is my point of view as a surgeon, and this will recall a little probably what Dr. Schauer has just told us. These are the very recent indication for bariatric and metabolic surgery issued by the IFSO. And well, if we consider which is going to be the battlefield in which surgeons versus physicians probably will fight in the next years, possibly it is between 30 and 40 BMI, or better, 30 and 35 BMI. I mean, that group of patients in which so far the metabolic surgery has had a great part. So do we have we found any change between the old recommendation and the very most recent recommendation from IFSO? Well, possibly yes, possibly no, but these are the clear recommendations that surgeons have done, have released for surgery. And if you see, there is a room for people between 30 and 35, also for people between 35 and 40. So let's have a look which are the numbers we're talking about, because this is an epidemic, of course. This is the World Obesity Atlas, and as you can see easily, obese people are going to increase, and morbid obese as well. And in the next future, it is going to be, the number is going to increase dramatically. And this has been released by the IFSO Registry Committee, and this is a paper in which are described the number of patients operated in different chapters of IFSO. I had the pleasure to be part of this group of authors. And why surgery, conversely, in my opinion, is expected to say it remain. Let's have a look of comparative effectiveness studies regarding the metabolic effects and historical treatment evolution. And of course, what is the pharmaceutical analysis of any companies that is involved in this new wave, in this new offered by the surgical studies, I would say. The SOS studies, you know, we know perfectly, is a study spanning over 20 years, and it's still going on. So this is the it's very important to define these about the length of a study that is, of course, focused on surgical patients with all the advantages that surgery can bring to this group of patients. And again, this is the Association of Metabolic Surgery with Long-Term Survival. These are all studies spanning for a very large period of time, 10 years in these cases. Also another studies, interesting, recalling us the great advantages we have found in a wide number of years, large number of years, about a cardiovascular impact or cholesterol quality of life. That is important. Again, 5 years outcomes, regarding different procedures, 10 years follow-up with other procedures, and very good results with bariatric and metabolic surgery in this case. And let's have a look if we have some comparative studies between surgery and medications. And at this stage, I would like to recall to your attention about possibly the difference of scales. I've authored some papers. I've read many papers and reviewed the other papers, and we surgeons normally use the excess weight loss rate to define the advantages that surgery can bring. Now we are dealing with a total weight loss rate. That is different concept, but of course it's still valid, but we have to talk the same language. And well, this is our results, as in this case semaglutide can bring the advantage of the liraglutide in this case, and this is tirzepatide, as you can see, possibly the best medication we have. We have results we have found with tirzepatide published in the evidence published, and this is interesting because if we take a look, very good results, even 20% weight loss. But if we go to see the results in terms of real life, the music changes, because sometimes in trials we have free medications, the patients are very well followed. In real life, things changes because of the surgery, and this other paper is recalling us how in the end, sleeve gastrectomy or gastric banding that are considered restorative procedures, so not as effective. But we are comparing weeks in terms of medication versus years in terms of surgery. And we have to remember that top efficacy of medication at this moment is limited to the 40% of all enrolled patients in the trials that have been published. We need the top dosage to have a good results. And of course, these patients should take medication, but they should complain with they should be compliant with a strict dietary and behavioral management. And so let's have a very quick look to the medication side effects. We have side effects. Well, oh, yes, we have, but we will go fast between these because well, they're very known and very well described in a lot of trials. Basically nausea and sometimes diarrhea, abdominal pain, but they are still present in up to 1/4 of 25% of all our patients that have been enrolled in these trials. And this is interesting. This is what I was commenting before, that in real life we have found different results from therapy, abandoned the study and basically providing worse results if compared with the results we have seen in many trials published so far. A quick look to the economic analysis. This is what has been recalled by Dr. Schauer a few slides ago. Surgery is more rentable so far. It's more rentable worldwide, but it is more rentable, especially if we take a look of some countries like Italy. In Italy, surgery is for free. I mean, if you go in a public hospital, Italy is full of public institutions, university, hospitals. Of course, they have to wait a waiting list, but surgery is for free. Conversely, they have to pay by their pockets all medication that have been. Also, I must admit I'm quite naive. I thought that all the companies that normally work with us surgeons, I see Medtronic or J&J, were the top on the market. But if we go to capitalization of some companies as Novo Nordisk or Lilly, is very much higher than and level of education to our students or to our residents, but we must recognize that sometimes we have to feel some economic pressure from these companies. And I'm coming to conclusions. Possibly, can we find a sort of compromise or a form of correct utility surgery and medications? Probably we should remind what has happened with surgical oncology. In the late 60s, early 70s, for example, for breast cancer, a very aggressive surgery was used as the Alstead procedure. Later on, where the health measures, the surgery has reduced it as much less aggressive. So possibly the multimodal approach is possibly the way we should meet the utilization of the medications and surgery. And this is interesting about using possibly in weight regain, as I was commenting, or before surgery medications. And this is a systematic review, also recalling us that the optimizing weight loss post-bariatric surgery, the use of medication, and possibly it's time to rethink the approach to treating obesity, considering a wide approach that it is not only surgical, but even considering these drugs, but not as an alternative, but as a something that is at our side, is an allied care to treat our patients. So in conclusion, first, remember we sometimes read of different scales. Excess weight loss is not total weight loss, but also the adherence to follow up. The trials results are not the results in real life. These medications, the media suggestion that this is important, this is very strong, especially considering what I was commenting about so far at least, and the synergic action that we can find, we can meet, and we should look forward between medication and surgery. Thank you so much. Thank you.
Thank you, Prof. Thank you. Okay. Seems no questions here today. Thank you, Prof. Thank you for the.
It's okay.
Regarding the cost, the table of cost of medications, is that per month, per course, per week? How much?
That was per year.
The next talk supposedly to me, but I elected to choose one of our best trainee resident, Dr. Arwa Ibrahim. She's an R5 senior resident in our institute in King Fahd Hospital of the university. She's gonna give us a brilliant talk about suboptimal initial weight loss.
Thank you, doctor, for representing me and giving me the chance to. Thank you for representing me and giving me the chance to talk today. So today we'll be talking about does suboptimal initial weight loss post-obesity medication versus metabolic and bariatric surgery in class 2 matter. So as it's well giving a review of the previously published literature and highlighting the definition of suboptimal weight loss, including all literature review. So as we all know that since 1991 and after the NIH general consensus statement, metabolic and bariatric surgery have been indicated for patients with class 3 obesity, patients with class 2 with medical management. So in 2022, both EFSU and ASMBS have set a major update of this guideline by indicating metabolic and bariatric surgery for patients with BMI of 35 and more, regardless presence, absence, or severity of comorbidities, as well as to be considered an individual with 35 to 30 BMI who does not achieve substantial or durable weight loss using non-surgical method. And as well as the long-term result of metabolic and bariatric surgery consistently demonstrate a safety and efficacy. And actually, after this guideline, still some physicians are stick to the previous guideline with unwillingness of legislator to follow the new guideline, either due to the lack of knowledge about the guideline or due to a financial issue. So if we have a look about the long-term effect and the durability of surgical management, we have a different study and well studied previously with 10-year follow-up, like what's been reported by Matthew and colleagues, showing that patient with Roux-en-Y gastric bypass reach loss of their baseline weights estimated 30 to 75% and 28.6% at 10-year follow-up respectively. And for 30% or more greater weight loss at 10-year duration was maintained in almost 39.7% of the patient undergoing Roux-en-Y gastric bypass. And if we have a look to another study, which is a sleeve pass trial, also it showed a main excess weight loss was 43 after sleeve gastrectomy, and 51 bariatric surgery and 10-year follow-up show a major and substantial weight loss. So what we could consider, or how can define the suboptimal weight loss? Although difficult to define the suboptimal weight loss post-bariatric surgery, after EFSU and ASMBS agreement, we could consider 20% weight loss of initial weight or less is considered a suboptimal loss. Yet the surgery success is judged by initial intended goal, whether it's weight loss or comorbidity control. And when we have the concept of metabolic and bariatric surgery, it's including both the metabolic cure and weight reduction. Although the former indication, which is a metabolic cure, is underutilized in our society. So access of patients with BMI of 37, otherwise no other medical illnesses, is much easier than a patient with uncontrolled diabetes with BMI of 31. On the other hand, with the recent evolution of medical management and emergence of the GLP-1 agonist medication, we have several trials that assess the weight reduction. So we have the scale trial where they used liraglutide, and in the scale 1, they follow the patient for 1 year follow-up, showing a patient of 5, 10 and more, 15 and more weight loss was achieved in 36, 33 and 14% respectively. And in scale 2 trial, they compared between 2 different dosage of the medication. Again, it showed a weight loss, but it's, as you can see, it's a bit dose dependent. Another trial, which is a step trial, when they use semaglutide as an intervention for a patient. In step 1, they use it over a non-diabetic obese patient, and they compare. And the step 2, they compare different dosage in diabetic patient with obesity. And again, it showed a weight loss, but as you can see, the percentage of patients who reach up to 15 or more is much less than patients who reach 5% of their weight loss. Next, we have the SARMANT trial, the emergence of trizepatide, which is a GLP-1 agonist as well as GIP. The SARMANT trial, it has four trials. The first one, when they use it over obese patients with different dosage and compared the outcome. And when they for the SARMANT 2, they included obese patient, diabetic patient. And the SARMANT 3, they started the lifestyle intervention first, prior giving a patient the trizepatide, followed by assessment of their weight loss. So in all of the studies, you can see there is a secondary results they came out with, which is a more than 20% of weight loss in the patient. And interestingly, the amount of patients who reach to this more than 20% is much less than patients who reach 5 and 10%. This either due to withdraw from the study due to inefficacy of the medication, or due to the side effect of the medication, which mainly gastrointestinal symptoms. So although trial participants experienced weight loss, it's important to notice the following. Weight loss was a dose dependent, more loss with a higher dose, and all medication associated with side effects such as gastrointestinal symptoms, which with some degree led patients to withdraw from the study, and in the 1 up to 4 years follow-up, and the recurrent weight gain after stopping the medication that was approved by SARMANT 4 trial, that necessitates patients to continue on maintenance dose of trizepatide to maintain the weight reduction. All this remained an issue that interfered with optimal weight reduction. So what can we define the suboptimal weight loss for anti-obesity medication? According to what's shown in the study, we could consider that 15% of initial weight loss or less in semaglutide and 20% weight loss is no longer acceptable for a patient with BMI of 35 and more. And patients prior starting this medication, they need to understand the substantial weight loss, which is more than 20%, have not been achieved by a majority of the patients. So for the time being, till the approval of patient, the weight to consider for surgery is the weight prior starting medication. Patient with the class 2 obesity should not be offered a medical management because it will affect, it will delay them from receiving surgery in time. As a clinical versus subclinical, the report stress not to use BMI as inclusion or exclusion for treatment, but screening for obesity at society level. So all of this evidence, obesity and obesity-related comorbidity, and avoid delaying excluding patient from receiving surgery in a timely manner by giving them a medical management. Thank you.
Any question, please? Okay, Arwa, thank you very much. Okay, Arwa, please.
So I'm just going to ask about, first of all, thank you for completing all the data. And I just, so your conclusion said that for class 2 obesity, you build pharmacotherapy.
Yes.
And is this an all or none? Are you saying everyone, or are you saying patients with type 2 diabetes?
Actually, our justification for saying that's patients when they receive, going with the previous guideline, when they use 40 BMI is indicated for surgery, 35 with comorbidity are indicated for surgery. Still, the majority and the insurance company, they are not following the recent guideline, which is 35 or...
treatments which will, where it's okay for the patient to come out of the surgical numbers of BMIs, because then I'm putting their obesity into remission. So if I total body weight loss, then I have saved that patient from undergoing surgery with class 2, and they don't need to meet the criteria for surgery then, because they probably won't need surgery anymore.
This is why I suggest when the patient fail to reach this, and for the trizeptide is 20%. So if patient...
So the maximum. So
yes.
That means that if I equate it to surgery, then failure of sleeve gastrectomy, which if you don't lose 25%, that's a failure.
If the patient started on this medication and he's out of the zone for the surgery, but the weight loss is only 20%, he's supposed...
Now we are to listen to Abdurrahman Nimeri. Where was recurrent weight gain.
أسامة الصانع, Abdullah Al-Ghamdi, Al-Garzawi, and Tumyat on a very successful Congress. So I was asked to speak about recurrent weight gain. This is my disclosure slide. Has no relevance to the presentation. So I'm going to speak about like failure and avoiding the stigma. When should we offer patients revision, and what's our current practice when someone comes back with recurrent weight gain? I will spend most of my 10 minutes in this part, and then briefly talk about options for different patients. So this is an IFSO consensus definition, and in it clearly states that suboptimal clinical response is rarely because of substandard clinical skill or patient non-compliance, and I'll just try to prove that point to you. So this is the randomized trial SASMBS study. You can see that the total weight loss after Roux-en-Y gastric bypass is 34%. But if you look at the variability within the treatment groups, it's between 12% and 56%. So within the trial, sleeve patients and bypass patients have significant variability. And it's the same for medications. This is the step 10 randomized trial, and even though 14% weight loss in the semaglutide versus 2% in placebo, if you look in the left lower corner, there is quite a bit of variability in the semaglutide group for weight loss, quite a bit of variability in the group that had placebo. And even when you look at recurrent weight gain after bariatric surgery, this is the very optimized study, and if you look at placebo, 0%, liraglutide, the very old medication, 8% weight loss, within the groups, in the liraglutide group, some 8%. So really, when someone comes back with suboptimal weight loss or recurrent weight gain, it's rarely because of the procedure of the patient, but rather the biology. But let me just, for instance, take an example of Roux-en-Y gastric bypass, what for years has been considered a dead end when someone comes back with recurrent weight gain. So let's look at what could explain the variability. This is a position statement or a review that I helped write for SASMBS, biliopancreatic limb, which correlates with less weight loss and less diabetes resolution. And international surgeons make a longer biliopancreatic limb. In the same review, we reviewed all the literature on biliopancreatic limb length, and it clearly shows that the longer your biliopancreatic limb, the more weight loss you have, the more diabetes resolution. So the variability could be because of the technique of surgeons. Now, not only that, if you add to it that the small bowel is variable, all surgeons, including myself, leave the OR not knowing the patient's comment. The way people measure the small bowel is variable. We know that visual measurement is inaccurate. You need to measure with an umbilical tape or with an instrument. And in animal studies, it's been shown that, to just measure, you could have variability. And in a survey, only 18% of surgeons actually measured the small bowel. So this is a second reason that could explain the variability in outcomes. A third reason is that because of the small bowel variability, surgeons who do Roux-en-Y on the left or one anastomosis do not know the common channel and the total elementary limb length. And surgeons who do SADI and DS on the right do not know the biliopancreatic limb. So patient's variability could be because we are doing different procedures. Let me explain that point one more time, and I'll give you an example. So if you make the same limb length in your patients have variable limb length at the end of surgery because of the variability of small bowel. So let me prove that point to you. Let's take a Roux-en-Y gastric bypass patient, and we'll take 3 assumptions. Your first patient has 700 centimeters of small bowel, so their common channel, if you make a BP limb of 50 and a Roux limb of 100, is 550, and the total elementary limb length is 650. Your next patient, on the same day, you did the same procedure, could have 900 centimeters of bowel, their total elementary limb length is 850. They'll have different outcomes. The third patient, you do the same procedure, but they're inaccurately, but because of the variability of small bowel length. So, and there is a systematic review, at least a couple of them, to show that not only the limb length is important, but your pouch size is important. The larger your pouch, the more chance you'll have measured. And the Scandinavians, I think, are the best because they showed that you measure the pouch by the number of cartridges you use to make the pouch. So you need to make sure that at least the way they describe it, you use at least less than 3 cartridges to make your pouch. I mean, some surgeons even use 2 cartridges. And it's important to make sure that you take the redundancy of the fundus out by putting a tube. So not only the limb length, so all these changes and variabilities could explain why some patients have recurrent weight gain. So when should you revise? There's a long list of things you have to look at. What's the risk status of the patient? What's their BMI now? Did they lose 10%? What was their BMI before? What are their objectives? Do they have reflux? Do they have dysphagia? How compliant they are? So these are all things to consider before you decide when to revise patients. You need to do an extensive workup. Most patients need an endoscopy. They also need upper GI studies, but also evaluation by the multidisciplinary team. So in terms of recurrent weight gain, this is a study we did looking at 400 patients who came back to our clinics after being lost for follow-up over a 4-year period. Only 5% of these patients came with no problems. So patients with no problems never came back. The patients who came back either had recurrent weight gain or had a symptom. And reflux was the most common after sleeve, pain after bypass, vomiting and dysphagia after gastric banding. And when we looked at patients, Roux-en-Y gastric bypass patients had the best weight loss of the 3 groups. and they had the least recurrent weight gain of the three groups. Now, what's interesting is most patients who had Roux-en-Y gastric bypass needed either endoscopic treatment or medications. They rarely needed another procedure. But most patients who came back with either a sleeve gastrectomy before or gastric banding, they needed conversion surgery, either to gastric bypass or to another procedure. And what's also interesting is that we found the anti-obesity medications, GLP-1. So again, only 5% of patients came back and they had absolutely no symptoms. Gastric bypass patients had the best weight loss, least weight gain. And most patients who came with recurrent weight gain and reflux were after sleeve, pain were after bypass, or dysphagia were after gastric banding. And the medications were the most effective after Roux-en-Y gastric bypass. So this is a study we did to look at semaglutide and the reason was mostly insurance. And then if you look at the group that took it for less than a year or the group that took it for more than a year, their weight loss was not like the randomized trials, 13 to 15%. Similar to what Professor Schauer mentioned, they only lost 9 to 10%. Better than 5% that he described, but still only 9 to 10%. What's also interesting is if the patient had a gastric bypass, they lost the most amount of weight. Patients after gastric bypass lost 13% of their weight compared to 9 to 10% if they either took it for less than a year or over a year. Then we also looked at, how is it if someone had a sleeve gastrectomy? So we matched 167 patients who had a sleeve and were converted to bypass to another 167 who just received semaglutide.
2 minutes remaining.
Yes, thank you. And we found that the weight loss initially was better for the bypass, but lost significance at 2 years. And what's important is that the complication rate was much higher after conversion to gastric bypass compared to obviously just getting medications. So even though the weight loss had a trend of being better after bypass, but not by a significant much. Now, who gets these medications? Mostly patients who are white, non-Hispanic, upper middle class, or have private insurance. If you are African American or have public insurance, it is less likely in our practice that you will receive these effective medications. And this is an important recent report similar to what Phil has shown that shows that patients after taking these medications because of either cost, inequities in access, or risk of side effects, many of them stop the medication. So these medications are not a panacea and not all patients continue on them. So I think the last point I want to comment on is this is an important recent IFSO position statement that reviewed recurrent weight gain and treatment in a very extensive fashion that came about last July. So I think I recommend you look at it. But for instance, when you look at Roux-en-Y gastric bypass used with endoscopic outlet reduction showing 8% total weight loss. I think in the future with semaglutide and tirzepatide, most of these patients will, rather than get endoscopic option, will probably get medications. As I told you earlier, if you lengthen the biliopancreatic limb, you'll have more weight loss. So patients after Roux-en-Y gastric bypass, one option is to do distalization. And it's not actually the short common channel and different BP limb. And the patients with the studies with the longer BP limb had more weight loss. So patients don't lose weight through malnutrition. It's not the common channel. It's actually the length of the biliopancreatic limb. So type 1 distalization is something we do for our patients, and it's been very well described, so I'm not going to spend a lot of time in it. What's important is you divide the roux limb and then move it, and typically connect it 300 centimeters from the common channel, from the ileocecal valve, but as long as your patient has 6 to 7 meters of bowel. If you have a patient with 10 meters of bowel, that 300 might not be enough. You might want to do percentages, maybe do the BP limb around a third, just because there's not enough literature. But this 100, 300 is appropriate when your bowel is 6 to 7 meters. Now, this is the entire series of distalization that's published in the literature, most of them. And if you make 50 centimeter common channel, 100% protein calorie malnutrition, done by Sugarman, 150, 40%. And there are some groups that reach 0%. So they're clearly a sweet spot. And what's important is to recognize that sweet spot. If someone has malnutrition, you don't need to reverse them. You need to move the roux limb back after giving them TPN. So an important other thing to mention is you could convert gastric bypass to duodenal switch, and it's very effective. But I want to show you, this is the largest series of, first I'll show you the conversion. This is the largest series of conversion of Roux-en-Y gastric bypass to DS from Philippe Topard's group. They did it in one stage in 93% of patients, and patients had a good amount of weight loss, but again, significant morbidity. But I want to show you that if you look at other studies, you know, most surgeons cannot do it in one stage. Bypass conversion to DS should be taken very, very lightly. What I do is I take them first and convert them to a sleeve and reconnect the Roux-en-Y and make sure that they don't have reflux, don't have issues, and then at the second stage might convert them. So the last two things I wanted to show you is if someone has a sleeve gastrectomy, this is a very recent study from the Michigan Collaborative looking at more than 2,000 patients. Some had reflux, some had recurrent weight gain, and they did GERD, quality of life questionnaires 1 year after surgery. And I think what's important is, contrary to what's described in the literature, they could show that patients could lose 24% total weight loss. This is also my experience. I think what's most important is that you explore the hiatus and you make sure your pouch is the same pouch size that you do in a primary case. If you don't explore the hiatus, you leave a large pouch, you might have inferior outcomes. And the second thing is, if the patient doesn't have reflux, there's a large study from the Netherlands, 140 patient limb, and again showing that Saudi is much better. So if the person's main goal is weight loss, maybe a Saudi or DS after sleeve is better. If their main goal is reflux control, maybe conversion to bypass is better. So I think in conclusion, recurrent weight gain is typically not due to poor surgical technique. Sometimes it is, and it's very rarely because of patient non-compliance. Sometimes it is. You need to look at the patient's conversion after Roux-en-Y gastric bypass. Primarily in our practice is actually medications, the new GLP-1 receptor agonists. We use endoscopic total outflow reduction less, and in patients who don't succeed with that or cannot access it, we use them a third. And I think finally, if someone has a sleeve gastrectomy, if their main issue is reflux, conversion to bypass. If their main issue is weight, conversion to Saudi or DS. Thank you very much.
Thank you, Abdurrahman. Because of time, and I think we have to move to the next speaker, please.
Okay.
Thank you. Listening to his talk and learning from him again today.
Thank you. Thanks, Nasrin, for the introduction. Thanks for the organizer for having me. I'm going to briefly talk about metabolic surgery for MASH. Here's my disclosure about the MASH, which stands for Metabolic Dysfunction Associated Steatohepatitis. So formerly, this disease is known as NASH. The new name is MASH. So this is basically liver manifestation of metabolic disease, and it's strongly linked with cardiovascular disease. Obesity is the main driver of the disease. When we have obesity, fat infiltrates everywhere, including into the liver, and that over time can damage the liver. Inflammation comes, then scar tissue forms. This is called MASH. Diagnosis and management are challenging. There was no medication, approved medication for this disease until recently that FDA approved Resdifra as the first treatment. Or semaglutide are expensive, but Resdifra, the cost of 1 year supply of Resdifra in the United States is about $50,000, 50. Patient need to take a pill a day, $50,000. So, but no therapy has been. So even Resdifra, we have a repeat liver biopsy that can improve liver fibrosis in 15-20% of the patients, but we don't know about the clinical outcomes, if that can progress. So in terms of pathophysiology, just briefly, as I said, fat infiltrates into the liver tissue forms. It's going to build up over the years. So we have no fibrosis in the beginning, then F1 takes about 5, 6, 7 years. So it's a chronic, slowly progressive disease. From normal liver to cirrhosis, it may take stages actually. One is compensated cirrhosis, that patient don't have any symptoms. They may have, they do further tests and the cirrhosis is diagnosed. But patients usually don't have any symptoms of the cirrhosis, like ascites, esophageal varices and bleeding, or encephalopathy. So they get sicker and sicker, and then they may die. In that course, they may develop liver cancer, hepatocellular carcinoma. So, and then had repeat liver biopsy before and after, I mean baseline and then after bariatric surgery. And then we had a control group and about 91 non-surgical controls. So on the third set of the graph, you see that in repeat liver biopsy, about 2/3 of patients who had bariatric surgery had at the second set of the graph. About, again, 68% surgical group, 22% in the non-surgical group had complete resolution of MASH in their repeat liver biopsy. And if you look at the both process improvements, half of the surgical patients experienced complete resolution of their MASH and fibrosis improvement versus about 12% in this non-surgical improvement of the liver histopathology. So here's the BRAVES randomized clinical trial published in Lancet a few years ago from Italy about enrollment. And as you see here, MASH resolution and fibrosis improvement was significantly better after metabolic surgery compared to they don't understand that. So they don't want to have the symptoms of the disease. So let's look at the clinical outcomes. So in the SPLENDOR study, which was published in liver fibrosis, F1, F2, and F3. So we excluded people with F0 and people with F4, which was cirrhosis. Control group of Cleveland Clinic patients, over 500 patients who just received the usual care for their MASH and endpoint of this study. So we had two endpoints. One was progression to cirrhosis, or which was called transplant or liver-related mortality, all the bad things that can happen to the liver. And then we had also MACE, which was major adverse cardiovascular event. So here's baseline characteristics, exactly balanced between the two groups. More weight, they had better diabetes control over the course of 10 years. Just look at the gap between the curves. Years. In the surgical group, only 2% developed one of those bad liver by 88%. So you see the widening of the curve and how clearly surgery could change the trajectory of that risk by 70%. So here's us who had cirrhosis at the baseline. So in SPLENDOR, they have symptoms of that. And then we looked at progression to decompensation or dying from the liver disease. So we wanted to see, so again, we had 62 patients in the surgical group, 60% of them had gastric bypass, 40 had a sleeve gastric. And here is the mallow, which was defined as progression to decompensated stage, need for liver transplant to the liver occurring 20% in the surgical patient versus almost 50% in the control group. Surgery could lower the risk of mallow in people with cirrhosis and compensated disease by 72%. So that's the other outcome of the study, progression from compensated to decompensated. Decompensated was defined as development of surgical patient lost more weight, they had better diabetes control. So to summarize, indications of bariatric surgery in people with MASH surgery can change the trajectory of the disease and help those people. If patient has cirrhosis at the baseline, that cirrhosis needs to be compensated, and patient shouldn't have portal hypertension. So again, this is the progression of the disease from normal liver to fat infiltration, inflammation, and then fibrosis, and then cirrhosis, compensated, decompensated, and dying. So we have to intervene and change the trajectory of the disease. If people have compensated cirrhosis, we need to rule out portal hypertension before surgery. So like people, if their platelet count is low, or if the fibroscan shows the stiffness of greater than 20 kilopascal, or if you have a liver biopsy showing. In Cleveland Clinic, we do an upper endoscopy, liver vascular ultrasound to make sure that the patient doesn't have portal hypertension in people with cirrhosis. And if they do, then we ask our interventional radiologists to place the tips. They get endoscopy, we do repeat the liver vascular ultrasound to confirm that the portal hypertension is gone, and then we take the patient to the OR. If you take this patient to the OR and try to do the sleeve, then it's going to cause profuse bleeding and the patient going to die on the table. So we send the patient to the IR, they place the tapes, they lower the sleeve gastrectomy. So another patient who had portal hypertensive gastropathy, PHG before and after, so we place the tapes, that's lower the portal pressure. Yeah, I get it. So in decompensated cirrhosis, if they have ascites, encephalopathy, bleeding. So median survival time in these people, that can be an option to do it simultaneously, but this is a contraindication. So we need to intervene before people getting to decompensated stage. The patient MELD score is above 15. Those patients are usually sicker patients, are very close to get the trend. In terms of the procedure selection, with MASH and F0 to F3, our procedures would be good choices. If they have compensated F4, maybe a sleeve would be a better choice because in future some need to have access to the biliary tree. They may need multiple ERCPs, instrumentation with the sleeve anatomy. That would be more easier or feasible. So in conclusion, F1, F2, F3, and if they have F4, they need to be compensated, which can lead to MASH resolution in about 50% of the patients, and lowering the risk of MACE and MALO in about 70% of the patients, regardless of the stage of the disease. We need to rule out portal hypertension in patients with suspected cirrhosis before metabolic surgery, and if patient has that, we need to consider TIPS placement. So we are doing surgery versus the GLP-1 for liver fibrosis. So we have enrolled 15 patients from 22 sites around the world. We have with advanced fibrosis, randomize them, so 120 patients, randomize them to surgery versus GLP-1s. We're going to do repeat liver biopsy after 2 years. So that's, thank you very much.
We'll have two questions, Dr. Tamer.
Short.
Dr. Osama.
Sorry, short of biopsy, what would you recommend to follow these patients?
If we do the liver biopsy at the time of the surgery, or we have the biopsy before surgery, when we do the surgery, if the biopsy shows that they have advanced fibrosis, so we send them to the liver, to our hepatologist. So in the hepatology, we don't send them right away. So we ask them a year after surgery, go and see a hepatologist. And they go and see, and then hepatologists do the test. Sometimes, most of the time, they don't do the repeat liver biopsy. They just follow them with the FibroScan or the MRI and non-invasive tests. The best treatment for that is metabolic surgery. So the surgery, I trust the FibroScan. Sometimes people are big because, and they're up, which is very convenient. It's not that, although it's MRI, but it's not that expensive.
Thank you. I have a question. During intraoperative, while you took the patient for intraoperative finding, you find a very nodular liver, cirrhotic and macroscopic, but you didn't have still a diagnosis. You will proceed, or you will, for any bariatric surgery, suppose sleeve or bypass surgery. And intraoperatively, you find a very nodular liver, cirrhotic liver, macroscopic, but still I didn't have biopsy or further investigation.
Going to the OR, but if we don't have any idea and we get there and we see that there is a cirrhotic liver or cirrhotic appearance liver, obviously we're going to do liver biopsy and we're going to proceed. Unless we see the sign of portal hypertension, don't proceed. Or if the patient has ascites, we don't proceed. But if there is no ascites, if there is no enlarged vessels, no portal hypertension, regardless of the shape of the liver, we're going to proceed.
But maybe difficult to assess the liver disease at that stage. We'll not worry about decompensation later on because it's
no. Patient selection is important. So we need to make sure that the patients, the alcohol use is not an issue here, but the alcohol is an issue in the United States. So we need to make sure that, and we know that alcohol toxicity or alcohol dependence issue can increase after bariatric surgery. So that's the issue that can damage the liver.
This is what happened. I have a phase 1 patient once. He did not mention about alcoholic. When I went inside, I thought we did the biopsy, and later on
that can be an issue because alcohol. If the patient, especially if the patient, we want them to be off the alcohol for at least a year, 2 years before bariatric surgery. That's our protocol. But some of the concert. So but again, that goes to a good patient selection.
Thank you.
But just seeing the cirrhotic liver during the OR at the time of the surgery, Phil.
Ali, great work as usual. So what do we know
know about the effect of GLP-1 receptor agonists, the current ones, on advanced fibrosis, and what do you think?
Yeah, so the things that we know about the GLP-1s, there is no GLP-1, all the effect that we get from the GLP-1s on the liver is our indirect effect, metabolic effect, weight reduction effect. So that's one thing. So the data that are in the special studies, because we need a long-term follow-up to look at the clinical outcome. We need 10 years, 15 years. So we don't have those type of data for the GLP-1s. The thing that we have are repeat liver biopsies. So phase 2 clinical trial, they more to 50% reduction in people who had F1, F2, and F3. So in people with F4 or cirrhosis, there is improvement in fibrosis or inflammation in people with F4. But for F2 prototype, all three had improvement in histopathology between 30–40% of the patients. Thank you.
It's my pleasure to hospital, and he's associate professor at the Najran University, and he's the acting president for Najran University and vice president for the best postgraduate and research.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you everybody who was behind this organization, and I hope inshallah I will be very fast, as my name Saeed, the surgeon in the hall. They are doing surgery for diabetic patient BMI below 30 or 32. Below 30. Dr. Walid, Prof. Okay, very few. Okay, let me talk my story. Going home at the 5 p.m., I just crossed the emergency department. I want to check my blood pressure and blood sugar just to check up. I was 110. After some investigation, I found myself pre-diabetic, pre-hypertensive, and dyslipidemic. I could change my life. As a surgeon, I took my decision. I changed my life. I had sleeve gastrectomy 10 years back. I lost 100% of my excess body weight. The role of the surgery in the treatment of the diabetes mellitus. Just to see well in the female side. This is the map for the increasement of the diabetes, increasement for the diabetes by 2045. So now if you diabetes, and the 30%, out of the three, the death, it's related to the diabetes top countries. If you look there down, you will see there is 40% of the see it's because the diabetes people there although I am thinking about all in front of this problem, the diabetes, now in the market a lot of endless of the medication to treat the diabetes. Bariatric metabolic surgery in JAMA, they recognized in 2012 it is accepted treatment for the BMI more than 35. This is meta-analysis for more than 17,000 patients with more than 1,500 study. They clearly, the bariatric surgery, it's preventing microvascular complication for the diabetic patient. This is another study showed there is from including the diabetes or patient with the BMI from 30 to 35, and the surgery produce greater control for the diabetes. This is a study, it's done in the Kuwait, and they mentioned there is improvement for the blood glucose just 8 days post surgery. This is another study from the Emirat. It is including the all patients above the 30, and they found there is no significant difference between the morbidity or mortality with those bariatric surgery with non-diabetic patients. They conclude it was safe and effective procedure for controlling diabetes. This is another study. They include the gastric bypass and mini gastric bypass. You can imagine that after follow-up of 2 years, is the percentage of BMI, lowering is just 12. So still there is room to do the surgery for BMI of 30. This is another study. They showed the including 102 patients, and they include for the patient with the more than 30, and it is conclude 30 reduction in the BMI and the diabetes about 26% with the 10 month of follow-up. It's done here in Saudi Arabia. This is, they mentioned the difference between BMI baseline and the achievement only or just 14. This is another study with the the systemic review, including 7 studies, and the bariatric surgery was more likely to result significant reduction in hemoglobin A1C. This is one study. It showed with the BMI 30 to 35, including 112 patients with follow-up more than 2 years, and they include all the type of the surgery, also with the gastric application, and they found this is the diabetes remission to reach about 61. The complication it was with a normal comparing to the non-diabetic patient. This another study showed there is diabetic, including all diabetes with BMI below 35, and it was the 9 clinical trial, and they end up with the remission. It was almost 93% for the diabetic patient. This is the interesting study. It is showed that the patient with the below the 35, all risk factor for cardiovascular, it was eliminated by bariatric surgery. And you know the most common cause of the death in Saudi Arabia, it's heart disease. One of them, the atherosclerosis coming from the diabetes. This is another interesting study. It is led by Prof. Shower, and it was a randomized control study, including 150 patients, and the BMI starting from 27. This is what the interesting here, and the follow-up was the 5 years, and they conclude the remission of the diabetes. It was 29 in the bypass and 20-30 in the sleeve gastrectomy, comparing to only 5% with the medical therapy. They have remission of all the metabolic figure for the sample size. They conclude the bariatric surgery is more effective than intensive medical therapy for long-term disease control. This is from Japan study. They measure the cost. They make, and already I do know some speaker, I think Dr. Ali mentioned that, for the cost-effective surgery, it will be more effective and costly saving for long time. This is another study. They showed it's comparing 5 randomized study for below 35. It is more favorable to control the diabetes rather than the other group. I look what's the cause. It is complicated, the complex pathophysiology, but one of them it is regarding the hormonal changes after surgery. This is the list of the hormone changes after surgery. This is the studies including, and if you look to there, GLP-1, it was the most common hormone changed post-surgery, and this is the most common effective to control or to affect the control diabetes after surgery. This is the top 6 hormones, all including GLP and CCK, and I am surprised I found this cholecystokinin was one of the hormone changed after bariatric surgery. This is another study. It's imported from USA. They recruiting more than 8,000 cases, and they study. Only 1% of them they be above the 30. BMI 30, they received the service, and it was against the guideline. Now, to judge not only with, but also we will look and we see what the other side they said about the surgery to control diabetes. There is a study came from Italy, they including the 30.
2 minutes remaining.
Okay. including 30 overweight cases, bilipancreatic diversion, and after follow-up with 10 years, they found it is not effective and it's the complication more than to control diabetes. There is another study coming from Italy. They include the cases 25 to 35. Also, they are not in favor of metabolic surgery to control diabetes. And this is another study, systematic or review done by one group of our colleagues here, one of them here, I think Dr. Fawaz. And I don't know, he studied all of these reports, and they found the bariatric or current evidence from different studies justify of the complication outweigh of the benefit to control diabetes. So in this controversy, what we'll do? You need somebody to judge. So in the era of artificial intelligence, I went to the artificial intelligence and I asked him, what is the rule for bariatric surgery to control diabetes in BMI lower than 30? I make him concise, clear question. He answered me, as evidence grows, bariatric surgery may become more widely accepted option for managing type 2 diabetes mellitus in lower BMI patients. And I asked him again, what's the future of bariatric surgery controlling diabetes disease epidemic? He said, it is likely that bariatric surgery will become more widely accepted and utilized option for fight against the diabetes epidemics. So I think with the II, one day we'll find the surgeon not himself, he's operating on himself with the II. Also, I ask myself, this is because my bias, because surgical paper, I went to the American Association for Diabetes and I found this statement, especially in the red one, it is acceptable for type 1 diabetes mellitus cases. So, in summary, there is growing up of the evidence supporting the bariatric surgery to control diabetes rather than medication. And I think the home message for me and for my colleague to document their experience and to do the experience from the field. And I think there is more study demonstrate, no doubt, for the role of bariatric surgery to control type 2 diabetes mellitus.
Thank you, Dr. Said. Thank you very much. We believe you. I think now we'll leave it to Osama. I think he wants to...
Just need 2 minutes of your time, so before we break. We don't do this usually of changing tradition, but today there's a special situation. We would like to recognize someone, and we chose to recognize her through this session. So I'd like to invite the chairman of the society, Dr. Aidil Qahtani, Dr. Sultan Timyat, and Dr. Ahmed Al-Garzai to be on stage. And she's a dear friend of the society, and a dear friend of, I'd like to call on Dr. Phil Shower to be with us upstairs. She has been instrumental since the founding of this society in supporting us in our activities, being there for us in setting up programs, and helping us in pursuing the fight against obesity. She's also an academic person who has represented Saudi in a lot of international meetings and gatherings, including the recent Lancet Commission report. She represented Saudi well. On top of that, she is an academic, fought hard. She's always going against the dictum, and part of her going against the dictum is establishing the FAIRS Obesity Fellowship. In fact, she started her obesity medicine fellowship before we started our obesity surgery fellowship. So credit goes to her as a single person, handedly doing all that and giving recognition for obesity as a specialty through her efforts. So for all that, the society has elected to recognize her specifically here in this session when she presented the keynote lecture earlier today. Without further ado, I'll leave the microphone to Dr. Aidil Qahtani to say a few words on that.
Thank you so much, Dr. Osama. It's really a pleasure also being a society for all metabolic and also medical and surgical treatment of obesity. We are really honored and happy to have somebody like Nasreen as a member of our society, contributing not only on the national, not only on the national level, but on the international level in making guidelines and practice changes in obesity management. She is working with the mindset of a physician, but a mindset of a surgeon as well, or surgical treatment of obesity. There are a few people, you have seen them in your life, that when you talk to them, though they are medically, or they have the medical background of treatment, whether endocrinologist or primary care physician or bariatric medicine, they are thinking in the way that we are thinking. Not because we are right, but because this is the right way of managing obesity. In general terms, we speak the same language. So thank you so much, Nasreen. We're proud to have you with us, and always we'd like to have you with us in our meeting, in our presentation. You contributed a lot to the medical field, and thank you. I really appreciate it. Dr. Sultan Al-Tomiyat, go ahead, please give it. Thank you. Thank you.
Thank you very much.
Thank you so much. I'm very humbled, and these are words way bigger than what I am, and I've learned so much from everybody here, but I'm among giants, so thank you so much. Thank you so much. I really appreciate it.
Congratulations. Congratulations.
تعالي هنا، تعالي خذي صورة مع المجموعة هنا، تعالي بين سلطان ومع تعالي.
In the middle. The shortest of them all.
We need photo.
So we should be back.
Before that, for our esteemed faculty, we have also appreciation for you tonight at the gala dinner. Please, all of you, don't miss it. For the gala dinner, appreciation for our senior and esteemed faculty tonight, inshallah. Because she's leaving now.
So 30 minutes for lunch, please. Faculty inside on the ground floor.
We'll come back 2 o'clock, please, sharp. We'll start. Next session.
في الليل متى؟
الجالة دينر.
ايوه الجالة دينر.
ان شاء الله نخلص قبل.
لا 7 برضه الباصات زي امس.
ايوه
خلاص.
When you start doing the program, you should have a simulator training. You have no proper training fellowship. So you have to do a simulator workshop, at least 20 hours. Then you go for online training. You receive the certificate from the company that especially has people executive. So you should have this certificate to go and further training. Then you need to know there's a really booklet to be clear about it, what all the structure of the report. Then you go further, know all these tricks and scopes, how you do the targeting, especially in XI detention, and how you do the consult. The second is what we learn in simulator. Can we start the video? So this is really difficult area. You start adapting these training simulators and data special square. This is everything, your motion, your instrument is out there. All these are very important steps of training. Then after that, you go and do the animal training. Before that, you have to do the Da Vinci skills model. It is very important. You go in the model and fix the robots in the model and start practicing before you go animal training. For the time being, I will just go fast. You need to know how to look the ports, where you set the ports should be in straight line, how much far from target anatomy. These all very important. We learned it in the workshop yesterday. The next step is the animal training. You need to do all the steps if you have a practical training.
Training before I start in human. Then you will get the last, what they call it, consult surgeon certificate. By this, they will allow you to work in robot. But before that, you cannot do this thing. Then the second step, how you start your cases. So you have to select your patients in the beginning. If you want to go in robotic bariatric field, you need to select simple cases like sleeve gastrectomy. You don't do metabolic surgery at the beginning of your, at least you need to do 20 cases of straightforward sleeve gastrectomy. Then you go and doing gastric bypass and other complex metabolic and revisional surgeries. This is our experience in King Fahd Medical City. We did around 323 cases, 72 cases sleeve, straightforward. Then we did 161 revisional, 80 cases primary Rowan-Y gastric bypass. We did around 6 cases SADI, and 3 MGB and 1 reversal to normal anatomy. We have some complications, like 2 bleedings, no leak since 2018. This is our experience since 2018 until 2005. We have conversion, 1 case conversion and 1 case revisional. The important how you consent your patient. The patient, they think the robot do the case himself. You need to explain it to him that we just operating the robot. You need to, first of all, in the OR to teach your staff, especially nursing staff, positions, where you put the table. Your instrument should be ready. Laparoscopic open sets all should be ready, and robotic, the cannulas and the trocar should be ready also, and all these things you need to be aware of. One, you have to be quick in the OR. You need time. At the beginning of your practice, you are slow. But with time, you will adapt how to be fast, because at the start, we spend 3 hours in sleeve gastrectomy, or less or more. But now we spend less than 1 hour in sleeve gastrectomy. In bypass, we spend 1.5 hours. So you drop your robot, the patient card, then cover it before the patient enter the room. By this, you save the time. So you cover it so they will not get contamination, as I show in the next photo. Then position of the patient. Of course, you have to do the position before you start the robot. Then insufflate. Here, who is doing this thing? The fellows. All the fellows do this thing. So you need to adapt the positions and start the deploying. This all we learn it in the putting the first port is very important. You locate where is your target anatomy. Maximum you have to go 20 centimeters below the target anatomy, because the robot arms is long. Then next, insufflate your patients. Then locate your port positions. It's very important. ports and docking is the most important part in robotic. It's not the work. Work is very simple and easy. The most important part is how to do docking, and you should use lesser port than laparoscope. We start when we start our practice, the first 2-3 years we are using what they call it extra port, what they call it assistant port. But now, last 2 years, we never used any assistant port. We use only 4 ports with some tricks I will show you in the coming slides. This is, can you start the video? Here is the fellows when he's going to insert the docking. Can we start the video, please? Excuse me. Start the video. So here, one of the fellows, himself, he's in bariatric surgery fellow program. He's doing the docking, giving the instruction to the nurse when we're starting the docking. He spent less than 1 minute. His name, Dr. Faris Sharif, he's one of our F2 fellows. So he's doing now laser pointing to the first port, camera port, to start the targeting. He's doing the targeting now. This is a gastric bypass patient. So he will dock other arms also. Then they will do part of the procedure. In sleeve, they are doing around 70% of the procedure done by them. So we have special setting in the OR where to put the monitor, main monitor, and also the second monitor, where the surgeon have to sit. He needs to face the patient. If there is anything going wrong, he can observe it. Where you put the console, where you put the vision card. So you have to organize your team and your nurses all the time. So not to spend more, because we have more videos to show. Then when he complete the docking, how many minutes? Okay. See, this is the position of every thing in the OR, so it should be ready. And here we speak about, can you start the video? The staplers. Staplers is very important. This is fully robotic bariatric surgery. Can you start the video, please? Excuse me. Can you start the video, please? It doesn't work from here. So we have excellent staplers in robotic. These staplers, last week I am doing revisional bariatric surgery. Then when I put the green reload in the gastric pouch, the robot gave me a message, this reload is not accepted. So I have to change it to a higher reload. So you have feedback from these staplers. This really excellent. The range of movement is more. Second point, you need to use the vessel sealer. We'll show it in the coming slide. Now, how you do liver retraction. So every case you have to change your practice. Like here we are using Nathanson liver retractor. I use Nathanson liver retractor in case I'm going to do something in the hiatal hernia, so I need the liver completely retracted. Then if there is no need for liver retractor, the next slide, I can use the fourth arm as liver retractor without putting any extra port or any extra device. Here we use the gauze to retract the liver. Here we use the Verras needle. It's a very simple thing, no need for extra port. It works. It is danger, but if you know how to use it, fix it with towel clip, as I show you in the first slide, it helps you a lot to retract and continue your dissection. Here we use a special made device like stitch, and also it's good not to increase one more port. So here can you start the video, please? Here the fellow is doing the dissection for the greater. You give them these easy steps so they can go in. Further steps. As you see how much they progress, they get more oriented, so they can be, depend in visions. So this is what they call it vessel sealer. It's advanced bipolar. It's a very good, see the angle of the vessel sealer and doing the therapy. You have a very relaxed. Now I'm using the vessel sealer as a dissector. I didn't change instrument because it is not there is no heat in it. So I'm dissecting the short gastric. In the meantime, I will do the diathermy. Okay. So next step, next video. Here, how to do gastrojejunostomy. Jejunostomy. So I use the scissor to open. It's very fast to open this the elementary limb. Then I will open the biliary limb. There's a very nice trick in robotic staplers. They are very safe, and I'm not using any more stay sutures. So I'm not using suction. I use the gauze to dry any secretion, any bleeding. So now we insert in the cartilage in the elementary limb. Then see how you go with the stapler, robotic stapler. You bend your hand toward the pelvis. Then insert the tip of the stapler in the in the biliary limb. And this very nice tip. You are using the fourth arm to help you. The number 4 arm, it will help. See, now I use the 4 arm, and I go toward the pelvis. Then I retract the bowel. Then I freeze number 4. Then I bring number 3 arm and pull. That's it. It's a very simple, and you can do it fully robotic without using any assistant with you.
Okay,
so you need an assistant, or you need nurses only. That's all.
I think your time finished.
I'm finishing.
We can give it a chance for a few questions.
I'm just finishing.
Okay.
Sorry, I will just see the benefit. Can we go? This is the last slide. Just start the video. The last slide. Here is the fellow practicing the robotic. He's the only nurse with him. And you can see the nurses, they are ready. And I am outside, I am videoing this. And here is the, all the equipment in the room this is the console side. It's facing the patient. The fellow is the practicing part of the procedure. And that's it. Thank you.
Okay, thank you. I have a question for you, Dr. Abu Khalid. Do you have a second console at your hospital?
No, we requested, but still in the process.
How valuable do you think it is if you have?
It's very important, because if he do any wrong, any problems, you can take over. So I think second console is very important training, but still you can involve your fellow in the training.
Exactly.
Any other question?
Any other questions? I have one question. Anybody? You have a question?
Thank you, Dr. Abu Khalid. Just a simple question. What's the learning curve for robotic sleeve gastrectomy?
As I mentioned, 20 cases.
50?
20.
20 cases?
20 cases.
What about the bypass?
Bypass, I didn't remember the number, but I think less than laparoscope. Laparoscope, 100 cases, the learning curve. In robotic, I think less, 25, something like that. I'm not sure, I forget the number. It was around 25.
Thank you
but in my opinion, if you are a laparoscopic surgeon, you need lesser number. Frankly, if you do 4 or 5 cases, you will feel more comfortable doing robotic bypass. It's more than enough. It's easier than laparoscope in learning. That's all.
Okay, thank you very much.
Thank you.
Because of time, I would like to invite the next speaker, Professor Marco Raffaelli, to speak about robotic-assisted Roux-en-Y gastric bypass surgery on HOGO platform. So this is the second platform we have in our country after Da Vinci. Please, you can start.
Thank you, Chairman. Thank you, everybody. Thank you for the scientific committee for the invitation to participate to this exciting meeting. It doesn't work? Okay. This is my disclosure. Where I have to point it? Okay. This is the 3 available platforms at my institution. 2 of them, the Da Vinci and the Medtronic one, are used for the bariatric surgery as well. This is the this new platform, new because it was introduced in 2022. It has a different system tower, but different cards. The main difference is that in the modular set, it is not only one card, but there are 4 different arms you can use based on what you are going to see. What is important to understand that you can try to set the height with respect to the table to the patient. You have to choose the angle, which is the angle of the arm with respect to the patient. That means that you can modulate on the basis of the procedure on the patient, and also the tilt of the arm, which is depending which side of the abdomen you are going to approach. Another important thing is the console is not a
closed console, but it's an open console. This is a 3D system. Everybody in the operating theater can see what the surgeon is performing. This is very important, different with respect to the Da Vinci system, where everybody can see the same thing as the surgeon. The console has this a little bit different but quite intuitive system to control the robotic arms. Unfortunately, there are not vessel sealing devices or robotic stapler available, but they will come in the future. Just since last week was introduced the Indoshining Green with this system, and very important, the quality of the vision for those who not wear the 3D glasses is really excellent, because it's a native 3D stores tower, and now for introducing the ICG it was shifted to the Rubina, that you know is one of the most performing system of vision. Several papers since introduction have been published in the literature concerning this new platform. I have to say that probably I was the first general surgeon who had the opportunity to use this system for a general surgical procedure, because it was first approved for gynecological and urological procedures. Since adrenals are in the field of urology, my hospital was one of the first who bought this system, and I involved in adrenal surgery. I was allowed to perform adrenalectomies in several patients. That gave me some experience that just after the approval by the CM mark, by the European Community with the CM mark, we started with the bariatric surgical program starting in January 2023. We have already published some papers on that. What I did at the beginning is try to find a setting of the trocar which is similar to that you have already seen with the previous speaker, with some way shorter with respect to the Da Vinci one, so we have to set a little bit higher the trocar, but the position is at least the same. Then we have to choose the setting, because as I told you, this is not a automated setting, but it's a setting that is manual. It can be adapted to the patient, to the procedures. So after these two procedures, I have to change a little bit. Since then, I haven't changed anything, and all the team and also a surgeon who came to see how it works adapted this approach. This is the setup, and this is what happened at the console. You can see sitting at the console with someone on the back, which is able to see what are you doing, and this is his arm at the table. Just to show you the difference between the system, but we can run, because in order to spare time, we lose a lot of time this morning. You can see on the right side you have the Da Vinci system, on the left side you have Hugo Ras. The image is quite similar. What happened? Yes, but I didn't ask to forward. I didn't ask to forward. No, I will say to the back, then we can forward after, as I told you. I settled to the... they are in parallel. However, as you can see, the stapling is a bedside stapling with respect to the Da Vinci system. This is the major. Unfortunately, we cannot see in parallel because it was forwarded. However, no, don't worry. Yeah, I go behind. In this way, we are losing much more time than if we have not forwarded it. I'm sorry about that. Okay. However, just to show the suturing, and then we can forward it to other, but I have to start also with the other. Okay. Good. So we went back. Can you forward at least maximum 1 minute per video? Maximum 1 minute per video. Yes. Yeah. Maximum 1 minute. Both of them. Please. This is the same way to perform the anastomosis. They were in parallel, but unfortunately I cannot measure from here. You see, I would like to show you how suturing is very similar in both the procedures. It's just you have to probably have to look to the mark of the company to understand. Okay, it was evident that the learning curve was quite shorter since the beginning. This is the total in the first 15 cases we have published it, and since then more than 80 cases have been performed. But what is important is the learning curve in the team is quite similar. Till March 23, I was the single surgeon using this machine. After that, 2 other surgeons started the program. As you can see, the learning curve is very flat for both of them. We also compared the results with respect to the other platform, the Da Vinci. This appeared at the end of the last year, as we didn't find any significant difference in terms of complication, but also of operative time. This is very important to us. We made also a multi-institutional studies, including 5 centers that have started the program in Italy very early. All of them are using the same approach I show you. And what we found is, in this paper, which has been presented, submitted for the next IFSC meeting in Venice next year, we included more than 200 patients with a very low complication rate. It was less than 5%, even if in most of the centers this was the first robotic program started. So, just to conclude, in our experience, robotic Roux-en-Y gastric bypass surgery is, with the Hugo platform, it seems safe, feasible, repeatable in different settings. There are some advantages, which is the vision for all the team, the suturing, which is very good, the possibility to adapt the position of the single arm in the case of a collision. We have to keep, I put among the disadvantages in red fluorescence, because as I told you, since last week, there was the possibility to have fluorescence also in the system. I showed yesterday how it works. The disadvantage, however, are manual dockings, the lack so far of energy device and robotic stapling, so we cannot think to a solo surgery as the previous speaker showed you. Probably the instrumentation should be ameliorated, and we have to set up very well the operating theater, because if we don't choose the adequate setup, we can have some problem, some issue also with anesthesiologists, because the arms are quite big. What determined, however, the introduction of this new platform, it has increased the number of robotic procedures performed at my institution. I started very early the program, but I was not allowed because it was too costly. And I chose during the last year to perform only primary studies, which is the most difficult procedures with the robot, but after introduction, as you can see, there was a sharp increase of the robotic Roux-en-Y gastric bypass, and they represent nowadays at least 30% of my experience. And the reason is just in these 3 last tables. At the beginning, 2022, while performing robotic surgery, we lose money, while progressively the costs were reduced, and now we have a positive margin. That means the hospital earn money from every single robotic procedure. And probably this is just to introduce the next speaker from the topic. There is another advantage of this platform, which is the digital surgery, touch surgery. You have every single procedure stored to use to segment the operation, trying in the future to, thanks to we hope, to the artificial intelligence and the machine learning, to have some form of surgery, not performed by the robot, but probably driven or guided by the robot, especially, which is very important, especially for the beginners, for the teaching purpose. I thank you again for your attention and for the privilege of being here.
Thank you very much.
And I hope not losing time.
Thank you very much. We allow for one question. Dr. Osama?
On Thursday I operate on Da Vinci, on Friday I operate on Ugo. Easy to switch from one to the other, no problem at all.
Even for your team?
Even for the team, yeah, yes. As I told you, on Thursday we have access to the Da Vinci. On Friday we have the access to the Ugo.
If today you will give them both available, which one would you choose if you would like to have it?
It depends on the operation. It depends on the operation, depends on the patient. For certain operation, for sure, Da Vinci is preferable. For certain settings, especially if would you like to use a bedside approach for stapling, and someone prefer this approach, it could be preferable the modular Hugo, as well as if you have to change, if you have to perform an operation where to change quadrant for the operation, probably is better having one single arm to redock rather than all the robot to redock.
Okay, thank you, Dr. Raffaelli. It's my pleasure to invite Dr. Raj Baliniban. He is the Director of Bariatric Surgery. Thank you.
Thank you.
It's my pleasure to invite Dr. Raj Baliniban. He is the Director of Bariatric Surgery at Apollo Hospital, Safita University, Chennai, from India. He's going to talk about, can you make robotic bariatric surgery an affordable option?
Yeah. Thank you to Dr. Mohammed and Dr. Marco, who made my life much easier. So I was talking to Dr. Osama and found out that cost is a big problem for robotics in Saudi Arabia as well, which I thought shouldn't be a problem. So this topic might be of much interest with you. No conflict of interest from my side. Okay. So this is the utilization of robo across the globe. So it's only 3% of the entire globe is utilizing robotic surgery, highest in the US, and around 3 to 5% in the Europe, and around 1% in Asia, and Saudi Arabia also it's about 1%. And if a specialty breakup, this is an interesting slide. Urology, gynecology were the one who were progressing so fast, and from 2011-12 when general surgery picked up, and when robo was started getting used for basic surgeries, there was a more than 350% growth in the general surgery, and that broke the entire market of robotics into the world. And in the Saudi Arabian continent, we have around 30 robos, and 420 bariatric surgeries were done in 2024 with 14. So average of 1 surgery per robo per month, which is not viable for anybody to use a robo. Expected to grow at 9% GR, but then still a long way to go. So to talk about how to go about, we have to look into what is the platform that can reduce the cost, and what is the training that can reduce the cost, and what are the budgets that a hospital should do for that affordability to be increasing. So first thing is choosing the right platform. If you use a wrong platform, like what Dr. Marco said, there are indications for certain robos for certain procedures. So we have to be very careful about what platforms you choose. And an interesting study, what we did through our fellowship students, candidates in 2023, around 180 students were assessed. 74% excelled in adapting to robotic platform. 30% variability depending on the type of platform, various factors. So if the platform is wrong for a certain procedure, for example, you had oncosurgeons working on a CMR, there were a lot of variables, they couldn't control much of a problem. So there was a lot of difficulty, and then affordability, you have a problem and surgeon will not convert much. And 100% adoption if the platform was chosen after training. So if a surgeon gets the economical understanding of the platform and then buys the platform after training, everybody transforms themselves into a robotic surgeon. And again, specialty influences the type of robot what you buy. So if you want to be making it more affordable and more patients to be done, you have to be careful about choosing the robot themselves. Again, we have closed console, the open console. Every surgeon will have a different motor visual orientation. Accordingly, they can train and choose. Again, the hand control of pinch with pistol with joystick. Every different platforms have different hand control. Again, based on the hand control, there are some surgeons who are making it very difficult with the pinch technology. The joystick, since they are video game players, 3-4 trainings they are masters in robotic surgery. So be very careful about again choosing what is the hand control. Foot control is similar in most other things. This is again more important, called the arm dynamics. So multi-arm or independent arm, the arm should have 11 joints. If you have 11 joint, what happens is that's called null movement. When the arms are clashing at each other, without changing the fulcrum of the robotic arm, we can move the arm and the forearm of the robotic platform so that it doesn't clash, robo clash will not happen. If that 11th joint is not there, which happens in CMR, that is when we have a trouble in using a robotic surgery. A lot of complications or long operating time, affordability comes down drastically. So that way it influences the, again, multi-quadrant surgeries as well. If you want a multi-quadrant surgery, you need 11 arms to it. And again, instrument exchange. There is something called as mechanical remote center of movement, where on a railing, the hand instrument moves in and out. That fixes the fulcrum, otherwise called as a pivotal movement. If an arm cannot have a pivotal movement, every time you change instrument, your fulcrum comes out, redocking takes 5 minutes, 6 minutes against 15-20 seconds in instrument exchange time. That again, affordability comes down, surgeon gets fed up and doesn't convert himself into a robotic surgeon. Again, that's a problem with a CMR, and that's why it is not getting as popular as Da Vinci and now Hugo Ross across the globe. Again, system card, if we have everything inbuilt, the Da Vinci 5 has insufflator, electrosurgery unit, everything inbuilt, what happened? Algorithm is stored inside, AI is stored inside. You have a better orientation and AI will teach you about how to go about in the algorithm to understand your errors and become a better surgeon. So this will be helping. Otherwise, you have, and that might have a trouble. Surgeries reduces the complications and less conversions. So your affordability increases choosing the right platform itself. It's not just about training alone. Next, elevate your surgical performance. How to train yourself to be a affordable surgeon. Short and sweet. The more structured training program you go through, you'll be much better with it. So there is a beautiful study by Anne which proves novice and expert surgeons have similar but shorter learning curve than laparoscopy. Again, I think there was a question asked during Dr. Mohammad's speech. 10 to 20 procedures for surgeons to convert themselves into a robotic surgeon. Bedside assistant, 5 procedures. 10 procedures for an advanced surgeon and 20 procedures for a novice surgeon before they become master in robotic surgery. And non-technical skill training is very important to be affordable in robotic surgery, because 86% of all adverse events in robotic surgery is technical error and not a clinical error. Again, 40% of intraoperative errors are related to miscommunication, Moore said. And there are a lot of assessments, NOTS assessment form for surgeons and NOTEX for training nurses to get themselves mastered in the art of non-technical training. Again, continued medical education. Significant deterioration within 4 weeks of inactivity. So a surgeon has to be somewhere down the line, at least do 1 surgery a month for sure, to make sure they are going to be well versed with the surgery. And cadaver training improves the surgical skill, but equally deteriorates if you don't perform well. Simulation, however, because it is replicable, 80% of skills.
Dr. Raj, you
hold
have
on.
2 minutes.
Yeah. And significant improvement in skills with regular usage. So 1 case a week is the best to master the skills of robotic surgery. And then unseen clinical benefits of cumulative benefits outnumber the advantages over other modalities. Introduced more specialties and specialists very soon into the practice, and increase the patient volume, and then reduces the operating cost slowly when you go to a certain case load. That helps to make sure that there is affordability along with it. Now come to the major part, affordable packages. What are the packages we like to do? So this is a cost. The best unit what available with us, Da Vinci, costing around 2 million, and equipment costs around $100,000 to start with, and the disposable per case is $1,500, and training is $5,000 per team, and annual maintenance of $100,000. But the least affordable unit, SSI Mantra, which is Indian, and maybe CMR and few of the Chinese companies, they are only 75,000 to 1 million, and they give free instruments for 100 cases. Training is free for them, disposable of $500, and annual maintenance of only $10,000. Makes is as affordable as laparoscopic surgery, which is going to be a reality soon. And then purchase deals is what we recommend to surgeons. They always have a cooling off period, maybe for a year or two, have a purchase where the reduced AMC is done, and then startup instruments deals of 100 surgeries. Free instrumentation is easily given by all the companies, and again inbuilt training cost along with the package of the purchase, and then initial platform charges to be written off by the company. So what happens, you only use the instruments, and the instruments also 100 units free, so it is as good as doing a laparoscopic surgery cost. Start with 100 patients. The moment you cross 100, the data will prove. So moment you cross 100 surgeries, what happened, the cost comes down to around $7,000-8,000, which was $16,000, $17,000 when you start the case. But when you reach 250 surgeries a year, you hit the laparoscopic cost of $3,000 to $4,000. That is when it starts becoming profitable to you.
Dr. Raj,
yeah, one more minute. Yeah. So return of investment wise, 50% increase in the cost when you start it, and it reduces to 10% by the time you hit 500 cases annually. So the cumulative benefits outnumber other modalities and replaces laparoscopy as well as bring in new volume. So these are all the advantages what it has. And thumb rule, unwritten guideline, 250 procedures a year, you break even. Minimum of 4 specialties to start with, 1 procedure per surgeon per week at the least. So there will be 4 procedures per week, around, it easily come to around 250 at the end of the year. And addition of at least 1 specialty year on year, that should be the plan on which you have to buy them. And then 2 to 3 procedures clubbed on a specific day. So what happens, you switch on the robo, continue all the procedures, the instrument is a single use, do a plasma sterilization, single use instrument. So if they give 10 users, you use 30 surgeries, the same instrument, that reduces the cost by 1/3. And use of assist port for specialized instruments, for example, $1,000 may be a cost for ultrasonic dissector. You can use assist port and do ultrasonic dissector through a laparoscopic one, cut the cost. So these are all small tricks to work around. And then unsaid revenue savings wise, the middle class will be what we can say is platform being switched on the entire day, dedicated days for surgeries will help them, and then concern of platform and instrument sterility has to be considered, and multiple use case scenario for an instrument. For example, we use a bipolar grasper as a needle driver itself. So we don't have to buy a needle driver which is going to cost another maybe $200-300. So that way you save it. Again, underreported benefits. Reduction in the skilled staffing by 30%. That money is again a saving for you. Significant increase in surgeons' man hours because of lesser musculoskeletal disorder. A surgeon will have another 6-7 years of more time spent on the surgical scenario than laparoscopy. And AI decreases surgical errors and decreases the complication as well. Telesurgery saves time, money, and increased productivity, and soon surgeon can be sitting at home and operating maybe another 5 years down the line. So to conclude, it should be in 3 phases. Phase 1 is the first year, all inclusive packages including the OT time, dedicated slots, 4 specialties minimum, proctorship, mentorship, minimum of 100 surgeries, and then appraisal at the end of the year. Surgeons who are not doing, get them off the list, add new specialties. Second year, package for specialties, dedicated OT, 2 new specialties to be added, 250 surgeries, and the department audit. Then third year onwards, look at 500 surgeries, and then you look into multiple platforms if you want to do that. So at the end, the robotic platform is still an emerging technology. Choose wisely which platform to buy. Learning curve is related to time and cost. So structure your training properly. Use in bariatric surgery still remains negligent. Take advantage of the benefits and use right platform. Affordable platforms and instruments are available. Then crack a good deal with the companies and get the best deal for you. Tailor-made approach makes robotics affordable. So that's why use it responsibly. Long-term outcome proves significantly. So take up bariatrics at the earliest. Thank you.
Thank you, Dr. Raj. We'll have only one question. Go ahead, Dr.
That's true.
Story of PC versus Apple, what to choose. So you start with one, then you like it and you wouldn't. So today, if you were in a cost-conscious environment, which one would you choose?
So right now, in my practice, if I have a patient with a good insurance, I will do Da Vinci because Da Vinci is fully robotic. If the patient is not that much affordable and still I feel robotics might be helpful, especially in a super obese or a revision patients, I do Hugo Ross. Because Hugo Ross, case to case expenditure is half as Da Vinci, one. And second, I have a consultant in my team. He serves as a bedside surgeon. So there is no increase to cost. It's going to be the same cost having 2 surgeons. So that way we work around. But if stapler comes in, if any source comes in, then Hugo Ross might be similarly costing. But the biggest advantage what Hugo Ross is bringing in slowly is adapter for click line call stores. So you use a robo, but you use laparoscopic instruments inside. So that bridges the gap between robotics and laparoscopy. Maybe in the future, maybe another year down the line, we might have plenty of, again, other platforms coming in, which might help big time in working around the cost, which is going to be as equal as laparoscopy.
Thank you, Dr. Raj. Thanks for a great presentation, a very thorough and detailed one. Our last speaker, but not least, is Dr. Sachin, and he's from the United States. He's amazed us yesterday about updates about the new Da Vinci, and I started to feel threatened that the robot will take our jobs. Man, I'm just joking. So today he's going to present us his talk, and it's the use of the robot in all bariatric cases. Shall we use it selectively or for all the cases? Pros and cons.
Thank you. Thank you very much for the invitation to be here. It's been a fascinating and amazing experience. If we could load my slides, please. Thank you. Don't let the lead picture misguide you as to my talk. It's not advancing. There it goes. Okay, so should we dock the robot for every case? And I think the answer is actually quite simple. It really depends. But let me go ahead and try to give you the arguments for each side of the issue here. So what are the basic merits of robotic surgery? This can certainly be picked up from a catalog or a basic website. But if you talk to people who do robotic surgery, or maybe their arguments for robotic surgery in general, the ergonomics are better. You're less awkward in your positioning. You have wrists. You have angles. You're more precise in the operations that you're doing. Your inherent tremor, stabilizing instruments, thereby losing the dexterity of your wrists. Today means having a computer between you and the patient, doing much more than just translating your movements, but actually interpreting those movements, acquiring data and information that may confer more information for outcomes in the future. And then lastly, robotic surgery is very, very young. It's in its infancy. And so as this technology evolves, we are ensured to learn much, much more. So those who believe the robot should just be used selectively, anybody want to raise their hand? Only use it selectively. Okay, so these are maybe your arguments. You may say, high cost per case. It's an expensive toy. I've heard it called a $2 million sewing machine. It's a huge capital expense. There are only certain patients where there's benefit, revisional patients, those with a very thick abdominal wall or high BMI females, those who I feel like I need to do a hand-sewn anastomosis. If I'm not using it, that allows somebody else to use it for their complex case, and so I'm maintaining access by only using it selectively. And then simple cases may actually be easier laparoscopically than robotically. And then lastly, I don't want that handicapped, I don't want that crutch of always needing a robot to do every case. I want to keep it for the hardest cases. Now, those who maybe have a counter argument that say you should use it for every case, meaning if you can dock it, you can rock it. And that is maybe my perspective on this, would say that the more cases you do, the better you do them. The more efficient I become, the more efficient my team becomes, the more reliable my instrument trays are, and I am developing a foundational skill set. So when I do a robotic chole, that makes my robotic sleeve go better, that makes my robotic bypass go better, that makes my robotic switch, revision, paraesophageal all go better, because I am becoming proficient by doing more and more cases. Those of us who also believe this would say that you can never argue with enhanced precision. If you have a 911 turbo, were you going to complain about driving it in a parking lot? No. Okay, so is it ever a problem to be more precise in the work that we're doing? Probably not. Can you really complain about feeling better? After all, as a surgeon, I am the most valuable asset in the room. It's not the robot, it's not the team. If I end my career early because of injury, fatigue, whatever it is, how many fewer patients am I helping? So remind yourself that you are the most valuable person in that room. And then you never know when you're going to get into a disaster. You book a 35-year-old outpatient cholecystectomy, and that is your hardest case of the month. Sometimes you get in there and they have a huge inflammatory rind, completely unforeseen. And so you never know what the anatomy is going to give you, and having the best resources at your avail will never be the wrong thing. And if I am touching the robot 4 times a day, 3 times a week, then my learning curve is vertical. Lastly, maybe our leak rate during laparoscopic cases is only 1%. Maybe it's 1 in 200 cases. If I can reduce that to 1 in 300 cases, I may not see the benefit this year, but I will see it over 2 years. And so there are always opportunities to do better. And if your technology is better, if that is your aid, your wingman, then you will do better surgery. So lastly, what is the value of a robotic machine sitting in the operating room and not being used? It's not worth anything. It's no longer arguably an expensive instrument. It's now a worthless instrument if it's just sitting there, not being used. So considerations, laparoscopy is dying. In my opinion, laparoscopy has no room for growth. We now need digital surgery as the opportunity to allow for improvements in technology, angles, adaptation, and this evolution cannot happen with a straight laparoscope. Training is shifting. In my circles, residents are learning robots. What that means is when they go into practice, they are not going to be proficient laparoscopic surgeons like we may have been finishing our training. As robots move on, technology gets better, and the technology that we use today on the XI was patented in 2014. That technology that is fascinating in the exhibit hall that we're all sitting down and enjoying is 11 years old today. So imagine what technology will bring in the upcoming years as we have more things available to us. Training algorithms are standardized. I can now simulate on the robot how to do a hand-sewn anastomosis. I can have my resident, my fellow, simulate retraction. And not only is this simple rubber bands that we're retracting, now we're actually doing tissue simulators that we could not accomplish laparoscopically. And then the metrics that will happen because we're doing this digitally will actually be objective to be able to say this person is a proficient surgeon on the robot. We cannot do that with laparoscopy. And then ultimately, the simulators will be the surgery. I think we will be able to take a given operation and simulate that in 3D video on a robotic simulator as if it was the real thing and not know that there wasn't a real patient attached to my vision cart in that very moment. So think about a few clinical situations before you commit to your answer. This was a case I did a few weeks ago. This gentleman, 34-year-old guy, BMI in the upper 30s, he had had 2 prior open paraesophageals through the abdomen. He had a recurrent paraesophageal hernia. He had mesh at the hiatus. And now I'm converting him to a gastric bypass. And I would challenge anybody to get that operation done well laparoscopically. And yes, it took 6 hours, but in that 6 hours, I was sitting down, I was comfortable, I was able to take a break if I wanted to without any ill effect. And so dramatic lysis adhesions, multiple docking angles, yes, it happens, but you can do harder surgery because you can see things better, get the angles better, visualize better, and do operations that you maybe couldn't otherwise do. Or think about this patient, a BMI of 93, you're doing a DS, or maybe you're doing even just a sleeve, and you're fighting abdominal wall, right? 750 pounds, I don't know, what is that, 500 kilos or so? Doing such a thick abdominal wall, tremendous visceral fat, your assistant is complaining because they can't retract through the abdominal wall. You're doing 3-quadrant surgery, so do you target trocar through the abdominal wall to the upper abdomen, to the right lower quadrant? How do you even know? And then when you get time to finally do your anastomosis, navigating the abdominal wall that is 8 inches thick, good luck. Let the robot fight that fight for you. So we've all been here. This was a VBG to gastric bypass, and this was earlier in my career when I was doing a lot more laparoscopy, and I would say this was my transitional period. You can see my resident opposite me trying to grab the omentum to take it off the abdominal wall. My resident working opposite the camera. We cannot reach the abdominal wall because of the insufflation. The omentum is up to the abdominal wall. We can't get the angles that we need. I'm doing subpar dissection with my ultrasonic shears, not coming right up against the abdominal wall there. And this is just a struggle. We've all been there. If I could get this video, please advance into the middle of the video. So eventually I was able to give up, dock my robot. Can you slide to the middle of the video? Okay, so we docked the robot on three trocars on one side of the patient. No longer are the angles a problem. No longer are we operating opposite the camera. Everything is straightforward, unidirectional surgery, make progress and get the operation completed. And so now my standard is when I have a complex abdominal wall that I'm navigating, I'll just double dock. Double dock on one side to get the midline adhesions taken down, then dock across the abdomen to go to the upper abdomen. So where do you stand? There's 2 sides. Universal robotic use. Why limit access to a tool that enhances precision, enhances outcomes? Routine cases benefit from improved control and ergonomics, making universal robotic use a future-proof bariatric surgery practice. Or the other argument, selective use. With cost pressures on healthcare systems, we need to optimize robotic use for cases where it makes the most clinical and financial sense. Using it selectively allows us to maximize benefits without overburdening our resources or systems. Well, in my practice, having done over 2,600 robotic cases, my cases are consistent. My hospitals complain about the laparoscopic surgeons because they're slow and they're costly. My teams know what I want to do or what my instruments are. We have something called the Cucragia tray. It has 4 instruments and I can do any surgery I want to do, from an inguinal hernia to a bariatric revision with those 4 instruments. So it's simple for everybody. The instruments have the names written on them, so there's no confusion as to what a type of grasper might be. I'm ultimately doing this without the benefit of an assistant. For the last 4 months, my PA, she's been on maternity leave and surgery hasn't stopped. So I can do this without an assistant because I'm doing this robotically. I am doing bigger patients, harder surgery, more complex surgery, and I'm doing it well. My patients are going home quickly with very good outcomes, and now I haven't touched a laparoscope since 2019. So this is just a brief view, because again, this is digital surgery, so I have a computer telling me what I am doing with my time on the robot, summarizing my clinical volume with sleeve, bypass, gallbladders, and such. 20 minutes after a case, I have a case summary that comes straight to my cell phone. This was a sleeve a few weeks ago. 15 minutes of my instruments working, 21 minutes of sitting down, 3 instrument exchanges, all my exchanges here through arm 1. And you can see consistency. This is my OR time over time, And now universally, my sleeves are all within a very nice tight window of operative duration between 22 and 37 minutes, last case being 21 minutes. So where do you stand? When you consider universal versus selective use, I fall into the universal category because I believe this tool is an asset that will help not just my patients, but help me do better surgery for my patients. I think that's the last slide, but it doesn't want to advance, so. Maybe we'll stop it there because that is the point after all.
Just stop there.
So.
Thanks, Dr. Session. Great presentation as usual. I'm expecting a lot of questions from the audiences.
Finances. How does it work for you when you do a laparoscopic procedure versus a robotic procedure? Is the reimbursement different? Is it more?
No, our reimbursement as physicians are the same. Reimbursement for the hospital is also the same.
Does it affect you in terms of your decision, the financial implications of your decision, whether to use the robot or the laparoscope?
So I can tell you 2 years ago, I booked a laparoscopic sleeve on a patient who had previously had a liver transplant, and the patient had a chevron incision. I booked it laparoscopically, and the hospital OR director called me and said, "Can you please try doing it robotically? That'll be cheaper for us." So,
observation.
Yes.
Expert like you speak about robotic surgery. Is that the advantage in very complex cases? Still, you are not selective. The other things, there is no, emphasis on the benefit in an emergency situation. What is the thing about this issue? Can you elaborate?
Absolutely. So I think that we, in some ways, overthink this. Okay, you can't ask somebody to build a skyscraper if they can't build a house. So I view all of these other procedures as foundational. Now, can I do a laparoscopic sleeve? Can I do it well? Yes. But if I'm doing my robotic sleeves, I'm doing them well. Not only am I training my own foundation, my own skill set, my own muscle memory, but I'm training all of those around me. So when we do have a complex case, it's as routine as the sleeve. Now, that also matches with your second question. So acute care surgery is transitioning to robotic surgery. Now, the reason for that is because you can deal with things the same way that you could laparoscopically, but once you become proficient with the platform, you actually become quicker and a little bit more agile. Now, I didn't show these videos here, but you can imagine during a laparoscopic case, you get into bleeding, you're grabbing whatever's bleeding, you're transitioning it to your assistant, someone is trying to clip, someone is trying to sew, and all of these transitions, they're awkward. Sometimes controlling that bleeding is harder. You become a one-person show, and so you have that complete autonomy, whether you're in the upper abdomen, lower abdomen, wherever you are, to deal with acute care surgery more adeptly, in my opinion, robotically. And so, even the hardest of gallbladders can be standardized robotically, I feel. I think robotics, and I can tell you in my market, in Dallas, Texas, right now, 72% of all bariatrics is done on Da Vinci. So it has effectively replaced laparoscopy. And anecdotally, I don't know the numbers, those people who have stayed laparoscopic are all within 5 years of retirement.
Thank you very much. Thank you very much, Dr. Session, for your... we have... And say no.
Okay, wonderful presentation, Sachin, as usual. Congratulations. So my question for you is, a lot of my friends in the UK and in the US, those in private practice, their volumes of bariatric surgery are going down. What would you advise the surgeon who wants to take up robotic bariatric surgery in this type of environment? Is it worth the effort of the training when your numbers are dropping 30-40%, or do you think that the future of bariatric surgery will rebound and be bright again?
I think that this is exactly the time to get your training in robotic surgery, and the reason for that is because your first cases will be awkward. Your first 20 cases will be uncomfortable. You will have some missteps. You will feel you will feel weird, right? You are a comfortable, proficient, good surgeon. You impress all those around you, and now you come out looking like a brand new trainee for those 20 cases. And so you don't want that experience when you have 6 or 7 or 8 cases on for that day. Have that experience when you have 2 or 3. You have the freedom to operate a little bit longer, to be slower in the operating room, grow your skill set, and hopefully Dr. Schauer is right, and we are all busy in about 2 years.
Okay, thank you.
Great, thanks a lot.
Thank
Thanks
you.
a lot, Dr. Sachin. Great presentation. I have a few questions to the audiences. Who is currently a practicing robotic surgeon? Excellent. And who is actually planning to get trained in robotic surgery? I love that. That's great. That's great. So,
Who has practiced robotic and doesn't like to do?
and who did practice robotic surgery 20 years ago, and now he changed his mind because laparoscopic at that time was easier than robotic? That's up.
We'll go to the next session. I'll call the chairperson with us. This will be the endobariatric session, and I'm sure you will like it, better than robotic for sure. عماد الجحدلي, Abdullah al-Musa, Abid al-Lehebi. Abid is not. Abdullah, come please here. Chris, where are you? Come with us, join us here, because Abid is not, so Fadal Abdullah. So it's really a pleasure to start this meeting and present to you the first speaker. And of course, our chair and co-chair, we have Dr. Abdullah al-Musa, who is practicing endobariatric. He's a gastroenterologist. And again, the society is really establishing endobariatric section that deals with all endobariatric interventions. And Abdullah al-Musa is one of them, and he's practicing currently. And I'm really honored also to have Chris Thompson from Harvard, US, and he's one of the leaders and founders of many technologies and techniques in endobariatric. And he will give us the promising future of endobariatric therapy.
Thanks very much. Thoroughly enjoying the conference, and really a great time. So again, my topic is the promising future of endobariatric therapy, and really what we'll do is use this to kick off the session and touch on a little bit of kind of where we've been and where we're going. So this is how I like to think of obesity, right? I don't like to think of it as a weight on a scale or a body mass index. I like to think of it as the disease that it is. It's a disease of inflamed adipose tissue. So this is a scanning EM, an enhanced scanning EM image of a fat biopsy from a patient suffering from obesity. And you can see the adipocytes, the larger cells are adipocytes, and then they're surrounded by macrophages, and it's truly an inflammatory disease. What happens is these macrophages then secrete cytokines into the blood, the toxic cytokines like TNF alpha and IL-6 and IL-1 beta. They circulate throughout the body, causing all the systemic related conditions we think of, the vascular disease, the type 2 diabetes, fatty liver disease, and whatnot. And of course, metabolic syndrome. So the response to that over the years has been, well, just eat better, right? That's one thing. We can just eat better. Well, that's not a way to treat a disease once someone has it, right? Certainly, it's not terribly effective when someone's suffering from obesity. It leads to only about a 3% total weight loss, and only 3 to 5% of dieters can maintain that weight loss for 5 years. So it's not a good long-term solution. Well, now we have, of course, medications, and this is, very promising and exciting, right? Well, this is also not the way right now, right? We have all sorts of problems with this. 70% of people that have this medication paid for, okay, from claims databases, 70% are off the medicine at 1 year because they just can't tolerate it. There's all sorts of problems with lean muscle mass, bone density issues, Ozempic butt, Ozempic face, recurrent weight gain as soon as you come off of it. So there's lots of issues. So this isn't a solution either. Surgery, fantastic. Surgery does work, right? And we know it works. It's safe, it's effective, it's great, but you can't scale surgery. It's too expensive to scale. This is a pandemic, right? We can't do surgery on everybody for sure. And a lot of people just don't want it. That's why probably globally, less 1% of patients that should have surgery don't. So it's great, but it's just not going to scale. It's not a good long-term solution. And then we have endoscopic therapies. And, we have lots of different devices. We have gastric devices, which we're going to hear more about today. There's intragastric balloons, there's suturing, gastric remodeling. These are all making a lot of headway right now. And there are also small bowel devices that really focus more on metabolic kind of mechanisms and have stronger anti-diabetic effects. And again, we're coming a long way with this. This is what our ESG procedures currently look like. They're very efficient. We're done in about 45 minutes. We're getting nice full thickness bites. The team works very quickly together. The final appearance is beautiful. There's no fundus visible on the left, right? Nice tight sleeve. This is what it looks like. It's beautiful. However, it is far from perfect. This thing needs a lot of work, right? It is safe and effective, but there's no standardization, so everyone's procedure looks different. There's questions about suture loss and durability. The procedure time is long still for a lot of people, up to an hour plus. There's a long learning curve for 50 procedures required typically. It's still expensive, so scaling this is hard, and there's limited insurance coverage. There's a lot of issues with this. So I do believe, though, all this is coming to a head and we're now poised for a renaissance. And what I'm supposed to be talking about is the future of bariatric endoscopy and how these things all align to help create that future. I think there's a future in surgery and a future in medicine too, but this is just the future of the endoscopic procedures. And I think that we have to focus on a few different elements. First is improving existing devices and procedures, which we'll talk about a little bit. Then we'll talk about the brand new approaches, okay, that address mechanisms of disease, and mechanisms of disease are very important to understand and address. And then we'll also look at altering normal physiology to have treatment effects. We'll look at genetics and epigenetics and how we can maybe use those, and then homeostatic regulation procedures. So as far as just improving the devices, that suturing device has been around over a decade. We're still using it, but there's other ones that are on the horizon you're going to hear more about today that automate different parts of the procedure, so you don't have to actually place every stitch yourself. Maybe you can advance the device down, push suction, and then a device will place multiple stitches for you. Or maybe, you have bigger plications you can place rather than one stitch at a time. So those are certainly very encouraging. We just heard a great session on robotics. I spend a lot of my time working with robotics, and we do have endoluminal robotic systems now that are quite promising. So at the bottom right, you see an ESG being performed in an ex vivo model using a robot. And we're getting much quicker at this. You can actually automate certain portions of it, and it actually is quite nice. And we're also trying to teach people to use the system, because it's not quite like a Da Vinci interface there, but it's very similar. And we're able to actually teach this a lot quicker, we think, than we are the standard endoscopic devices, especially for surgeons that have used robotic systems. They pick up on it very quickly. So I think that's one advantage, one advance that we're going to see in the near future. What about understanding physiology and designing a new procedure that's not just kind of replicating surgery? Well, this is one approach we used recently. So if we understand gastric physiology, there's a few different phases to it, 3 main phases. One is fundal accommodation, so the fundus stretches to accept a meal. The next is the grinding, mixing, and breakdown of food in the gastric body. And finally is the emptying of the stomach via the antral pump. Well, each of the different bariatric devices that I mentioned briefly work by different mechanisms. The original pose procedure works on fundal accommodation. The intragastric balloon and ESG procedures work on the mixing and breakdown of food, that second phase. And the transpyloric shuttle focus solely on the third phase, preventing gastric emptying. Well, we created a procedure that actually hits multiple mechanisms instead of just one. So this was called the GEM procedure. So what we do is a tunneled myotomy in the antrum. So we do a submucosal access site, and we tunnel the entire length of the antrum and make a long myotomy to affect that third phase, okay, of gastric emptying. So we inhibit the antral pump, and we also do a modified ESG in the gastric body. And we, with this technique, got over a 19% total weight loss. It's very durable. 100% of people had at least 10% total weight loss. And the gastric emptying consistently went from 90 minutes to over 200 minutes. So we got a nice delay in gastric emptying, which is more random with traditional suturing itself. Additionally, we looked at the GCSI scores. There was no nausea or vomiting, so this mechanism seems very viable, and it's one way we might be able to improve existing procedures. What about small bowel devices? Well, this is the old endobarrier, right? And it was very interesting because it replicates a gastric bypass, okay? You shelter the duodenum from seeing any food, sort of like the bypass would, and then you have food that's emptying distally. So you have really hindgut mechanisms at play here where you see increase in GLP-1. Meta-analysis showed this was really encouraging. You had over a 1-point drop in A1C and a 19% total weight loss with many, many studies. Unfortunately, the device was associated with hepatic abscesses, so it went off the market. Now they think they fixed that and it might be coming back soon. But that was very early results and it was very encouraging. So now we have several other devices that are trying to kind of work on similar principles. We have devices that are ablating the duodenum to get a similar treatment effect. Now, they only work on the hindgut mechanism, so you're not seeing the weight loss, but you are seeing an improvement in type 2 diabetes. Okay, so this is only working on foregut, not on the hindgut at all. And then we also see other devices that are, this is an electroporation device, so basically it creates little tiny holes in the cells and this induces apoptosis, and they're getting similar results. I'm not sure they're going to be much better, but it's just a different way to do something that's similar. And then of course we have magnetic anastomosis. This is something that came out of my lab years ago. Fractal, the original burning procedure, also came out of the Brigham, my hospital as well. So this is self-forming magnets, and we originally did these procedures solely endoscopically. It was very hard to get that distal ileal magnet into position. So this was the original endoscopic approach. You can see we put the magnets through the scopes and just kind of pushed them together. And so this was a side-to-side anastomosis. And it only worked on the hindgut. So unlike the ablative technologies that work on the foregut, this only works on the hindgut. And we had really pretty decent results in our initial 10-patient first-in-human series. We had substantial weight loss, and we had over a 1-point drop in A1C, 15% total weight loss. It was very encouraging. However, it was just hard to do. So now we've modified this so you have a hybrid procedure. You can place both magnets laparoscopically, or you can place one laparoscopically and one endoscopically. And this just got FDA approval in the United States last week, so we're excited to see where this goes. But again, it's something that can make procedures quicker, a little more streamlined, and it might be something worth looking at. And finally, what about gene therapy? So this is another project we're working on at the Brigham. So what we're doing is using adeno-associated viruses and endoscopic ultrasound to inject these viruses into the tail of the pancreas and create a GLP-1 transgene. So the beta cells of the pancreas can produce their own GLP-1. So it's very exciting. We've shown in animal models we can actually inject this safely into the tail of the pancreas without causing pancreatitis. The virus stays in the tail of the pancreas, and it is very effective. And we've done several animal studies where we take, it's a murine model, so this is a diet-induced obesity murine model, and we randomize the animals to either have the gene therapy performed or put them on a GLP-1. And both groups lost roughly the same amount of weight. You can see in red that the transgene animals lost a little more weight than the semaglutide animals. Then what we did is we took the animals on semaglutide and we divided them in two groups. One group we just took them off the semaglutide, and the other group we gave them the transgene. And the transgene animals again continued to lose weight. So that's very exciting. And this was kind of regardless of, they all had the same access to food and whatnot. So this is extremely exciting, and this is going into clinical trials this coming year. So gene therapy is potentially on the horizon. And it's great because the bigger meal you have, the more GLP-1 you produce. The bigger you are, the more GLP-1. And similarly, as you lose weight, you produce a little bit less. So this is something that might compete with the pharma. So in conclusion, endobariatrics has a clear place in the spectrum of obesity management. I think small bowel and combination procedures, as well as the use of robotics and gene therapy, are certainly on the horizon. And next, we have to focus on personalized, phenotype-based approaches to optimally employ these various modalities. Thanks very much.
Thank you, Chris. It's an excellent and, as usual, very advanced technologies and techniques. Questions, please? If I will ask one question, Chris, like, do you see the improvement will be in improving on what we have in terms of procedure, just advancing, maybe improving the switchers the way we do it also, or a new technologies and new tools? Where do you see the most things will go?
Well, I think we will see continued incremental improvements with these technologies, and they're already being used a little here and there in Europe, where you simplify the existing procedure and just make it easier to do. I do see that, but I believe something disruptive is coming pretty soon. Right? I think something like a gene therapy is something that would be very disruptive, and I think that is not far away. So it's going to be hard to predict how that affects all of us, right? When all of a sudden you don't have to inject yourself with this GLP-1. Now you have one injection for the rest of your life, and it's more effective than the drugs, right? So this is something that might not be as far away as we think, and I think until that happens, the incremental improvements will be helpful. But I think something like that's closer than we think.
Okay. Questions? Yes, please.
Chris, thank you for all what you're doing, and we'll talk about it in a little bit, but and other aspects in bariatric that we do. But I think it's like going to what Dr. Ida is saying is that I think improving in the current skills that people have, and having more people who can do some of the stuff that you guys do in your center. So a lot of the stuff that you can do are a little bit kind of high-tech and slick, and maybe not being done by the mainstream doctors. So can get people to do sleep gastrectomy like what is being done right now is the thing that will have more impact on a lot of people. So I think it's a parallel until something like drastic, like the stuff that you're talking about, are important. But I think in continuing on the current thing that a lot of people can do is, I think, a way to go. I don't know what you think of that.
Well, I agree. We have to make things easier, right? So there's two things. You have to make them better, and you have to make them easier. So why we started doing the tunneled myotomies is there's a lot of problems with ESG. The stitches fall out. Everyone does a different pattern. It's very frustrating. You never know if someone's doing a good job or not. Well, with a myotomy, it is what it is. You do a tunnel, you make the cut in the muscle, and it's done, okay? There's no variability, there's no suture loss, and someone doesn't put in 2 sutures and someone else puts in 8, right? It's very straightforward. So all of a sudden you have a consistent, reproducible procedure, but it's still hard to do for some people, right? So how do you make that easier? And that's where I think robotics might actually play a role. It seems like they're really, you hold a lot of promise, and I think they'll simplify it for a lot of people. And I think as far as suturing goes, automating that process is important. It is hard to put in 70 stitches and make sure you get them in the right place, but if you can just put a device down, hit suction, and push a button, that's going to be really helpful. So I think those are the things we're going to see getting traction in the near term, and I mean within the next 24 months, we're going to see more of that, and that's very exciting.
Okay. Thank you so much. We'll move to the next presentation.
Thank you.
Pleased to present Dr. Abdullah Al-Musa. Presenting, no, I will be the one presenting myself. Sorry.
It's with me. So the next presenter is well-known, Prof. Al-Qahtani. He's the leading of the endobariatric in Saudi Arabia. He will talk about using and outcome of the refugian endobariatric therapy. So the floor for you, Prof.
Sultan. Okay, so we will have the presentation. It will be about revisional surgery, and of course, I think this is definitely primary surgery is important, but as well as revisional, and for us, bariatric surgeon, I think we'll be more utilizing bariatric as revisional in our practice, because we see a lot of patients coming with us. So, as you know, it can be gastric. Endobariatric is really growing fast. It works mostly on remodeling the stomach, resizing the stomach, but also there are a lot of metabolic component in this, and you can see how much we can do in the signaling, as Dr. Thompson's mentioned about interaction with the signaling and GLP-1 and others. It can be primary, can be secondary as a revisional procedure, or you can revise any single procedure. I'll show you some videos for this with endobariatric. Any single procedure that you have in your practice, and of course treating complication. It's growing worldwide. We have now more than 50,000 cases done, 250 publications, randomized studies, systematic review. So we have published a lot of publications on terms of use of endobariatric, whether it's primary or comparative with LSG, below 30 BMI, or in children and adolescents. And we showed that if we compare the two procedures with LSG, it is within 10% total weight loss for LSG. And if we look to comorbidity resolution, it's significant, and also side effect. Also, below 30 BMI, quality of life and also weight loss is really good in these cases. Pediatric, we have done 257 cases and good weight loss in 4 years. 5 years outcome in 2,000 cases of ESG, 16% total weight loss. Now the good things, can you run the video please? The good things here you can see. Make it full screen please. Now if you look to this, you can see here, play. You can see you can remove it. You can just go there and cut the switcher. So it's very reversible. And this will indicate, go more. You can just there and cut. See there? You can cut. You can go there and cut again. In the bridge here. Even, so it's a reversible procedure as you can see here. You can also redo it. Play, please. You can redo it, and this is a case almost 1.5 years or 2 years, and you see loosening of the switcher. You can reinforce these switchers. You can say this loose switchers is okay, it still have some function, so you do the diagnostic and you go there, just simple as a primary procedure. You can also, play please, you can revise it to LSG. You might find this adhesion. It's okay. It's not a problem. Just take this adhesion out. And when you take the adhesion, you start your mobilization for sleep as standard. There is no problem there. And then after you fully mobilize, you occlude the duodenum. So this stomach is fully mobilized. Occlude the duodenum. Go there, because you don't like to insufflate the bowel while you are doing LSG. And I recommend combined procedure. If you cannot do endoscopy before, then go there, take all switchers, take anchors. You will find anchors there or needles there. Just take them out. And then when you take them all out, just aspirate the stomach and do routine standard LSG. And you see, that's what you have. So this is the beauty of you can revise it, you can do anything afterward. Now also, play, you can do it with TIF. You can do, if you have somebody with reflux, you can do in this TIF here, run fast forward, please. In the middle. In the middle, yes. There, you can see, you can do the wrap just before the last. Again. More forward. Okay, go more. You see how it looks, go more. You see how it looks at the end, more. More. You see there, more, yes. This is ESG. This is a TIF. Good fundaplications, and afterward, what you do, you can do ESG. This is, it's okay. Now this is a very interesting case. Here you can go Gerdix after LSG. This is very common problem. Patient with reflux post-sleeve gastrectomy. So you can go there and go in the middle, please. You can go there, it's okay. So there you can tighten the hiatus with Gerdix. And in this way you'll create a wrap. And then that's it. So ureteroflex in a patient. This is very important tool. Somebody with reflux, post LSG, you can manage it endoscopic. Somebody with reflux doing LSG also, you can do anti-reflux procedure endoscopic and do LSG. So it's a very nice tool in your hand. Now, what about weight regain? Again, the definition as you know, but what we can say here, you can do stoma reduction and pouch reduction and bypass. You can do it for sleeve, you can do it for banding, you can do it for all biliopancreatic, and I will show you. This is run the video. This is just animation. Run in the middle, please. In the middle. And you can, this is the stoma, more. And you tighten the stoma, as you can see here, and then you tighten the pouch. As simple as that. You can do it in real life, there is no problem. So this is for bypass. Now, this is a picture. You can also ablate and then tighten as well, the stoma, which is okay. And this is the Dr. Thompson's publication in randomized study, also 5 years follow-up, 10% total weight loss you can expect in these cases. Now, this is also ESG after LSG, somebody with weight regain after LSG. So you go there, you tighten the stomach. Go in the middle. Simply, it's a primary, like primary procedure, but you might correct the alignment of the stomach. Go more to the, just before the last. And go there, and if you see more, you see, that's the last, how it looks, it's okay. You can see how it looks at the end. This is pre-pyloric, you go board, reduced up to 60% of the size that's happened after LSG. Now, this is the publication with our colleagues in multi-center study, 10% total weight loss in 1 year. This is how it looks afterward. You can do it after banding. This is the retroflexion for banding. And this is you see the stoma. This is the gastric band. You examine the stomach. Then you pass with overstitch system through the stoma. Go in the middle. This is the go. And you do your techniques. As simple as a primary procedure. So this is post-banding. You can do it here after what? Biliopancreatic. This is the stomach, the huge stomach, as you can see. And this is the anastomosis. Exactly, you go, and in mini bypass as well. You can go and narrow the stoma and placate the stomach. So this is another tool in your hand. So combined therapy, you can combine the revision also with medication, anti-obesity medication, and that will augment almost double sometimes the weight loss. And again, also this is for TOR or stoma reduction. You can use combined therapy. In addition to endobariatric, you use it with anti-obesity medication. So in conclusion, several endoscopic options to manage recurrent weight gain, both bypass, single anastomosis, LSG, are there in your hand. Endoscopic revision of post-bariatric surgery is safe and effective. TOR or stoma reduction endoscopic revision can result in up to 10% total weight loss at 5 years. And also, if you add pharmacotherapy, you can almost double that in some cases. And ESG result in 15% total weight loss as a revisional procedure and can be used for GERD, post-LSG, as I showed you. And it is better and safer to consider it before going for aggressive bariatric surgery. Thank you.
Thank you, Prof. Any question? Yes.
Great talk, Dr. Ail. Fantastic revisions on the endoscope, which we unfortunately were kind of behind as bariatric surgeons. Just as great as these technologies are, there's just a word of caution. I've seen rare occasions you get a patient with ESG and a TIF, and they still have GERD and a hiatal hernia, or they have a problem after multiple endoscopic surgeries. Now you need a surgery, and it can be a much more complicated surgery. That's all.
So your question about if you operate on somebody with endobariatric and there is a hiatal hernia?
Yeah, so what I'm saying is maybe a TIF procedure or a GERDIX on somebody who has a hiatal hernia or a sleeve migration, which unfortunately we see more and more of. I don't know if the
That's very good. First of all, endobariatric for reflux as a treatment of reflux is completely in the area of gastroesophageal junction, and there is no much of plication. So in generally, we looked from outside, you don't see much of plication. It's inside, it's within the junction is there, and I control it from outside because sometimes you do sleeve. I have done TIF with the sleeve and and Gerdix post sleeve, but you control it from a side. So there is no major worry. The beauty about anti-reflux procedure endoscopic that you can do Nissen after that, you can do sleeve after that, you can do any procedure. So, and of course we do C-TIF now, where we close the hiatus before the procedure, or C-Gerdix, as this is the other platform. So these are all options in our hand.
Thank you, Prof. Hawid. Very interesting presentation as always. Sometimes gastroenterologists refer a patient to us post-plication and you still find it difficult to remove the sutures or the anchors. So what's your advice when we sleeve those patients? Sometimes it's in our stapler line. So how to remove them properly surgically, and what is the way to avoid having them in our stapler line? Thank you.
Very good question, because in doing LSG after ESG, first of all, you clear it from inside. And this is what you've seen in the video. You see the anchors, you see the sutures, it's okay, take it out. Now, from outside, you might see anchors or needles in the wall of the stomach. So simply you avoid it either going medial or lateral to that point, and there should be no problem in that. Now, there are three options, as I said, for LSG post-ESG. One, you do endoscopy before and do laparoscopy later on, but you are subjecting the patient to two procedures. So that's maybe not the best option. The second and the best option is combined, as I showed in the video. You go there, remove from outside. The third option, and I don't advise to do it, it's done, it has been done, is just go blindly and transect the stomach regardless of what is inside. And I think this is not advisable and should be avoided if possible.
Yeah, any question? So, Prof, I have one question. Okay, now the patient, let's say he do laparoscopic sleeve and he regain weight. So when you decide, let's send the patient to the ESG or give him medication, or let's go to the bypass.
This is also very good. And I think, and as I said it in many meetings, that always as a surgeon or people managing obesity, provide all options and discuss with the patient all options. And this is very important for you. So the patient will come, post-LSG, gaining weight. If he is a candidate, go to the criteria and indication. Candidate for revisional surgery, the best option is revisional surgery. Mini bypass, RONY, whatever. Now, he doesn't like that. The next to that is endobariatric, because it's more durable, more sustainable, better weight loss in the long term. Now, if they don't like this, they say, well, doctor, I want something temporary, I will do my best to overcome, then you go for anti-obesity medication. If their weight only is 10 kilogram, maybe 15 kilogram extra and less, maybe anti-obesity medication is better. Between 15 and 20 weight regain or recurrent weight gain, no, endobariatric is better. If the patient is giving you the option and accepting all options. If not, then go what the patient will accept only.
Any question?
Okay.
Yes.
No more. Khalas, we'll stop.
Thank you, bro.
Okay. Thank you. Who's next? Yeah, you have it?
All right, next we have Dr. Abdallah Musa, and he's going to be telling us about primary endoscopic sleeve gastroplasty as a standalone GI facility.
Okay, assalamu alaikum, good afternoon everyone, and actually it's an honor and thank you for organizing committee to invite me, and it's making a little bit, it's difficult for me because there is two really expert figure in the endobariatric before me, and it will be difficult to discuss because in my lecture, almost of the slide is already mentioned. And the other thing, I talk with the people who's in the field of the bariatric and they know very well the obesity, how to deal with the obesity. If you compare to gastroenterology, usually we are dealing with the complication the most of the time. The field of the endobariatric, it just started in the 10 years ago, and it's growing. I'm just waiting the loading of the.
Is it a problem? We can go to the next until you prepare if there is an issue. Okay, go.
Yeah, okay. Good. So I think this is the slide is repeating and repeating and repeating because we talk about the obesity is trending up. And the worst thing, if you're looking just looking in the 2023, it's maybe reaching the world, the overweight and obese people almost 50%. And this is really a problem. If you're looking, the obesity, it's not a comorbid or risk factor now. It's a really disease. It's ending by the complication, diabetes, hypertension, ischemic heart disease, and it's a chronic. We have to follow the patient. You have to treat the patient and you have to follow the patient. If you're looking for the option of the treatment, as we mentioned, Dr. Kristen before, we have a lifestyle modification which is safe but less effective. We have the medication which is growing, the GLP-1, but the problem with the GLP-1, once you are in the medication, you have effect. Once you stop, most of the people, they are regaining weight. And the other problem, the long-term efficacy, we have a problem with this. We don't know how is in the long standing. Now, what about the surgery? The surgery is the best option for the patient, but the access to the problem for the patient because the patient is fair and is not fit. Now, what about the endobariatric? Endobariatric, it can fill the gap between the medication and the surgery and is less invasive and safe. Okay, and we looking for the endobariatric. What's our goal? It's our goal first, weight loss. We want the patient is losing weight, and we need a safe device and safe procedure. And the main issue also for the patient is the quality of life. He wants to be the enhanced the physical and mental well-being and comorbidity improvement. So, okay, so the question, do I need to shift the patient from the obese to the ideal weight or not? If the partial of the weight losses can help or not? This is one of the studies, it's randomized controlled trial, which looking for the 51 patient. And this is the one, it's looking just only 5% weight loss. And they found it's improving in insulin sensitive, increasing in the B cell function, and reducing the intra-abdomen and intrahepatic fat. What about 7%? This is another randomized controlled trial. It's around more than 3,000 patients, and they're looking for the pre-diabetic patient, only 7%. And there are 3 arms, placebo, patient in the medication, and patient just lose 7%. And they found the good things, the patient achieve this idea in the 12 months, they have experienced significant reduction in the incidence of diabetes mellitus. So you can prevent only 7%. Now what about, it's 8 to 20. There is a really large trial, which is randomized control trial. It's looking for the patient and the The patient is between 8 and 20. They found a significant improvement in the both diabetes management and blood pressure. And even with some weight reduction, still they have more benefit than one who is not losing weight. So, and we'll end it by this study. This is one of the study in the semaglutide, and the other study which is conducted by Prof. Fahid Al-Qahtani, and they look at sometimes if you're reducing weight of the patient, you get a benefit. And if you target the right people in the study, they target the class 1, and you find if you look in, there is a difference of the weight reduction 10%, but the comorbidity, there is no significant. In hypertension, diabetes, dyslipidemia, there is no significant between them. So the idea, do we need to reaching the ideal weight or not? This is what the study is talking about. If you target the class 1 in this procedure, you can have the same outcome in comorbidity for those patients. Now, we have many devices, especially in the last 10 years, and many procedures. And the devices are divided in two things, either in working in the gastric or a small bowel. So I will not spend time in the small bowel, just concentrated in one thing, in the middle one, which is the gastric remodeling. We have multiple platforms. We have the endoscopic sleeve gastroplasty, we have pause, and we have endomenia. And the main concept of those, one thing, they reduce the cavity of the stomach up to 70%. Now, I will talk about the endoscopic sleeve gastroplasty because there is a lot of the study about this one, and there is more than 15,000 patients already reviewed, and at the end of this review, they found that the 12-month total body weight loss is 17, 24, after 2 years is a 15, and after 3 years is a 14%. Which they are maintaining the weight reduction. And we have also small study with Reem Sharai. It's also after 5 years, they still maintaining 60% of them. Now, there is another study which done by the group, and they're looking for the cost effective. And the study they are comparing with the cost effective, the endoscopic and surgery and pharmacokinetic. And they found the ESG, or endoscopic sleeve gastroplasty, is the most effective in the class 1 obesity, while the laparoscopic sleeve gastroplasty is the most effective in the class 2 and 3. Now, what's in the future? What for the future in the endobariatric? There is a modification of the procedure. We do ESG, or endoscopic sleeve gastroplasty, or even the pose, and we can affect it also. We are not closing the fundus, all of the fundus. Maybe we'll close part of the fundus, but there is idea if we burning the fundus, will be increase the weight reduction or not. There is one study just they are still going on looking for the outcome, but it's promising. There is another thing which is abstracted in the last DW. They look on how we can select the patient. Usually we are looking for how is the one reducing the weight after the procedure, but what about the before procedure? So this is the study looking for the patient. It's a retrospective. There is a limited data, but the main issue they're looking for the gastric empty. The one who have gastric empty before the procedure, he's the one having more effect and weight reduction. Now, what about combination between the gastric remodeling and medication? They look at also the retrospective, and they found the one who take the medication after 6 months of the procedure, they have more weight reduction more than the one who take it before. What about combined between the two procedures, affected one in the small bowel and the other one in the gastric? If this, you will be pushing more weight reduction. It's a really promising. We are waiting the data for this one. What about its mimic bypass? This is the enteric gastric bypass, which is mimicking the bypass. Is this will be promoted of the weight reduction or not? Still we have thinking about it. This will be coming in the future. So we know the endobariatric is growing. So when we think about it in my region, In Al Qasim, we started one thing. So we started in the cluster thinking about, so we have a center of bariatric. The question, do we have to include the endobariatric? So we started discussion with our colleague in the bariatric surgery, which I think this is a very important thing. If you want to success anywhere, if you're not a good collaboration with the bariatric surgery, we cannot success. So then we are started the initiative, and we're looking for the initiative, and we created the plan, brainstorming, creating the groups, and they are started to looking for how we can help our colleague in the whole spectrum of the obesity, either in the complication treatment or either in the special population, which we are targeting the 35 to the 30. So we created the team, we have the goal, we set the goal, and we see the team is including in the bariatric center. It's just only specific for the endobariatric. And then we have started to do policy, guideline, review it, and the other things. And then we are making the clinical pathway for the patient who should be go to our endobariatric, who should be go to the surgery, bariatric surgery, who should be go to the endocrine, who should be no, we have to be back again to give him intensive life change and modification. And also, because we have to know what we are doing, we have to make a KPIs. Without KPIs, without monitoring exactly what happened, it's not a procedure and just forget the patient. As we mentioned in the beginning, it's a chronic. Maybe you hit him by surgery, he will come after maybe some years, he having gaining weight. You will hit him with the endobariatric. If you not follow him, you will coming with the again with the regain weight. So the idea, I think we are all agree, it's the patient reducing the weight, avoiding or preventing the comorbidity, and we hope inshallah we're reaching. And in the conclusion, the endobariatric are safe and effective and treated the obesity and metabolic disease. The endobariatric, we can use it as a primary for a naive patient, and we can use it in the endoscopy managing of the bariatric surgery complication, or including the weight regain. The endobariatric should be offered in the multidisciplinary care modules. Thank you so much.
Excellent lecture. Thanks so much. This is open for questions now. Question? All right. Well, I'd like to know your views on ESG in a kind of a standalone center. Is there enough volume to support that? Are there other things that need to be done as far as a bariatric endoscopist, particularly gastroenterology, within a center focusing solely on this? Is there enough kind of to keep you busy just doing bariatric endoscopy here?
Yeah, thank you, Dr. Chris. No, I think, yes, this is the main issue as a gastroenterology. Usually when you go in the field of the endobariatric, I think this is, you will busy is more than 50% of your time. So I think you have to more specialize on this one. The second thing, what we're facing, that's why we are creating the group, it's the cost. Usually when you're offering this procedure in the government hospital is a free, but the free is the hospital director and the financial teams, they are not allow you to do everything. That's why we have to targeting the people who is the fit, who will be help more of the patient. So we think, the best group for this patient, 35 to 30. Now from 30 to 28, with the comorbidity, we are still negotiated. We have to go to those type of patients or not, because we have a shortage of the funding for this procedure.
Excellent. And as far as integration with a multidisciplinary team, is that within the center? Do you view that as being part of the structure, or do you interface with that as a separate kind of institute?
Okay. So if you I will just describe the cluster. It's what's that mean? This is the area is under the administration, one administration. In our area, there is a 3 center of the bariatric. So what we try now is pilot study in one center to embed the endobariatric. And then if we see how much we are success in this, will be have to broaden the other center. But in my hospital, we have all the variety. We have bariatric surgeon, We have endocrine, we have the endobariatric, and we have the, for sure, the style modification dietitian, which I think it should be in the same hospital. It's difficult to the other hospital, at least in our area.
Excellent, thank you. All right, thank you very much.
So we'll move to the next. Dr. Assam Bataya, talking is one of the leaders in bariatric surgery in Jeddah area. Troubleshooting endoscopic sleeve gastroplasty.
Good evening, everyone, and thanks to the organizing committee. It's a great honor and pleasure to be among the distinguished speakers, and especially with our mentors. I changed the title of my talk to Tips and Tricks, just only to give a little bit of the other backwards of the endo sleeve. They show the pioneers what they did, the best things, and the things that which is good. But for me, as the least expert beginner in such a field, I would like to have it. This is my disclosure. So the available device that's almost everybody is start using it is the double scope channel, that it's fit in a special kind of a scope. So unfortunately, during the last era, unless you have this kind of a scope, you will have a difficulty that to have such device. But this is was solved a little bit later on. I will talk a little bit about the anesthesia and the issue of the type of anesthesia to be used, the CO2 insufflator and the need of it, and the helix, and this is the magic device that people they are using, some anatomical consideration, suture pattern, and some complication that I face my own. So in anesthesia, it must be under general anesthesia. You don't need to have the patient in a deep conscious sedation, and it will never be done with that way. And you don't need the patient to have any coughing or sneezing. You need really a good anesthesia. The other issue that sometimes the anesthetists, they suggest that it to be nasopharyngeal. It's not the endotracheal tube, which is not needed. Most of the patients that we are doing with the endotracheal, yes, you can pass the scope through the over tube, and you can pass it easily. If you need sometimes to deflate little bit the balloon until you put the endo sleeve. The other issue is the pneumoinsufflation. We know that during the endoscopy, you are using CO2 is a better and much more comfortable for the patient from the regular air. Especially that during the procedure time is not easy, especially for the beginners. Sometimes it takes more than 1 hour, or sometimes you have to do more stitches. That means more insufflation of air. This insufflation of air will cause post-operative pain. So you have to have such kind of these devices of pneumoinsufflation. And it's very important really, as much as possible, while you are going out, to suck as much as you can from that. And the magic instrument in the field regard the helix. This is the tissue that will be grabbed, and when you will grab it. As much as it is a simple, small, but it is very tricky. The helix itself, from the beginning to the screw sides, it's almost 6.9 millimeter, but this is in the old version. Maybe the newer version is lesser than that. The wall thickness of the stomach itself, from the thicker to the thinner part at the area of the fundus, it can reach to 2.6. So that's why take this in consideration, and this is very important. What you need always to take the anterior and the greater curvature, and try to avoid a very important area. What you need, you take only the wall, but there is always a structure or things that's behind it. And sometimes you don't need to see this. When the anchoring of the helix itself, if it's go much more deeper, it can lead to a problem that you will anchor a tissue behind it, and when you will grab it and you will take the stitch, this is really can hit and you can damage any organ behind it. So always take in consideration, can we play the video please? To avoid this especially and easy for the helix, when you just go there, usually we point the turn knobs and you ask your assistant when he's turning the knobs, when we take the bite, it has to be spiral and free. You can pull it and you can pull the tissue very freely. If you don't have this kind of maneuver, that's mean you are grabbing a tissue behind, and this grabbing of that tissue, it can really damage and you can have a problem with it. Another issue, anatomical consideration. So one part that you should always avoid to do any suturing in it is the fundus. As we mentioned, it is the most thinnest part, so this can perforate and penetrate easily. The other thing is the posterior area of the stomach, and can we play the video please? So this is another issue that to play the video. There is a very specific area at the upper part of the incisura where is here located. This is a very dangerous zone, and also here very high up to the fundus. Don't do any suturing there. Otherwise you are looking for trouble that sometimes can end with bleeding or perforation in such places. The last thing is about the suturing pattern. There is a lot of suturing pattern that it can people doing it. It can be the first bite number 1, then in the middle, then at the posterior. Then you go back again to number 4, then to 5, end up with 6. This is one type. The pattern that I learned from my mentors and with the most useful, I can say, way to do it. The last thing is regard the post-operative pain. Such patient, they will not have a smooth recovery unless they have really a nice good bites, but also this will never be without pain. So a significant times if you do any routine chest x-ray post-op, you will find some air under diaphragm, and that's really a cause of that pain. But this one, it also can be due to perforation, and this perforation can occur. So with the gastrography, this is a young lady that it was operated with ESG. She has a smooth recovery. She went home in the same day. But after 17 days, she started to have pain that it's never goes back and again and again. So she insisted that to be further workup and to see what's going on with this patient. We found this is a minor perforation. Most of the time, such small minor perforation, it can be treated conservative. But also I found in the literature, and patient can have even a perigastric abscess, and if especially with the clinical correlation, if there is a fever, there is tachycardia, all the features that if there is any really significant leak. So my second advice, when you cinch and to tighten your thread, when you're pulling up the thread, you try as much as possible to pull the thread to the maximum so that you can reach to that. And even though this is one of the cases that I, unfortunately, with the agonizing pain of the patient, I have to take her for diagnostic laparoscopy to see what's going on. This is the finding that I found. Yes, your stitch, it can be through and through. It can be until outside. You can see the stomach wall is the upper, and you can see the veins and the vessels for the splenic is just close to there. And yes, your bites, if it is too much high to the area of the fundus and you are reaching to higher area, you are looking for troubles. Now there is the new device, which is the Overstitch NXT. They overcome the obstacle that it can be used in a single port trocar, and it has a new beautiful thing that it can be overflexed with the bending, because if you overbending the other previous ones, unfortunately the channels cannot help you and you might not be able to do the job. So in conclusion, it's need to have a better practice to start and understanding the anatomy, observe the experienced endoscopist and be there, especially that to have gradually assisting and performing under supervision to take more responsibility. Thank you.
Thank you, Sam. Great points. A question, please. Okay, Badr al-Hadrami. Dr. Badr.
Thank you, Dr. Isam. You said one of the cases has minor leak. If we didn't respond to conservative management, what are the options?
What
the option for that leak after endoscopic sleeve gastroplasty?
She went very smooth with just conservative treatment.
No, I mean if she didn't respond, what is there any other like stenting, or you are going again inside and trying to fix the leak? Is there any other algorithm for that?
It can be done again endoscopically, but I would.
Is the perigastric collection or leak, can it be managed conservatively?
No, he said already it can be managed, but I mean if he didn't respond to conservative management.
If she did not respond to that conservative treatment, we should go for surgical.
Okay, thank you.
Okay, Dr. Abdul Hakim.
Oh, thank you, Assam, for your beautiful presentation. I have one comment, observation. I had a patient who had endoscopic sleeve gastrectomy, and 6 months later, she still had pain, agonizing pain. I took her to the OR, and I found that actually the stitch went through and through to the abdominal wall, almost to the rib, and the stomach was shaped like boom, and attached to the abdominal wall. So once cutting this, and she wasn't happy about the result as well, so I ended up doing a sleeve gastrectomy in her, and her pain went away.
That's why another advice, don't over-insufflate while you're doing the procedure. When you do over-insufflation of the stomach wall, it will start to distend it, even almost attached to the other structure. And the helix tricks that I just showed you, sorry that maybe there was a video that it was not working when I downloaded, but it was showing clearly how you can differentiate that you are grabbing a tissue behind, but it was very clear in the illustration, but I would love to show it to you in a video. Maybe I can post it later on, but it was, unfortunately, it was not working.
Thank you so much, Dr. Assam. Thank you. We'll move to the next talk.
The next speaker is Dr. Umar Sharif. He is a well-known gastroenterology intervention and endobariatric. He will talk about the endoscopy management of the post and are there available options worthwhile.
Good afternoon, everybody, and thanks for being here. And it's great to be after really great mentors in here, Chris Thompson and Dr. Adil Gahtani. And they are one of the leaders in the field here, and we're humbled to be that. I'm an interventional gastroenterologist, deal with biliary casing, got into endobariatrics. There are a lot of options that can be used in there. And to start with that is that, we're talking today about what are the options if we're having weight regain. We'll be speaking mostly about, post-gastric bypass, but a little bit about the sleeve gastrectomy and what can be done afterwards with endoscopic options. So the weight regain incidence afterwards, after metabolic surgeries, are 20-30%, and it's significant after that. Okay, so what can we do before we go to the surgical options? We have to know that endoscopic sleeve gastroplasty was started initially for this issue here, is to what can be used for post-gastric bypass, and the stitches are used for that. So anatomic factors that can happen that can cause weight regain is like dilated gastroduodenal anastomosis, enlarged gastric pouch or remnant, and obviously behavioral and physiological factors are the issue here. So we need to address that, and that is basically the bottom line most of the time. Poor dietary adherence, decreased physical activity, and metabolic adaptations.
So why endoscopic approaches? Minimally invasive alternatives to revision surgeries, lower morbidity and shorter recovery, cost-effective compared to surgical intervention, but we can talk about that because the cost of the devices are not as much. Nowadays, you can do endoscopic sleeve gastroplasty can cost even more than laparoscopic sleeve and with laparoscopy and stuff. So it can be done. In Bahrain it's a little bit different, and then in Saudi, and most of the stuff are done in maybe private practice and these kind of things. So it can be a little bit tricky when we talk about endoscopic versus surgical options. The potential for repeat intervention, if needed, is also another advantage of the endoscopic part, but again, it comes down to the cost, and we'll conclude with that. So endoscopic option for weight regain is basically you can do you're talking here about the bypass surgeries. The argon plasma coagulation can go to the stomas and ablate them, and by this way can cause stricture and closure of the stoma. Transoral outlet reduction with endoscopic sleeve or other devices that can be suturing of the devices, and or we can use TOR and APC, and we'll talk about the literature a little bit about it here. So argon plasma is a thermal endoscopic treatment to induce narrowing of the AG. This is meta-analysis for studies reviewed, including 828 patients. BMI division was 37, and total weight loss was 6.2, 11, and 5 after 12 and 24 and 36 months. So modest reduction with APC with that, with total weight loss. So something to consider with that when we talk about the options. This is a video Dr. Ayed, just informative, can show it in here. Just what are we talking about in here with endoscopic? So you can go to the middle of it. So that what happens is after the sleeve gastrectomy, so you see dilation of the pouch, the stoma can increase in size, and what we can do is with time, you see what's going on in here. The stoma will get bigger, and then the idea here is closure of the pouch itself endoscopically with suturing, and closure of that. And as we said, ESG was first approved, okay, and Chris Thompson is like one of the pioneers in this part in here, and a lot of the data comes in from what they've done, and it was done for this purpose here, is closure of the stomas with suturing. So can you fast forward, is like this video was shown initially, so you close the stomas and they can use APC to closure, and this is what the combined procedure is. And there are other techniques that come in, and we'll talk about them in a minute. I'll go to next in here. So TOR alone, this is a meta-analysis of 4 studies, 269 patients, full BMI data of 5 and 1.8 at 12 and 48 months. But you can see the data from Chris Thompson is like, you're talking about 6% initial studies, then 8%, and then eventually 12% with increased techniques and better techniques with that. So this is again one of the studies in endoscopic suture with transoral outlet reduction, again from Chris Thompson. Sorry, Chris, mentioning in here, but again, thank you for all the work you've done in this subject. The subjects who received TOR had significantly greater mean percentage weight loss. We're not using total weight loss in this study, but again, these are the initial things with reduction of this with TOR alone. TOR plus APC, there's a combination of both procedures. This is meta-analysis of 9 studies, 1,226, BMI division is 40. You see the weight loss 8.4, 6.8, 6.7. So here you're talking about, we're doing endoscopic procedure, and this is modest, but again, better than nothing is like weight loss with that. Or the options are other like what presented in the previous session number 2 is like Dr. Nimri and talk about extending the limbs and stuff. So endoscopy or that, again, the results are variable, but not that much. This is another 32 studies were included in this meta-analysis. 26 described full thickness endoscopic suturing, and the pooled were, again, at 3 months 7.3, 8, and then 6 at 8 months, and then at 12 months were 6.6. A subgroup analysis showed better APC plus TOR. And then when you go and modify the procedure more and use some of the pursuing with interrupted stitches, this again study from, again, Chris, all right? So 241 patients were enrolled, and Chris showed us a very nice video yesterday about use of hyperknife and how they do it. So different technique in argon plasma, and then the way you do the ablation, the way you do the suture with purse ring, with the technique, a little bit more difficult technique, you know, and we can find it difficult, but again, that can reach up to 12% of total weight loss reduction. So if you're talking about that option, and here we talk about, is it cost effective or not? Would you go for endoscopy or surgery with that? And if you can do something like that, maybe it's worthwhile. But if you don't do some of the other stuff, the technique that we show in the video is kind of simple. Anybody with good ESG skills can do it. But the other stuff might need some more, but there's more training. But it can be done. But it all comes down to cost and to the possibilities that can happen. This is a nice study, 1, 3, and 5 years between surgery and TOR here. And the adverse effects were much less on the TOR group than the surgery group. Smaller study, but again, promising results with that. So again, it gives an option, especially for those come in with that. When we talk about sleeve gastrectomy, you're talking about here the study that Dr. Aida showed. I did not mention the video, in the slides in here, but in that study, they included around 82 patients and for post-sleeve. And they can induce really good weight loss. More than 50% of the patients in Dr. Aida's study have shown reduction of 15% or more of total weight loss. So when you talk about sleeve, it's an easier option, and then you have an option of going to Roux-en-Y gastric bypass after that. But when you talk about Roux-en-Y gastric bypass, the other options are a little bit difficult. So endoscopy here comes in as a good approach. So the pros are it's a minimally invasive, shorter recovery, lower complication as we can show, but the cons is modest weight loss, need for adjunctive lifestyle changes, and potential for reinterventions. So are the available options worthwhile? For the right candidates, yes. Post-sleeve, maybe it's worth it. It can be done with ESG, and can do the remodeling, have good results with one good study in there. Fantastic. And success always depends on patient selection, multidisciplinary support, combination with lifestyle interventions. And again, if you can be in a good hand with a good person that can do excellent surgery in revision, yes, fine. But again, the cost comes down to the cost. I had a few patients that we've done these cases in Bahrain, and they had good results, but not that much of good results. And then you come down and tell them, come by and get a procedure with the increased cost of ESG for those cases and with modest results versus going for a major surgery and going through bypass and doing bypass again. Which will you choose? Not an easy answer, but I showed you the options, and it is worthwhile in certain patients, and it is a debatable thing. We need more studies, obviously, for that. Thank you.
So, any question? Yes.
Thank you for the excellent review on the topic. One thing we're noticing in the United States is that we have many patients that are eligible, but very few end up getting this procedure. So I'm wondering what your thoughts are on, why maybe it's not been widely adopted and what needs to happen to make it more readily available.
Well, having it more readily available is having really a more cost-effective endoscopic solutions for that. So if we talked about maybe some kind of a suture that you guys are working on, if it's going to be cost-while or not, then the available devices, then it might be easier. So you can try that with less cost. And AGD will cost us nothing. If the suture is not expensive, then we can do that easily. But if the suturing device will cost me that much, then of course it's not available. And then it comes down to who has insurance, who has not, public in a public university hospital versus in a private practice. All these are factors. So to modify is better training. So getting a lot of people now being very familiar with the devices, having more into bariatric. It's a booming field between surgeons and gastroenterologists. And we got the medications that are available that can be helpful. It comes down really to cost and available options in there. I think that's the worthwhile, Chris. So the work you guys are doing in advancing technologies, maybe making it more this, maybe, and it's always comes down to cost and who's paying for that.
But the question back to you, Chris, the barrier in your patient that they are not coming, is it surgeon or referral, or is it patient themselves, or is it what?
Well, we have a lot of patients just from word of mouth because we've been doing it for so long, but we train fellows that go out into their practices. We've trained 35 fellows, and they have problems getting patients. It seems like a lot of patients get limb lengthening, or they were getting band over bypass, or several other procedures rather than this. And it's just kind of hard to understand why, because the data is so supportive, and there's more groups publishing on it as well.
Maybe the physician who are treating these obese patients with the weight recurrence is not familiar or not willing to refer them to.
Correct.
Yeah.
I just got one question. Is it covered by the insurance, the toll?
Yes, actually. Actually, in the United States, it's pretty widely covered. Fistula revisions and revision of dilated anastomosis seem to get pretty broad coverage. It's just the patients don't seem to find themselves to the doctors that can do it. They tend to have other interventions instead.
And just one question for Dr. Omar. Now, for the EBC, you will just burning the gastric side or the gastric and the small valve?
I think the outlet is the one that you go and touch by, is making it a little bit more stiff so that it can be more available to do the suturing on it as well. And maybe Chris can give us his wisdom about on that aspect of how the APC is being done with that. Because the techniques, as you're using the hyper knife and having better cut, because the APC might not be very good on doing that effect that you want with the thing. And maybe Chris, I think I would revert the question to him.
What do you do? I know you prefer to do EST and...
I do. I prefer to remove the mucosa with a modified ESD technique and place the stitches in there. I think it's more durable, and it's fairly easy to do once you've learned the basic techniques. And I think that does get us up to over 12% total weight loss.
What's the limited for smalling or shortening of the, just you go back to 1 millimeter, or there is balloon using or what exactly?
So we use a balloon to size it at about 8 millimeters. Yeah. Otherwise, it tends to get strictured. Yeah.
Okay. Any question? Thank you, Dr. Thank you.
So that's you. You will be presenting me, as usual.
And finally, bring it home. We have Professor Al-Qahtani, and he'll be talking about how to incorporate endobariatrics into practice.
So I think if some of you will say, how I do it, how to start. So we'll tell you how to start. That's the way to start. So first of things is didactic and educational video demonstration. That's what we do. So we will use it. There are a lot of programs for training and educations, and these are the steps. The second is hands-on dry lab, and I will show you how is it done. Then hands-on wet lab, and then live surgery. You immerse and you go there with the operators in the operating room. We call it the endoscopist, whether gastro or surgeon. And then you do proctorship, whether through mentorship type of, you go with the surgeon or the operators, or he comes to your place and you start doing it. Now the learning curve, there are 3 learning curves. One, to learn the scope itself. So some of you are familiar with the endoscope and the scope, and it's not a big issue, but there are some tricks that we always saying. In usual endoscopies, you have to turn the scope and twist it right and left. In ESG and others, it's mostly relying on your body movement and wheels movement. These are the most important. Then you learn about the system, the device itself. Loading and loading, this is very important until it is recorded in your brain and intuitive, and you do it without thinking about it, like driving your car. This is very critical. That's the next step. The third step, when you master these 2, you go to the third learning curve, which is doing the technique inside the stomach. Anterior wall, posterior, where to put the bite, what is the next bite, where to stop, where to go back, when to tighten, and how to tighten. This is the third and the most difficult one. You must maintain the symmetry and the alignment of the stomach, and this is very important. So didactic, those who are surgeon or maybe internist or anybody who's dealing with obese patient with obesity, fair, you know the disease, you know the treatment. But if you are a gastroenterologist who never seen a patient with obesity, of course you have to know the disease. And I always say this, patient will not come to your clinic to say, I need endoscopic gastroplasty. They will come and say, well, I want to lose weight. What are my options? So you know the options. So you give the option, you give them the disease, you understand the diagnosis and indication and for all modalities. And why you are selecting endoscopy and not anti-obesity medication? Why not surgery, doctor? So you have to tell them about this. So this is the didactic where we give them this demonstration, video and educations and the devices. We tell them about the device and how is it done. We tell them all about component to the device. We go there to dry lab and we tell them how to load and unload the machine on the screen you see, and you are doing it on your own. And then there is single, this is the video to show you, this is single channel scope, but there is also double channel. Maybe eventually you will not have any more double channel supplies, you will be only working with single channel, so that's another scenario. And this is where you do it until you master it on the scope. So this is dry lab. Then you go on, after that, on animal labs. And then this is the pig stomach where we demonstrate how to do the procedure on the animals. And it's exactly like what you do it in a human, even more difficult. Anterior wall, posterior wall, you tighten, you do all maneuver and switchers. After that, we take you to the OR, and this is the OR, the setup in the operating room, how to do it in the operating room. And this is very important because here you can see where to position the patient, where to position the back table and the supplies of your instrument, where to position the monitor, and you go and do the procedure. So this is intraoperative setup. And this is also, you get familiar with it, you go and you will be exposed also to doing some steps in the procedure. Then usually, this is very common question, how many cases, doctor, I need to do? So most of the time, it is 8 to 10, you will be, depends on your experience, if you know you are advanced endoscopist or no, but in general, 8 to 10 cases is enough to say, I will be sitting on the chair and looking to troubleshoot whatever you are in. But you will be, when you pass 30 cases, you are really somebody safely, you don't need somebody around you to help you inside the operating room or in the hospital. And it is mentioned here, as you can see, that 10 cases will give you some skills that you will be performing the procedure without interference, while 50 to 100 will give you proficiency, and 100, more than 100 will be expert. That's the most standard learning curve. Now, proctorship is very critical for anybody, and I advise anybody, like those who were with us in the workshop yesterday, you go there and plan your start. Don't wait for 2, 3 months, 6 months. By the way, 80% of those, in general, not only in endobariatric, who's doing workshop, they don't continue doing their procedure. They're doing it and they forget about it and they are busy. So if you are willing to start, do the workshop and plan your next step. And somebody can come with you. I will be happy to support you or other colleagues in your place, or you come with us for a while and then we go and support you. But don't start alone. Don't feel you are okay. No, bring somebody with you to help you, because yes, maybe you are doing the device, but there are a lot of things around you don't recognize it. Sitting the tower, sitting the irrigation, sitting the machine, sitting this, and then all of a sudden, oh, what should I do with this? You were not exposed to it during your training. So this is very important. Now, ESG can be integrated into, as a primary procedure, as has been explained. You can combine it with other anti-reflux procedure, and you can use it for revision. So it is very good tool in your hand. And again, this is the indication, BMI more than 35, surgery is definitely better. Between 27 and 35, ESG is better. And in between, you can figure out what to do for your patient. Now, these are the standard indication, where 18 and above, 30 BMI, but we go nowadays to 27 BMI. But for anybody who's starting, start with the clear indication, and then later on you go above the boundaries. Contraindication, hiatal hernia more than 3 centimeter, or any like coagulations or bleeding issues, or esophageal varices. Don't do it. Then the next day, so this is also very important. After you do this, you have to be engaged in multidisciplinary team, and we'll talk about it. But you have to give labs, routine lab, clear liquid 1 day before surgery, and if they are in GLP-1, maybe 2 days before surgery, and stop GLP-1 before. On the day before surgery, clear liquid, you give the antiemetic analgesia is very important. Give them rehydration on arrival to the operating room because they are day surgery, proton pump inhibitor and antibiotic. And then post-op and intra-op, this is the standard management, analgesia, antiemetic. Positioning can be left supine or left lateral or supine. CO2 insufflation is very critical for all cases. And over tube is optional, but do it on the learning curve. ABC, do it in the learning curve, but not mandatory. Ensure the safety after you finish. Irrigate, check the esophagus, check the stomach, check there is no problem there. Post-op medication, this is what we discharge the patient. With regard to antibiotic, sometimes you give it for 1 day, 2 days, maybe two doses. There is no science. It's up to you. Discharge medication, antiemetic, analgesia, BPI, and sacral fate. And usually we give it for 2 to 3 months. PPI, but others only for short term, 1 week or so. Vitamins only for 2 months, and then they don't need it. Essential is follow-up. This is very critical. You see them 10 days before, after surgery, and you see them monthly, and you see them every 6 months, monthly for the first year. As again, multidisciplinary must be part of your protocol. If you have it as a surgeon or a buddy, okay, they are there already. If you don't have it, go and establish it or work with a surgeon and obesity management team. I went to Romania to operate with a gastroenterologist who had no clue about obesity. But the patient came from bariatric surgery and the surgeon was with us in the room. So he is providing the patient, the endoscopist will operate, but eventually the patient going to the same cycle of the surgeon. So he's seeing the procedure with that, he understands the whole concept, and he's managing it. That's one scenario. Or you go and learn the disease and learn everything. There are a lot of scenarios that you can learn from this. Now, dietitian should be essential, and I advise you to see the patient before surgery, not after surgery. And then they do the behavioral and pre-op and post-op management. This is our protocol for dietary protocol for ESG. And it's not different than sleep, but there is a little bit more easy for the patient. It's the same thing, all stages of dietary. Post-op, same protocol, 3 days and 1 week, and then the same as ESG. Nurse is very important. Anthropometric measurement and the same as bariatric nurse. I'm saying this for those who are not familiar with multidisciplinary teams, so they understand what is it. And clinical coordinator is very essential. She's the point of contact for the patient, for doctors, for nurse, for dietitian, for anybody. This is very important to be part of your team. And then internist, if you are not managing this patient, you can have an internist also to give them whatever necessary medication for their diabetes, hypertension, or even for their control of their problems. Anesthesia must be familiar with your techniques. Don't be surprised with every single anesthetic coming to your techniques that they have not seen before. So today one anesthetist, next day another anesthetic. No, you organize your team and get the anesthetist already like what we do. He's familiar with your protocol to avoid mishaps in the operating room. There are a lot of predictors for outcome. And here, this is the last 2 slides, but if you have more follow-up visit, 24 visits a year, you will improve the outcome. If you have these visits will improve also eating behavior changes. So they will be eating more frequent diets, they will be organized in their eating, speed eating is eliminating, binge eating is eliminated, also snacking, and also sleep is improved. So reinforcing these parameters and behavioral change will improve your outcome. And other things is there. So in conclusion, yes, you need to start, if you want to start into bariatric, these are the parameters, develop the team, know the techniques, there is didactic, there is video, there is workshop, there is hands-on, there is OR, and there is proctorship. Thank you.
Thank you for the excellent summary. Open for questions.
Mike, Sam.
Within the fellowship?
I think it's important to be exposed to it because I know now they put in the fellowship 2 months or 3 months, 2 months, 2 months mandatory to do endoscopy. So if they put these two within as a program and put a mandatory for the program that's providing 2 months rotation to have endobariatric in that will be great things to do. Yes.
So you don't think it's a must?
I think it should be. I think it should be. Because there are a lot of tools we do. Even if you don't know it, it will solve a lot of our problems. You can see even structure. You can do BOEM and you can do like structuroplasty and myotomy.
No, because like we have the fellowship now, what we have is we have bariatric surgery.
Yes.
And we have bariatric medicine in it.
Yes.
So I think knowing all the 3 options, knowing them well, is I think very important.
Absolutely, I agree. Yes.
I would like to thank you for your nice presentation. I want to ask about general endoscopic methods. After widely use of these treatments, endoscopic gastroplasty and other techniques, some patients have begun to apply us without success for revisional procedures, revisional surgery. Do you advise something special or for treatment for these patients to do? For example, there are some stitches still remaining in the stomach. Do you advise to remove these stitches, or do you have any advisory for these patients who is going to undergo a surgery after
I think you should remove all sutures before doing the procedure, but it can be doing combined procedure. During surgery, you do. If you are familiar with endoscope, do it yourself. You are not, get the gastro, but there is a scissor, they call it E-scissor. It's a very strong one, like a laparoscopic scissor. We cut the suture and we take the needles. Dr. Omar?
Doctor, I think, answering Dr. Sami, thanks a lot, Dr. Sami. I know you've been a mentor a long time and relate with that. But again, we always talk about this as like a surgeon or a gastroenterologist doing this kind of procedure. Because, I think it comes down to your endoscopic skills. Because it's coming down and down that many surgeons are doing less endoscopy than gastroenterologists. The gastroenterologists, we do like, even if doing colonoscopy or an endoscopy, it's much easier for us because we do high volume of that and makes doing this procedure and the maneuvers endoscopically much higher. I'm biased as a gastroenterologist than a surgeon. But I think it comes down to not every surgeon can do endoscopy like you, Dr. Aid, have done a big volume with that and you mastered this kind of procedure. I think it comes down to your endoscopic skills. If your endoscopic skills are good enough, then I think the bariatrics should be incorporated in your practice. Maybe later on something like robotics would take off that kind of thing and it can be all done. Maybe the surgeons will take over this kind of a thing. But I think that what comes down to it is your endoscopic skills to proceed with this kind of thing.
I'll tell you, look,
because
no, they have a huge demand on the endobariatric. But let me, this is very important. Both of you are right in a way. To be exposed to endobariatric is very critical in bariatric era nowadays. Yes. Whether to do it or not, that's up to you later on. You want to expand your knowledge, fair. But at least to know there is good option there, and there is positive and negative. Like, for example, ENT surgeon, they do 2 years in general surgery. Not because they want to do general surgery, but they understand the disease. 100%. So it's the same thing for endobariatric. So it's very important. But I like the concept of calling it endoscopist. Endoscopist, for example, we were operating in Sao Paulo, and Chris Dr. Thompson were with us there. In 25 rooms, all of them full of endoscopic procedure for endobariatric, complication primary, and none of them is called surgeon or gastroenterologist. All called endoscopist. They see the patient in the clinic, they admit and they do the procedure. We don't know what is their background, whatever it is. So this is very important, but at the end of the day, I think we should include endobariatric in our concept and practice. Yes.
100%.
Okay, maybe it's up to you as a chair. You want to continue or? Yalla. There is one question there. I think he's in need for that question. Quick.
يعطيك العافية دكتور عايض.
Thank
you very much for the high-tech demonstration of the techniques. But I just wonder if we could involve endoscopic ultrasound at the top of the technique to assure the full thickness of the gastric wall, as well as to prevent anchoring the surrounding
You are sophisticated. Now, the good system, the new system for Apollo, it's called Next. Now, the helix will not go beyond the wall most of the time because it's very thin, it's very soft and does not go. So I think that's solved. And again, there is always a trick I tell. When you go to turn in the wall, just bring the wall to you and go another third turn, there is no problem. But don't inflate the stomach to maximum and still continue with the helix more than 3 turns or 3 turns even, because that can go easily outside the wall. Stomach is stretched, thin, and you are going outside. Deflate a little bit the stomach, go 2 turns, bring the stomach to you, go more, you will be okay with that. And the new system, a single anastomosis, a single channel scope Next is okay with that, will not cause that problem.
Follow up to that, actually, there's been some research out of the United States, Chris McGowan and some others, that have been looking at rat tooth forceps instead of the helix to grab the tissue and pull it in. What are your experience or thoughts on this?
I'm not sure the forceps, do you think it will get the full thickness?
I don't know.
I don't think so. I think it will bring the mucosa and will not solve your problem.
Even if he's the boss.
We'll just interrupt you. I agree. Okay.
Oh, thank you, bro.
Yalla.
So we'll do the sessions back to back. We'll try to limit the questions so we allow you to go, but don't worry about going to dinner because we'll have buses all the time. So you can go anytime.
Assalamu alaikum wa rahmatullahi wa barakatuh. I welcome my dear colleague Dr. Abdullah Al-Mas'ud, bariatric and minimal invasive and abdominal reconstructive surgeon. Dr. Abdullah Mas'ud with us. We will back to the real common general and laparoscopic bariatric cases. I'm honored to introduce Dr. Abdullah Al-Zahrani. Dr. Abdullah Al-Zahrani is a senior bariatric and minimal invasive surgeon, one of the earliest surgeons who started the practice in Prince Sultan Medical Military City in Riyadh. We honor to have Dr. Abdullah. Please, Dr. Abdullah, please limit it to your time.
Thank you very much. Mr. Chairman, Co-Chairman, dear colleagues, I'd like to thank you all for attending, and I'd like to thank the organizing committee for giving me the honor to be with you. My lecture is focused on one specific technique in the sleeve gastrectomy, and I've chosen this one because, as a matter of fact, the sleeve gastrectomy constitutes of more than 60% of the performed procedure. Sleeve gastrectomy, since its recognition in 2009, has been booming due to its simplicity, reduce overall risk, and unfortunately it is associated with high risk of revision and other complication, though minor, but it does affect the quality of patient's life. The sleeved stomach has an altered anatomy. The stomach is fixed to the following surrounding structure with multiple ligaments, and all of them are disturbed except the hepatogastric ligament. If you are adding hiatal hernia dissection, then the phrenicoesophageal membrane is divided, and then you are leaving the stomach hanging to nothing but the hepatogastric ligament, and I would leave you to think of what could be the problem of doing this and having an unbalanced traction on the stomach. So once you have divided all these ligaments, you would expect to have an unbalanced traction, and that will have a relative curvature twist angulation and volvulus of the stomach. And there is no way you could mitigate this unless you restore these natural attachments. The esophagogastroamentopexy restore the normal anatomy and the natural fixation, and that shall lead to a smooth curvilinear stomach with balanced traction around the stomach, no twist, no distortion, and wide, smooth incisura, and intra-abdominal fixation prevents proximal migration. Additional benefit is buttressing the stapler line and reducing the both bleeding and leak. In literature, you have seen from 2017 more and more literature and evidence is coming on the importance of esophagogastroamentopexy. Imad et al. In 2017 on 250 patients study have concluded that staple line inversion is associated with less bleeding and bit more operative time. Poyer et al. Reviewed a systemic review in 2020 for a study of 1,300 plus patients, and they have concluded that laparoscopic sleeve gastrectomy with omentopexy has significantly lowered overall morbidity compared with LSG without. And as you could see there, the relative risk reduction of gastric leak is 0.07, and there was no significant difference between the two groups in terms of hospital stay. The other evidence is from Shank et al., and they have looked into 11 randomized control studies with around 1,100 patients, and then you could see the omentopexy has reduced the bleeding by more than 2/3 and leak by more than 2/3 as well. And they have concluded the same thing. The omentopexy does reduce bleeding and leak. From 2019 to 2024, there are multiple studies that have been done. Kian et al. In 2023 have looked into 13 studies with 3,500 patients, and as you could see there, they looked into the nausea, vomiting, reflux, bleeding, leak, and gastric torsion. And these are the commonest complications we encounter following sleeve gastrectomy. And you could see how much these has reduced following omentopexy. Another study by Shawush et al. Again in 2023 with 13 eligible study of more than 5,500 patients, and they have looked into the same thing, and you could see that as well. A leak has reduced with an odd ratio of 0.2, bleeding of 0.3, twist of 0.09, and so on with the rest of the complication. If you look at the post-operative GERD, odd ratio of 0.5 in those patients who had omentopexy. Ali Yassin has published a nice review in early 2023 and published in Obesity Surgery 2024, and you could see the gastric leak and the stapler line hemorrhage. As you could see, the stapler line hemorrhage has reduced by more than 10 times in those patients who had omentopexy, and the stapler line leak has reduced with almost similar result. And I think this is very important for those who are doing sleeve gastrectomy. If I could manage to zero these two complications, that would be an achievement. If you look into the gastric torsion, from 1.2% to 0% following omentopexy. If you look into intra-abdominal collection, reducing from 0.9 to 0.2, GERD from 11% to 9%, and the readmission from 2.3 to 1.4. If you look into the reintervention, has reduced from 0.9 to 0% and no significant difference in the length of hospital stay, and there were 0 mortality in both. And they have concluded what you have yourself observed. It has dramatically reduced the incidence of leak, bleeding, intra-abdominal collection, gastric torsion. Abdurrahman et al. Again looked into 17 comparative study of total 7,000 patients, and this is not peer-reviewed or published yet. And they looked into the odd ratio between the omentopexy versus no omentopexy, and they compared randomized controlled trials versus cohort study. They both concur with each other, to be honest with you, and that all have shown clearly significant improvement in the outcome of those patients who had gastromentopexy. And I would pick up some of these for time's sake. If you look into the post-operative bleeding odd ratio of 0.32 in the randomized controlled trial and 0.32 in the cohort study in favor of omentopexy. Post-operative leak as well, 0.37 in favor of omentopexy, and the prolonged nausea, vomiting, and gastric torsion has significantly reduced in the omentopexy. Readmission has also decreased with an odd ratio of 0.21 in favor of omentopexy. GERD odd ratio is 0.36 in those patients who had an omentopexy, along with the use of anti-acid medications as well. In conclusion, sleeve gastrectomy alters the normal anatomy, and that can lead to structure-related complications. And these related complications cannot be mitigated except by restoring near normal anatomy. Gastroesophageal omentopexy is a simple and important step to address the structural-related complications, and there are enough evidence confirming the benefit of omentopexy, and I would suggest omentopexy should be an essential step in the sleeve gastrectomy. Thank you.
First of all, I would like to thank you, Dr. Abdullah, for your adherence in that time. Thank you. We will have only one question from the audience before we move. Dr. Bawahab.
Thanks, Abdullah, for this nice and elegant presentation. And you touch a very important point that I was implementing this step in my procedure, my sleeve, for the last 7-8 years. My question, through your reading and going through the publication that you mentioned, did they describe how they do their omentopexy? Is it a continuous suture or just interrupted? And what type of suturing? Absorbable, not absorbable? And what you're doing in your practice? Thank you.
To choose whatever, as far as you get the omentum fixed to the stomach, whether it is interrupted or continuous, as you all know. If you are just doing it for sake of fixing the stomach, then interrupted will be okay. If you'd like to add benefit of being hemostatic, then I would expect continuous to be of value. I personally, first of all, I tailor the omentum. I take an omentum or greater omentum that is fitting the size of this new stomach. I fix it to the upper border of the left crust of the diaphragm, just beside the esophagus, and I take 1 or 2 sutures in the esophagus to fix it intra-abdominal, and I take the stapler line down to the pylorus, a continuous suture. The most important, once you got to the incisura angularis, try to converge the sutures, taking wide at the greater omentum side and narrow at the incisura in order to open it and make it a smooth curvilinear at the incisura angularis.
Thanks.
Thank you, Dr. Abdullah, very much. And we will call for the second speaker.
Next talk will be presented by Dr. Amani Dosri. She's a general surgery resident. On behalf of my colleague, Dr. Naif Al-Anizi.
Assalamu alaikum. Good afternoon. It's my pleasure and honor to present in front of you. So today I'll talk about a very important question. Is sleeve contraindicated in a patient with a symptomatic GERD and hiatal hernia? So let's go thoroughly about GERD and the normal physiology and pathophysiology, but I'm going to speak about it briefly because earlier we were talking about it. Next, please. Okay. So we have the definition of gastroesophageal reflux disease. Then we have the updated to the modern diagnosis, Lyon Consensus 2, was published on 2024. The definition per se, it's about the conclusive evidence of reflex pathology on endoscopy and or the present of the abnormal reflex monitoring in a patient who is symptomatic. So as we all know about GERD and hiatal hernia presentation, most common, the patient will present with a heartburn, chest pain, dysphagia, and regurgitation. So as we know, the normal physiology, it's more focusing in the related to the GERD about the lower esophageal sphincter. We know we found the lower esophageal sphincter in the gastroesophageal junction. It's the important function of it to prevent the gastric content to move to the esophagus. So the normal physiology for the lower esophageal sphincter, it's all about the closed position. The most important structure here, we have internal sphincter, external sphincter, and lower esophageal valve, plus the crural diaphragm as well. So what's the most important here? Why GERD always related to the obesity? What's the pathophysiology related to that? So we know that the obese patients are pronounced to have a hypomotility, especially in the esophagus. There is a decrease in the esophageal clearance, this leading to a GERD. Although we have an increasing transient lower esophageal reflex resting because of increasing of the BMI and the abdominal circumferences as well. Although the obese patient has a high prevalence of hiatal hernia due to the separation of gastric esophageal junction and crural diaphragm. Lastly, increasing the gastroesophageal pressure. For 1 PMI increase, this leads to 10% increase in the gastric pressure. So, to summarize, the most common causes for the GERD and hiatal hernia due to the incompetent lower esophageal sphincter, due to pyloric stenosis and esophageal motility disorder. So, as we know all that the preoperative assessment for the GERD, it's mainly the gold standard is ambulatory pH, then going to esophageal manometry, upper GI endoscopy, and perium esophagram. So we have here the classification. We have two classifications, HELL classification and AFS, which stands for American for Gut classification. The HELL classification focusing more about the valve flap, whereas the AFS classification, it's about the valve flap plus the endoscopy finding and the results. So back to our question now. Does LSG is contraindicated in a patient who is having GERD and hiatal hernia? So let's go thoroughly about the laparoscopic. Laparoscopic bariatric surgery, sleeve per se, has generated a lot of interest due to its effectiveness in the way for the weight loss, for the safety profile, and improving or resolution of the comorbidities. Here we have a study done the effect of LSGs on GERD. The study was among 191 bariatric surgery candida. They studied the preoperative and postoperative GERD upon 1 year follow-up. Mainly the diagnosis of GERD was basic on the questionnaire. So to conclude the results here, they're saying that the patient who has a GERD preoperative and underwent to hiatal hernia repair, they have a significant improvement postoperative. and the patient who had a preoperative GERD with receiving a medication PPI has also significant improvement post-operative. But for them who have a pre-op GERD without any intervention, there is a significant increase in post-operative GERD symptoms. So to conclude for this study, they want to again discourage for the patient, to discourage the patient who wants to go with the LSGs but has a GERD. They support that the patient who has a GERD symptoms, they can went to LSGs. Another study here, it's about a meta-analysis. The meta-analysis done for a total of 8,092 patients who underwent LSGs. It's a pre-op assessment and post-op. Here we have a different study. For example, we have a winner, the study among 120 patients with a follow-up 2 years. It shows there is a decreased post-operative symptoms and also decrease the needs of using PPI. In addition to, we have Rebecca as well, 65 patients with a follow-up 2 years, decreased GERD post-operative and decreased use of PPI. In another hand, we have Kathleen also, they mention or they study among 45 population. They said that there is an increasing of post-op GERD and also increase in need of PPI. Zenge as well, they also study among 200 of patients with follow-up 1 year. Also, the study where that it's a similar effect pre-operative and post-operative and no decrease or increase in GERD symptoms. So it's a multivectorial relationship between LSG and GERD, but the majority of the study, they went and encouraged that to proceed, there is an improvement post-operative GERD regarding to LSG. Here another study or another paper describing the gastroesophageal reflux and parrot esophagus with a possible complication for a long term. This was done as an observational cohort study among 162 patients. The significance for this study, they focused on 3 factors. The first one, the esophagitis with the classification of Los Angeles. They focused on the diagnosis of GERD based on endoscopy. And also they compared the result pre-operative and post-operative with the hiatal hernia repair. For example, in table 2 here, they said or they conclude that a grade A and a grade B for Los Angeles classification, they saw the result was due to the increasing prevalence of post-operative GERD rather than in the severe grade C and grade D and parrot esophagus. For the table 3 here, there is a comparison between sleeve gastrectomy pre-op and post-op with sleeve gastrectomy as well in relation to the hiatal hernia. They mentioned that there is a significant improvement post-op with the hiatal hernia, but due to small population, because the study was only on 18 patients, it's limited and it needs more further study about it. Which is lead to this paper. This paper is focusing more about sleeve gastrectomy and crural repair in obese patient who underwent sleeve gastrectomy. As we see here, we have a total number of 97 who underwent hiatal hernia, and the patient here a total number of 281 with a sleeve gastrectomy alone. The remission, and comparing with the hiatal hernia, 57, and with the hiatal hernia, the remission was 80%. For the improvement in hiatal hernia, 12%. For the persisting, we can see here in hiatal hernia repair, 7.5. Whereas in de novo, it will be 0 with the hiatal hernia repair. Finishing with a gastroesophageal reflux and laparoscopic sleeve gastrectomy, this is an international consensus conference. The international consensus, they distributed in a questionnaire and they voted for specific topics. For example, here we have the first one, the preoperative GERD symptoms. Is it mandatory to do upper GI? They consist with a 91%. For the parrot esophagus with the intestinal metaplasia, contraindication for LSG, they went with the 95%. For high degree esophagitis, contraindicated for LSGs, they underwent it with 93%. Post-operative routine upper GI after LSGs, they went with 77%. LSGs and hiatal hernia repair. If the patient is asymptomatic, they went with a 66%. If it's a small hiatal hernia, they went with 80%. Lastly, Rho and Y, after LSGs with the severe GERD symptoms, they go with 75% consents. This is a sample of the questionnaire that were distributed. So, comparative outcome for LSGs and gastric bypass. For the gastric bypass, 70 to 90% reduction in GERD symptoms, whereas a sleeve gastrectomy, it's a variable, individualized upon the patient. Some of the patient will get worse, and some of the patient will get improved. So here we have a current guidelines and recommendation. In a patient with a sleeve gastrectomy who is presenting with the symptoms pre-op, we're suggesting an endoscopic evaluation post-operative. For the patient who is asymptomatic, we go with the screening 3 years, then 5 years later. For a patient with a parrot esophagus, we go with a surveillance guideline. So, in regarding to the hiatal hernia, if there is an aggressive identification of hiatal hernia intraoperatively, the consents were 83 to fix it during operation. Hernia should always be repaired if it's found, 82 consents. The post-operative diet, 100% should be started with solid food after 2 weeks. For the GERD, for the first line of treatment is PPI, they went for 85 consents. So, to summarize, clinically recommendation, preoperative definitely assessment for the patient. For the patient who has a GERD symptoms, we have to identify it and define the degree of the grade, if it's mild and moderate. After that, we can decide, do we go with LSGs or Rho and Y or hiatal hernia repair. And definitely long-term follow-up, post-operative for the patient who had a GERD symptoms. So in conclusion, no absolute contraindication for the LSGs in a patient who has a GERD or hiatal hernia. But if the patient has a case of a severe GERD, depend on the diagnostic criteria that will diagnose a GERD or a parrot esophagus, we recommend to go with Rho and Y. Thank you very much. For further questions, you can ask Dr. Najla.
Thank you, Doctora. If you can stay with us for one question, if we have one question for the speaker. Okay, thank you very much, Doctora.
Thank you.
Thank you. If I can call for Dr. Khalid Al-Ammari, he will talk to us about fund duplication and or Rho and Y gastro bypass in severe GERD, and we will have an experience from Sultanate Oman. Dr. Khalid.
Assalamu alaikum. First of all, I'd like to thank the organizing committee presented by Prof. Aid and Dr. Osama Sani for inviting me to be here in front of you. I'm going to talk about surgical management of severe GERD and large hiatal hernia. Which option will go for fundoplication or Rho and Y gastric bypass. I'm going to explore the evidence behind everyone, and before I draw the conclusion and algorithm how to deal with this problem. 20% of population considered to have GERD symptoms in normal population, GERD symptom. And this number increased up to 30% in obese patients. And this is attributed to the increase in the intra-abdominal pressure. And I think Dr. Amani talked about the pathophysiology and of GERD in very well manner. But in my presentation, I focus on few studies that established very good correlation between the increased intra-abdominal pressure and GERD, and to show the difference between patients who have obesity and normal population, and we should approach this patient differently. So this study established that abdominal pressure is increased in obese patients, and there is a direct correlation between pressure, BMI, and waist circumference. Another study which showed that for every 5-point increase in BMI, there was a 3-point increase in the reflex score. And also this study showed, this meta-analysis showed that a significant association between increasing BMI and erosive esophagitis. And finally, one study showing that there is significant association with the incidence of adenocarcinoma of the esophagus and gastric cardia, and this is attributed to the long-standing reflux. This slide should be my conclusion slide, but I thought to bring it here. So reflux may be different in obese patients because the pathophysiology is totally different from patients who are normal weight patients. Whether to do fundoplication or not to do fundoplication in this set of patients is really not straightforward decision. It's needed discussion with the patient and agreement also with the patient. Data exists in both supporting fundoplication in obese patients, and some data also don't support doing fundoplication in this set of patients. So still it's not a straightforward decision. In all literature that I came through discussing about fundoplication and GERD, define obesity as BMI more than 30, but they did not classify obesity class 1, class 2, class 3. Maybe only one or two studies which showed this classification. And there is no studies that differentiate, about maybe one or two also did any meta-analysis or randomized trial discussing the difference between Roux-en-Y gastric bypass and fundoplication in this set of patients. And on the other hand, all studies discussing Roux-en-Y benefits are done in obese patients with BMI of more than 40. So there is no comparison between the two populations of patients. And as I said, it is confusing what to do. We have two studies in front of us. One study is supporting doing fundoplication in obese patients, and on the other hand, there is another study that is not supporting doing fundoplication in obese patients. So what the evidence that supports the fundoplication in obese patients? This is a study which is 500 patients underwent fundoplication, and I said before, they mentioned that BMI 30 BMI, but they didn't subclassify that obesity, which is class, and they conclude that the obese patient can go to have fundoplication, and the outcome is almost same as normal BMI patients or overweight patients. And this list of studies showing the similar results. This is an interesting study also. This is the study that reoperation in patients who underwent fundoplication in the past, then reoperation. Although they stated that obese patients that have a higher recurrence rate, but as reoperation, it is the same procedures, and almost there is no difference between normal BMI patients and obese patients. This is the only study which also subclassify. If you can, class 1 obesity, 219 patients, and class 2 and 3 obesity, 114 patients. And also the same thing, the same conclusion. They said this fundoplication can be done in obese patients, although that patients class 2 and class 3 obesity. So what evidence support Roux-en-Y gastric bypass, and also some evidence also against fundoplication? This study as a comparison of Roux-en-Y gastric bypass and fundoplication in patients with obesity. Although they concluded there is no difference in the outcome of patients, but they look at the extra benefit of gastric bypass, which is weight loss and increase in the patient satisfaction. So they recommend that to be Roux-en-Y gastric bypass to be standard procedure for obese patients. This is also another study also showed that Roux-en-Y gastric bypass increase the patient satisfaction and also the reflex symptoms in patients. Something interesting about this, the GERD symptoms resolution is 39 patients out of 47 patients, and also the change from the heart pain symptoms which was there before the surgery to the regurgitation. And they cannot attribute to what the reason of causing that changing of heart pain sensation before Roux-en-Y gastric bypass to regurgitation after the surgery. Is it because of poor eating habits or because of surgery itself? This is study show the same also, that Roux-en-Y gastric bypass is a safe procedure and good in relieving GERD symptoms. So, is there any protocol or any guidelines discussing this matter? There's few of them, but I selected this SIG's white paper, and there are two recommendations, expert recommendation. The first recommendation is for BMI of 35 and above, and it's straightforward that Roux-en-Y is considered to be the procedure of choice. But the second recommendation, it can be used for BMI of 30 to 35, but in case of failure of previous fundoplication. And these are also another 3 studies with supporting that, evidence supporting that Roux-en-Y is a very good option for to treating GERD symptoms. But all these studies has been done in obese patients who has BMI more than 40. Before I withdraw a conclusion that we are dealing with 2 different presentations. We have 2 different presentations. Patient presented with GERD, and we found they are obese. And there is patient who present with obesity, and we found that they have GERD. The second class of patients have been discussed by Dr. Amani, and this had different pathway in management. But patient who has GERD, what is very important to the patient? Is the important is dealing with the GERD, or the important is dealing with the obesity, or tackle them both together? And before taking a conclusion or decision which procedure you're going to do it for the patient is fundoplication or Roux-en-Y gastric bypass, you need to discuss this result of each procedure. And you can see the difference between each one, and patient should know which one suits him. If he wants to have less invasive procedure, less complication related to malnutrition, they should go for fundoplication. But on the other hand, if they feel that obesity is a convulsing problem for them, it might be offered Roux-en-Y gastric bypass. So finally, I try to make an algorithm which might be a guide for us. For patients with BMI is 30 to 34.9, they don't have any comorbidity related to obesity, I recommend them to go for fundoplication. For patients who had obesity-related disease, I recommend to them to go for Roux-en-Y gastric bypass. In case of failure of fundoplication, refundoplication can be reconsidered, but I recommend them to go for Roux-en-Y gastric bypass instead of expose them to another procedure which might fail again. And finally, there are limitations in this category of patients. Most of cases, fundoplication studies focusing on class 1 and class 2 obesity, Roux-en-Y focusing on class 3 obesity, and we need more of the trials, randomized clinical trial to compare fundoplication and comparing Roux-en-Y in class 1 obesity. Thank you very much.
Thank you, Dr. Khalid. Can we have one question from the audience for Dr. Khalid? Dr. Haidar.
It's very good to have, but I think there is one point more to add. If you want to have a good bypass in somebody who has a GERD, you have to repair the hernia. Not only doing Roux-en-Y gastric bypass. So Roux-en-Y gastric bypass alone probably is also another possibility of failure. You need to repair the hernia by that. The other thing, fundoplication, there is a source of modified bypass where you can do bypass with rubbing using the excluded stomach. And that is especially seen, I saw it in my cases, where they come again with reflux, not with regurg. Regurg is different definition, but with reflux.
All patients I do Roux-en-Y for GERD, all of them I dissect the hiatus and repair the hiatus, all of them. And 2 weeks back, I had a patient whose BMI was 46, and he was offered Roux-en-Y gastric bypass for GERD, but he refused. he chose to do fundoplication. He came to me after 2 years, and I operated him 2 weeks back. And I unwrapped him. I was thinking about doing the same thing as you mentioned now, but I thought because they already mobilized the short gastric and all this, so I was afraid of ischemia of the fundus. So I unwrapped the fundoplication, and I did classic Roux-en-Y gastric bypass.
Thank you very much, Dr. Khalid. Next speaker will be Dr. Hind Al-Maghrafi from Oman with an interesting talk. Welcome to the stage.
Assalamu alaikum wa rahmatullah. Good afternoon, everybody. And we are still talking about more or less the same thing, and for a good reason, because of its very common pathology we are facing as bariatric surgeons. So today I'm going to talk about de novo GERD post-sleeve gastrectomy and a little bit about the algorithm of management. I'll talk a little bit about the introduction, prevalence, evidence. A lot of things has been talked about already regarding the topic. The possible technical causes of de novo GERD, how to prevent de novo GERD in sleeve, treatment, and do we still will do sleeve in patients with GERD and obesity. So the global registry shows that there is an increased evidence of sleeve. The sleeve surgery now is the most common surgery, and GERD is a common complication of sleeve. There is no doubt about it. And the problem that the prevalence of GERD post-sleeve is widely variable in studies. You will find one center have a very low incidence of GERD, while in other centers very high incidence of GERD, depending on the definition of GERD. So this was how you see still sleeve consists of more than 50% of bariatric surgeries we do, and the rest of all other bariatric surgery are less than 50%. And in all over the world, sleeve now is the most common bariatric surgery is done, and increasing with time. So we have a lot of studies which showing an evidence of increased GERD after sleep. And a lot of people have studied this, and all of these studies are actually showing that, yes, GERD increases after sleep. Surprisingly, also, there are a lot of studies showing that GERD reduces after sleeve gastrectomy. And there are a lot of studies showing about reduction of GERD after sleeve. And it is not surprising. Also, it depends on what are the pathophysiology of GERD in all the cases independently. Some patients, the GERD is a part of their obesity, and some patients, the GERD is a part of their anatomical problem. So GERD post-sleeve, it's either of worsening of pre-existing GERD or it's a de novo GERD. So in this meta-analysis, there are 22 studies, more than 20,000 patients. Prevalence of GERD shows it's around 35%. Okay, in another study, it shows the prevalence, the incidence of GERD is only 4%. The prevalence of GERD is only 4%. So, and this is a comparison between Roux-en-Y and sleeve, and no doubt now we know that sleeve gastrectomy has a higher prevalence in GERD post-op from Roux-en-Y, 1% versus 7%. So what are the technical causes? The previous presenter have already talked about this. Presence of hiatal hernia, disruption of the sling fibers, disruption of the angle of his, stabling close to the pylorus, torsion or twists, and stabling very close to the antrum or antral stenosis. How to prevent GERD? By avoiding all of these factors. Careful dissection of the angle of His, avoiding stabling close to the gastroesophageal junction, tube wider in the, keep a lot of antrum, avoid twisting, bigger calibration tube, and evaluate the hiatal hernia before surgery. So what we do, we go further technically, pre-op, we can do chloroplasty, and these are all done, omentopexy, gastropexy, fundoplication, a lot of things are done when the surgeons decide to do sleeve to prevent de novo reflux. These in patients who did not have reflux before. So chloroplasty, especially the posterior chloroplasty, is done very widely. And there is an evidence that it actually improves the outcome. Omentopexy is also done. Actually, although there is no evidence that it actually helps in the reducing the reflux. Gastropexy, that is attaching the gastric tube to the prepancreatic fascia, is also done. It maybe, possibly, but not very impressive. Fundoplication, there are many studies and many types of fundoplication have been reported to improve the outcome of reflux in patients who are having sleep. GERD is better, but doing a fundoplication with sleeve actually have other complications which hinders the procedure. So this is the criteria for ideal sleeve to prevent reflux. But if we see of this reduction in of the intragastric using a larger bougie, but on the other hand it will reduce the weight loss. Preservation of the pyloric function, sleeve tapering, narrowing of the avoiding of the narrowing of the central segment of the sleeve, circular fiber, preserving the sling fibers, and repair of the slide. Of course, any hiatal hernia encounter, especially if they are more than 4 centimeters. However, doing that can cause us a problem on the other outcomes of sleep, which is the weight loss. So if we, for example, increase the bougie size, or if we resect wide away from the pylorus, that will reduce the weight loss. We won't. And if also if we stable away from the angle of His, will reduce the weight loss, which we aim from the sleeve. So what is the treatment of GERD post-sleeve gastrectomy? As always, behavioral changes, dietary changes, dietary habits, medications, that is the first line of management. And most of the patients will go away with this. The next step is revision to Roux-en-Y gastric bypass. And that is the agreed, and it was also mentioned by previous speakers. Another thing, you can do links in patient post-sleeve. Still, it is a trial. Still, it is not in the clinical practice. Endoscopically, there are things which is actually tried, like mucosectomies in esophagitis cases, RFAs, but surveillance is important to assess the treatment of medication and to detect any Barrett's. And eventually, this is the algorithm which we should think of. First is lifestyle modifications, optimization of medical treatment, diagnostic workup, including OGDs, and manometry to exclude any other motility problems, conversion to Roux-en-Y gastric bypass, and other experimental therapies like magnetic therapy and endoscopic surveillance for all the patients. The last question, do we still do sleeves despite GERD in patients? We have patients, we don't want to do sleeve, but we have some high BMI patients whom we do a first stage surgery as a sleeve. So those patients we need to do. And we have also high BMI patients there without any evidence of endoscopic GERD. And there is a patient preference which we sometimes try to avoid, but we cannot avoid. And there are patients who also do want a bypass, but they have a contraindication like smoking, like non-steroidals, and you don't want to offer them a bypass, so you'll have to do sleeve.
Can we conclude, Dr. Hind?
That's all for my talk. Thank you very much.
Thank you very much. Do you have any question? Dr. Asayr, one question only.
Actually, my question to Dr. Khalid Al-Amri, just will go one step back because I have no chance to.
You can ask Khalid Al-Ammari in the coffee break time because we are really behind the 3 hours time.
Respect. Just a very short question, that's all. Dr. Khalid, regarding what you have a patient who is obese, the patient who have already nascent fundoplication. Patient have nascent fundoplication 3 years ago, and he have also now obesity. So what do you think, what's the best procedure?
I said that I had one patient I operated 2 weeks back, the same problem. He was obese, but he refused to go for Roux-en-Y gastric bypass at the beginning. But after 2 years, he developed diabetes, so he thought what better to go again for. So I unwrap the stomach and do classic Roux-en-Y. But Dr. Haidar, he mentioned also there's option, keep the wrap also and just resect the stomach and try to keep the pouch as small as possible. But in my patient, because they already mobilized the short gastric, I was just afraid about ischemia of the wrap. There's options are there. But
Thank you, Dr. Khalid. Thank you very much, Dr. Khalid. I apologize because the question should be directed to the speaker. If you want to discuss anything, you can discuss actually in the coffee break with the presenter. So I apologize for that. Thank you, Dr. Hind, very much. I would like to call our colleague, Dr. Mohammed Bawahab, a senior bariatric and minimal invasive surgeon. Dr. Mohammed is a professor in King Khalid University in Abha. And the floor is yours, Dr. Bawahab.
Good afternoon, everybody. Thanks for the organizing committee having me here today. My topic, I hope it's short, and it's being facilitated by the previous speaker. So, the topic that I was assigned to talk about, what are the surgical options for recurrent weight gain post-sleep if a patient has a hiatal hernia.
Mohammed, be closer to the mic, please.
So, I have no disclosure. Weight regain post-sleeve gastrectomy is a common problem. It happens in 20 to 50% of the patient who had a sleeve. Common risk factors include poor dietary habits, lack of physical activity, emotional eating, or independent or inadequate post-operative follow-up. Genetic factor being involved, psychological problem, at the presence of comorbidity like diabetes also contribute to regaining of weight. So the impact of primary, why sleep? They presented with GERD symptoms. First of all, it has a big impact post-operatively. Currently, the main disagreement that among the surgeon focus in the distance between the resection line and the pylorus, and all they agree in 4 randomized clinical trial that shouldn't be less than 4 to 6 centimeter and on the bougie size. And this was discussed by 41 experts from the China, Japan, South Korea, and all they were agree it shouldn't be less than 4 to 6 centimeter, and the bougie size shouldn't be in between 36 and 38 French to decrease the risk of the GERD as well as the weight regain. So, in definition, when we talk about suboptimal weight loss or inadequate weight loss or weight regain. So what are the definitions? Suboptimal weight loss is not achieving a weight loss of 40 to 60% from the excess body weight, while weight regain, regaining weight after you reach the nadir level of weight loss or regaining weight of more than 20% of total body weight loss. A systemic review revealed that up to 76% of all sleeve gastrectomy patients had a significant weight regain at 6 years follow-up. So why weight regain? Procedural failure as leaving more fundus of the stomach. The most common cause is thought to be dysregulated meal, including loss of control of eating or maladaptive behavior of eating. Non-compliance of dietary recommendation, return to previous eating habits, and sedentary lifestyle. Physiological compensatory mechanisms that happen and usually be measured increase preprandial ghrelin level in post-sleep patient, as well as reduction in the postprandial GLB-1. Comorbid, sometimes comorbid psychiatric disorder, especially depression, associated with a weight regain. So it's been summarized here. So weight regain is associated with the recurrent of peripheral complicated condition like diabetes type 2, hypertension, and other comorbid diseases. So we have to individualize person or patient who underwent a sleep and had a weight regain plus minus reflux problem. So management strategy has to be made. It's important to identify the cause of weight regain or insufficient weight loss. This can be done through a comprehensive medical education or medical evaluation, that include review of the patient diet, exercise habit, and other relevant factors contributing to the weight regain. It may also involve diagnostic tests to evaluate the patient metabolic status as well as the gastrointestinal anatomy to measure the gastric volume. Choice of index operation, guiding patient towards most appropriate bariatric and metabolic procedure is crucial before making a decision which procedure you will do for him. Given the heterogeneity of the population affected by obesity and its varying impact on individual patient, you may never identify a golden standard procedure for each patient. But in a randomized controlled trial, sleeve gastrectomy has a higher number of weight regain and inadequate weight loss when you compare it to Roux-en-Y gastric bypass. So to customize a procedure for each patient is a bit difficult. So revisional surgery and endoscopic intervention. Revisional procedure are going subset of bariatric operation that represent of up to 15% of all total number of revisional procedure. The American Society for Metabolic Bariatric Surgery Revisional Task Force, that was in 2014, standardized the nomenclature of various type of revisional bariatric surgery. Although it's safe, but having a revisional surgery carry more complication than a primary metabolic bariatric surgery. So, if you decide to do a revisional surgery, MDT is important for a better evaluation of the patient. Revisional surgery after sleeve gastrectomy for two reasons. Either the commonest reason, or more 50% of the patient who had sleeve gastrectomy underwent revisional surgery mainly for weight regain or insufficient weight loss plus minus GERD reflux problem or a complication of primary procedure. Multiple surgical alternative to revise sleeve gastrectomy were proposed. There is more data on converting sleeve gastrectomy into Roux-en-Y, but we don't have enough data of converting sleeve gastrectomy to SASMBS or other metabolic procedure. So this paper summarized the treatment option of weight regain or insufficient weight loss after a sleeve gastrectomy in a systemic review and a recent published paper. They had more than 5,000 study and included 22 study in this paper. Sleeve gastrectomy is frequently a failure long-term procedure. So insufficient weight loss and weight regain are among the indication of revisional surgery up to 37% of the literature, and some literature decoded up to 50%. So you choose the revisional procedure depending on the patient characteristic. looking for hiatal hernia, looking at the lifestyle of the patient, is he smoking, weight regain, or for a reflux problem. So, common procedure that we use for vaginal surgery: re-sleeve, Roux-en-Y, single anastomosis bypasses, or endo-sleeve. Effect of different vaginal procedure on PMI during a follow-up. Many gastric bypass or single anastomosis gastric bypass showed the best outcome in terms of weight loss in 1 year and 2 years follow-up, but high reflexogenic procedure. And one study showed the PMI decrease up to 17 points in PMI after 60 months. It's the longest study about conversion of sleeve to PMI to single anastomosis gastric bypass. In conclusion, re-sleeve, it is effective but has a low rate of weight reduction post-sleeve and a fairly safe procedure. Roux-en-Y resulted in a PMI reduction at 1 year up to 4 years of 7 points of PMI, but they have more than 90% reflux improvement and treatment cessation. SASMBS, no enough data, though it's a technically difficult procedure, take a risk of 6% of complication. ESG, as I mentioned, the lowest effective in weight reduction and fairly safe procedure. A meta-analysis of 22 study revealed almost up to 35 incidents of GERD following laparoscopic sleeve gastrectomy, mostly with hiatus hernia. However, some studies, they reported a higher rate and incidence of post-operative reflux reaching more than 50%. So, why GERD and hernia happen in a patient who had a sleeve gastrectomy? Reduced gastric compliance, elevated intragastric pressure, disruption of the angle of Hess and widening the angle more than 30s, hiatus hernia, and mobilization of the Z-line up in the mediastinum, gastric sleeve torsion, or other technical problem. So, surgical treatment of GERD after laparoscopic sleeve gastrectomy is Roux-en-Y gastric bypass, and it's been agreed upon as is the best procedure for weight regain with reflux and hiatal hernia post-sleeve gastrectomy. So both American Gastrointestinal Association as well as Society of Gastrointestinal and Endoscopic Surgery consider Roux-en-Y gastric bypass to be the preferred surgery for obese post-sleeve patient with hiatal hernia and gastroesophageal reflux diseases. Tremendous of publication around to assist the changes in esophageal mucosa as well as the weight loss post-sleeve patient who had reflux and weight regain before and after Roux-en-Y gastric bypass, and these showed improvement in the GERD reflux problem up to 93% of the time with no medication, and a weight loss of 40% of their excess weight.
Prof. Bawahab, can we conclude, please? Because
almost
we are over
half a minute or 2 slides. I'm done. So, it's evident that Roux-en-Y is the best favorable procedure for combined weight regain and hiatus hernia reflux post-sleeve patient. Is OGB an option? It's good for weight reduction, but is not a good procedure for a reflux patient. In conclusion, the prevailing recommendation with the medical community is to revise sleeve to Roux-en-Y gastric bypass and repairing a hiatal hernia, though there is no solid data to recommend repairing the hernia at the time of Roux-en-Y in a post-sleeve patient. The revised Roux-en-Y gastric bypass surgery is effective to control the morbidity associated with the weight gain for the weight reduction as well as treating the reflux. Thank you very much.
Thank you very much, Professor Bawahab. The closing lecture will be by Dr. Isam Bataya. The stage is yours.
Thanks.
Thank you very much to give me this opportunity. This is the lecture that will be concluding for the session for today. My disclosure, this is with the honorary from J&J regard, we know that the stapling technology, it has been 19th century, and since that time until today, still we have sentinel event, we have some malfunction, and this can lead to problem with surgical error. So just only to briefing with some of the terminology, the misfiring, that's mean when the mechanism of the compression itself and the stable that you don't have the well-formed B-shape stables. And the jam, that when sometimes, unfortunately, when you are just start doing the firing, unfortunately, the machine itself, it stopped working, not anymore, and it's not firing. And missing stables, that mean it's not going up in the pocket, and this is also can cause a serious issue. So the proper formation of the B shape, it's on the left lower side that you want it to be as a well-formed one. And you need to know how this occur or how does that happen. And this misfiring of this error. The manufacturer always asking that you should match the cartridge with the anticipated thickness, and this is not a new thing. You have to know what type of tissue you are stabling on, and according to that thickness, you want to have a well-formed B-shaped stabler, not the malformed ones. So actually what's happening when there is a defect and there is an inappropriate choice of that stable size, that's causing a variable of more complication, more problem with the patient. And if you study just only showing really the real thickness, so the myth is how we do know that this thickness of the stomach is actually the one that you need. So from what we know that according to the gender, according to the age, according to the body mass index, this is playing a role, plus also the surgical technology. If you are using the power different from the one that you are using with the manual, the compression on the tissue, the perfusion of the tissue, and there is also some patient factors that's playing a role, and the tissue movement. So from the literature and the study, it has been proven that the male, that they have a more thicker stomach, and also that the patient with a higher BMI, especially the more than 50. So according to that, all the manufacturers of many companies, they start to have a different type of colors. According to these colors, there will be a grading of the thickness of the tissue. And this is maybe little bit a surgeon preference rather than any other things, but you have to back to the standard that it should be according to that. So we can understand that according to that, the blue is the most common to be used, and the proper reload for that, for the thickness of the stomach to start with. Some people, they prefer to use the green, but also in revision cases and some higher BMI male patient recommended to use the black. So can you play the video? So the issue of the pre-compression and the matter of the 15 second, this 15 second, that's make almost the degradation and the biofeasibility of the tissue, so that it will give you the proper area. And this 15 second, it's not really too much time, and it can make a lot of difference, especially if you are doing with the 5 reloads. That means 75 seconds in conclusion. So it's almost 1 minute extra, because some of us are in a hurry that you will just do the firing without any compression. One more thing to add, to hug the tube, and this can have too much force of the tube on the stable line on the 3rd row, that's a little bit closer to the bougie. So at this area there, you don't want to have that much of force that to disrupt your there. So the surgeon need to have the appropriate stable size that match the tissue and the thickness to have a very successful outcome. That's why the re-innovation and the new technology of the new device with the new Echelon 3000 stapler with its new advance, and it has the main great mobility and articulation reaching up to maximum 110, and the jaw is much more wider, and also the junction, and it has little bit of the shorter articulation joint. The other thing that's most of the time with the previous one, even if it is not really harmful for articulating the previous one, which was manual, now they advance it with just a 2-button that it can have the technology, and you can advance it with just 2 technology. More than that, the new thing with the buttressing material, I will not talk much about the buttressing material indication and the proper use and these things. It has been proven in the literature, in systematic review, and a lot of that. But what make this really the endobath stable line reinforcement is the application. It is very seamless, it's very thin, and it's just applicable with 3 simple steps that you can apply. And what is really designed for, and the benefit of that, even if you are manipulating with the tissue, so it will not move like the other kind of buttressing material that if you manipulate the tissue, it will cause it to move. And make in consideration that always please keep in mind that an extra 0.5 millimeter regard the thickness of the buttressing material itself, although the ASR is 15% thinner. So it's much thinner than the regular buttressing material. And just leaving you with this, play the video. You can see how steady the movement of the tissue with the GST technology and the compression and the way that it's cutting with a very beautiful, nice, bloodless field, especially if it's really with the good indication that it will be used. So you will see a beautifully formed buttressed material with the new gun without the transmission or the movement of the tissue. Thank you.
Thank you, Sam, very much. Now we will conclude this session, and we would like to call our colleague for the coming session for Gus. Thank you, everybody.
The good thing is you have only 1 session remaining, the IBC. So the ghost session was moved to tomorrow in the morning at 9 a.m. So we'll leave now Harris to introduce the team of speakers, moderators, etc. Please come in.
Firstly, I'd like to really convey a real warm appreciation to the Saudi Arabian Society of Metabolic and Bariatric Surgery for this 65th IBC Symposium and the 15th in the Middle East and Africa region. So I'm very grateful to Osama, to Ayad, the entire organizing committee. Also very grateful to all the speakers, chairs, moderators, panelists for this session, and also all the audience who have stayed late to attend this. So this particular event, the way we divide it into 3 keynote lectures, and we also have a video session which would be quite interactive, I hope. So I'd like to invite to moderate this session Dr. Osama Al-Sani and Dr. Sami Al-Momin. And the first speaker is going to be Dr. Helmuth Billy from the United States. And Helmuth is going to give a talk entitled Achieving a More Consistent and Symmetrical Sleeve with a Single Continuous 23 centimeter stable line. Helmuth.
Well, it's truly an honor to be back. This is my 4th visit to SASMBS, and it's quite a pleasure to be here. So thank you for the invitation. Thanks everyone for staying for these late talks. I'm going to talk about a little bit of a different technology because pretty much all the technologies, whether you use robots or whether you use straight sticks laparoscopy, rely on a very similar stapling technology. And this is a little bit different because we've talked a lot about sleeves, we've talked about reflux, we've talked about leaks, and although they happen rarely with leaks, and reflux is a little more common in our practice of revising sleeves, the goal with this sort of stapling technology is to maybe not need to revise the sleeve as much, certainly not for reflux. These are my disclosures. Now, the current stapling technology is familiar, and now we have staplers from many different countries, all using the similar technology of either reloading a cartridge with the staples and the knife, or simply reloading the cartridge. They come in a variety of forms. There's mechanical, and there's also powered, and some of them have sensors, but they're all limited by their size, and they're limited. We just heard in a talk about how the surgeon has to select the right cartridge. I met a surgeon today who uses black for his entire sleeve, and I know surgeons that if they use the robot system, use white for the entire sleeve. So how do you even pick the right cartridge? There's limited options. They're all general purpose devices. They have 2 firing lengths, and they cut the tissue and form the staple simultaneously, all pushing the tissue away from the stapler. And they use different cartridge colors, as we've stated. And the surgeon is responsible for not only picking the right cartridge, but he's also responsible for positioning it in the optimal location to prevent fracturing and crossing of staple lines, and also to prevent a jagged sawtoothed appearance to the staple line. So the repositioning that has to happen is 4 to 7 times, 4 to 7 cartridges, 4 to 7 opportunities to maybe place it improperly or in the less optimal position. Now this represents a bougie within the sleeve, the stomach, and in creating the sleeve, the gray area is the staple cartridge being positioned, and the surgeon's responsibility is to pull or tease the tissue in a direction away from the bougie to position it optimally. Now that causes an uneven tension many of the times, which is out of plane, and the stapler leads to spiraling. In other words, if you don't position this equally on the anterior and posterior side, you're going to have a less than optimal staple line. And I know everyone who's done a sleeve, when they finished and take the bougie out, looks at it and goes, it doesn't look that great. We all think it looks great, and sometimes it does, and sometimes it doesn't. So how does that happen? Well, in the green area, we have the optimal, very nice pull where the tension was even on both sides. And then in the yellow, the tension is a little more on the anterior surface, which when you release the stapler and release the bougie starts to spiral it anteriorly. And similarly, you can pull too much tension posteriorly, and then it will pull the staple line in the undesired location posteriorly. So we end up with spiraled staple lines, sometimes less spiraled than others. We do know that the problem of inconsistent outcomes has been looked at, and really only 30 to 40% of the time do we get the optimal looking sleeve when we do it this way. With multi-fire staples, the lower pouch can bulge out too much, the upper pouch can bulge out too much, leading to reflux, and certainly we all fear the dumbbell-shaped upper GI swallow, where the angularis of the incisura is now the worst in terms of optimal sleeve design. 8% we may have one with a fundus that is retained, all leading to some of the problems that lead to sleeve revision. And this is a photo I found, which is the worst looking staple line I've ever seen. I hope none of us have ever had this, but we've all seen spiraled staple lines, which are less than optimal. So the concept of anatomy-based sleeve gastrectomy was designed to where we try to really have a standardized sleeve, where we can all do it the same way based on measurements. Is this something that's really impossible to achieve? If we pick a distance of 1 centimeter from the gastroesophageal junction, when I first learned sleeve, one of the lessons was don't staple on the esophageal tissue, it leads to leaks. If we take a standardized measurement about 3 centimeters from the angularis incisura and a standardized measurement of 4 to 6 centimeters, I know the Australian surgeons like 2 centimeters to 3 centimeters, but you can pick your standardized length. And if you had a staple line that was less multi-fire and more single fire, limiting the amount of staple cartridges, you could probably achieve this. So the goal is to place a series of short staples, this is how we do it now, on the stomach in a continuous line, in the same plane, to get a consistent shape every single time, ensuring a safe distance from key landmark cartridges for each pull line heights. We might call the ones in the front yellow going to stomach. so that after a series of stomachs are measured, the optimal staple heights for the average stomach have been preloaded into this stapler. It's 23 centimeters in length. It has 57 rows of staples, and it has 347 staples within the actual design. It can handle virtually every stomach that I've ever tried to staple with it. There hasn't been one yet that... You can make sure the video runs. So it starts out with making my measurements. There's the pylorus at the tip, and then we use a felt tip to make a mark so that we can see exactly where 4 to 5 centimeters is. And then I make a mark. It's an estimate. It's not perfect, but it's better than not having the mark. And then my jaws are about 2.8 centimeters, and I'll make a mark. And this is where I want the lateral edge of the bougie and the stapler to rest. I make a mark up 1 centimeter from the angle of His, create the dissection, and this is the curve that we want to achieve when we're doing the staple firing. Whether we do multi-fire or this single cartridge, that's the size and the shape that I hope to achieve. And the bougie is positioned. Once we get it in the antrum, it'll be about 4 centimeters from the pylorus, and the staple line should be about 5 centimeters. You can choose your own lengths, but this is the average that we do. And you can see if I do it or my partners do it and we follow this anatomical landmark, we should get a sleeve almost every time that looks virtually the same. And so we'll put this then to suction, and there's our staple line and we hope to achieve with respect to the pylorus. And the goal with sleeves, if we're going to minimize some of our complications, we have to get them to be more similar to determine the optimal shape. So now I use this 5mm instrument to estimate the position that I want this long stapler to be positioned, and this looks like it will work just fine. The greater curvature then is brought through, and this is the most meticulous part of the actual positioning. And the marks both anteriorly help us position the stapler optimally. Posteriorly, here you can see the marks, the stapler is still open. And then we close it partially to position anteriorly, and then once we think we have the anterior positioning optimal, the landmarks are displayed exactly where we mark them. I can then flip to a posterior view and see if this is optimally placed. Once I agree and I fire it, you can see we have a straight staple line. We have no crossing staple lines. We have no jagged edges. And once we take the bougie out, you'll see that we have achieved. That's a curved sleeve taken from a straight stapler. So what about the problem with crossing staple lines? Well, the Food and Drug Administration released a statement on optimal use of stapling. And in that was a staple guideline for us to avoid crossing staple lines. Be aware that there is a risk of increased leaks when staple lines are crossed, even if there may be a clinical circumstance when it is clinically necessary or appropriate to do so. If we develop better staplers, we can eliminate, doesn't matter, until one day this happened to me. This is actually from an OAGB, and the patient had a leak that didn't show up virtually on any study except she was sick and tachycardic, and we explored her, and we ended up resecting the remnant of the fundus, and we found this. It was originally a small pinhole of a perforation, and the more we played with it, the more it got bigger. But this is right at crossing staple lines. And so this phenomenon can happen, and it can lead to a problem in your patients. We position it, and how the staple line, and here we're positioning when we've flipped for the posterior. This can be done time and time again, and sleeve after sleeve after sleeve can look virtually the same no matter who does it if we follow the principles of marking landmarks. Here's a second sleeve, and you could have a whole wave of the future formed, and there's no bleeding. So thank you for the invitation again.
The next lecture will be an exciting lecture for AI and surveillance post-sleep gastrectomy, detecting Barrett and dysplasia. So, Dr. Thompson.
Thank you. Perfect. All right, so I'm going to cover pretty much, artificial endoscopy and artificial intelligence in endoscopy, and we'll definitely touch on Barrett's esophagus and the importance of the role there, and also the ability for it to detect cancer in the stomach. This is a interesting clip I found. I don't know if you can play that. There should be audio here. I don't know if you can play the audio. In any case, this was the first time AI really became relevant. It was 1997 with Garry Kasparov. Actually, it was beaten by Deep Blue, IBM's computer that was using AI, and it actually crushed him. It was very exciting. That was quite an interesting narration. Check it out on YouTube if you get a chance. It's quite chilling, actually. So this is really the timeline of AI, and the term was first coined in 1956 by Professor McCarthy at a conference in Dartmouth, 1956. And then it kind of took off for a little while. There was a lot of hype, and then I think it got overhyped, and people were predicting computers would be as intelligent as people within the next 3 years or 4 years. There was not a lot of investment. Again, it was just too expensive. Data was expensive. They ran into some technological barriers, and we went into our second winter. Then we have the Garry Kasparov clip I just showed you. Okay, clearly there was progress, and a lot of that was because data storage was cheaper. We were able to calculate things much more quickly, and that's where AI really started taking off and started seeing other potential applications in robotics, in manufacturing, and of course in medicine. So we've already heard about this, artificial intelligence, the definition, the ability of a computer program to learn and problem solve, and there's different aspects to it with intelligence, autonomy, and adaptability all being very important, and we do see those in their functions in endoscopy. So as far as a brief overview of the various types of AI, of course, we have machine learning, which is really important. Natural language processing, we see that in medicine all over the place, of course. Vision, which is relevant to endoscopy. We have speech, planning, and robotics as well. I'm going to focus mostly on the machine learning aspects of it. And the definition here, of course, is of machine learning is basically that data is entered and that allows algorithms to be built, and then decisions are made based upon that, and then it can actually self-learn as well. And we're seeing that in all over different technologies. And within endoscopy in particular, we're relying on something called deep learning, which is like machine learning on steroids, multi-layered neural networks, which are really convolutional neural networks, which are resembling the visual cortex. And that's how endoscopic images are able to be processed and utilized. This is a kind of a very simple construct of a convolutional neural network where you see multiple layers. So initially it might look at the edges of a lesion, and it adds that data to the next layer, which is simple shapes, and then the next layer is it looks at the 3D structure. The next layer might be looking at granular patterns, or they call them pit patterns of the various structures, and they're folding this, okay, and they're adding these bits of information together to eventually be able to use that to make decisions. Now, throughout all the studies we're talking about, they all go through the same phases of training and developing an AI system. There's a training phase, there's a validation phase, and then there's the testing phase. Most of what I'm talking about is the results in the testing phase, but this is the process that each one of the studies that I mentioned has gone through to get to the point where we can make kind of clinical judgments about their utility. So again, there's different ways AI is used within GI and within surgery. The one I'm going to focus on is the role in endoscopy, but it is making great headways in all sorts of different things, whether it's data analysis, being able to draft our notes for us, analyze notes, looking at histology, etc. But I'm focusing only on the imaging analysis. And it breaks largely down into the non-CAD E, the CAD E, and the CAD X, with the E, of course, being image kind of recognition or detection, okay? If you're looking for a particular thing like a tumor or an area of interest. And then the CAD X, of course, is when you're making a diagnosis or you're grading a lesion, so it's a little deeper. And the non-CAD E, that's other things. We're doing volumetric measurements, we're measuring the size of lumens and volume of structures and whatnot, and that's useful as well. So here's where we find its use, in particular with CAD-E and CAD-X. And what we're talking a little bit about here is, Barrett's esophagus, the ability to find lesions within Barrett's esophagus or neoplasias in Barrett's esophagus, and then the ability to detect cancers potentially as well in the stomach. That's what's relevant to the talk. Now, there's a lot of products approved in endoscopy. We're one of the first ones to start seeing artificial intelligence within our imaging systems. So we have on the market, Medtronic has devices for us called GI Genius. Fuji has systems, Olympus, everyone has these different systems that help us identify lesions. And there's different kind of spaces where we're seeing it, but again, it's mostly focused on just finding that lesion and making it more evident. Maybe they'll circle it for us, maybe they'll highlight in some way so we can see a lesion, and then potentially do visual biopsies for us so we don't actually have to take tissue specimens. And this is just kind of the breakdown of where we see it. Again, largely colonoscopy is what we've seen. A lot of this has been involved in colonoscopy, but more recently we started seeing research in the last 5 years, again in the foregut. So that's where we're starting to see some research at Barrett's, looking into Barrett's esophagus, eosinophilic esophagitis, maybe looking at H. pylori, even helping us with decision-making during therapeutic procedures like your EPOMs for achalasia and vessel detection and helping you to identify what tissue plane you're in. So we're starting to now see that. Where early on, really, all the work was with colonoscopy. And colonoscopy, what we're looking at there is it's polyp detection. Colon polyps are very common. It's the number one thing gastroenterologists do. They're fairly easy to spot, so it's easy to train the models for this. And, there's vast screening programs. Everyone in the United States needs to have a screening colonoscopy. So there's an incredible volume there. So that's really what encouraged it to be developed. And it was really developed solely for colonoscopy early on. And then for the gastric side, it's rare. The upper endoscopies are not performed as regularly in the United States, and the lesions are harder to see. So it's much harder to see gastric lesions and esophageal lesions than polyps in the colon, which are very big and very obvious. Of course, that's what led to all these programs on the left being developed for colonoscopy, all the companies, all their different initiatives, and there was nothing for upper endoscopy, again, until about last 5 years. So AI in the esophagus, the detection of metaplasia or neoplasia. It's very easy for us to miss these foci. The very top image, you can see how it's hard really to find that little area of neoplasia in the underlying mucosa. Whereas when you highlight it with AI, all of a sudden it becomes much more visible. But then where do you biopsy that, right? And you can see very, very targeted systems to help biopsy as well. So this is one study looking at Barrett's esophagus, and it went through 5 different data sets. And the first 3 are used to build the model. It's the last 2 that are of interest. And the CAD system was assessed with the 4th data set, and it was found to have a 90% sensitivity, 88% specificity, and 89% accuracy for identifying neoplasia in underlying Barrett's esophagus, which was great. But then what they did is they compared it in the next data set 5, to 53 general endoscopists. These are gastroenterologists that see this stuff all the time, right? And they found it actually did better. The sensitivity was 93% for the system versus 72% for the doctors. 83% specificity versus 74%, and the accuracy was 88% versus 73%. So it's better than people who do this all the time. Additionally, there's other studies that have looked at this, and they found that basically it can take, if you compare to experts, there's still improvement. So these are people that are only like Barrett's esophagus experts instead of general endoscopists, and there's still substantial improvements, which is quite encouraging. If you look at the AI system alone, it had a 92% accuracy versus Barrett's esophagus experts, which had an 83% accuracy. And these are people that are esophagologists, right? So clearly it was there. Additionally, it improved non-experts' performance as well. And you can see how below, how their performance across the board, accuracy, specificity, and sensitivity improves with statistical significance across the board using AI. So it certainly can help. It also is very useful in detecting gastric neoplasia, which is relevant to sleeve gastrectomy, right? So this is another study that, again, many images, over 4,000 images were utilized to build this system. And then the man-to-machine comparison below, again, the machine did better. So 88% accuracy for the machine versus 70% accuracy for the doctors who do this all the time. So clearly it would help us with diagnosis. And what you see with these over and over again, this is experts. It's outperforming experts, but it's also very useful at helping people that are less skilled in making these diagnoses. And this is an example of what it looks like, just a video. You see it's much easier to see on the right than it is on the left, right? And I think this is just something we're seeing over and over again. This was a meta-analysis of 21 studies looking at early gastric cancer. So now we're starting to get more data. And you can see here that the sensitivity and specificity were substantially better, again, with the system. And if you look at non-specialists, non-kind of gastric cancer specialists, the sensitivity improved from 64 to 76% using the system. Also, learning curves improved with this. So this is just one study, kind of a multi-field scoring system, a composite clinical endpoint, if you will, in people that were trained using the CAD system. Got a 72% versus 67% for people not in the CAD system. So it involved the fundus, or you didn't retroflex and look at the incisura. So it could actually provide quality control and tell you, hey, you got to go back and look at this part of the stomach because you missed it. And it's getting better and better all the time. It's also helping with non-neoplastic conditions like the diagnosis of eosinophilic esophagitis, vessel detection in POEMS, and H. pylori as well. So it's also cost effective because you're missing fewer lesions. This was a nice study that looked at the cost effectiveness of AI in upper endoscopy and colonoscopy, and it found really it's hard to convince hospitals to buy these systems. So fortunately, many of the different companies, especially Fuji's, just been putting it in all their processors recently. But for standalone systems, it still was cost effective to acquire the system because you're missing fewer lesions and you're making more diagnoses. So in conclusion, AI is making headway in upper endoscopy, although it's lagging behind colonoscopy. It's proving to be useful in lesion identification as well as diagnosis, specifically for Barrett's esophagus and for foregut neoplasms, as I mentioned. It holds a promise for shortening learning curves and improving performance of novices, which I've shown in several of those studies. And it now looks like there may be applications for therapeutic interventions as well on the horizon. Thank you very much.
Thank you. So thank you so much, Chris. We'll open it up for questions after the final keynote lecture. Thank you so much. Wonderful talk. So the next presentation is by a good friend of mine, Professor Ali Aminian, Professor of Surgery from the Cleveland Clinic in Ohio. His presentation is a futuristic talk entitled The Impact of the Next Generation of Anti-Obesity Medications on Revisional Bariatric Surgery for Weight Recurrence by 2035. Ali.
Hi, everybody. Can I have my slides? I know everybody talked to you about AOMs today, and you're tired of that. But unfortunately, you need to hear my perspective on that. Can I have my slides? Yes, 10 years from now, on revisional surgeries. You and me are going to be retired by then, Osama. So.
Yeah, I think if it's okay, Chris, while we're waiting, if the audience could ask you a question and also Helmuth. So we'll keep, while we're waiting for the next talk. So if I could just ask the first question, if that's okay. My question to you, Helmuth, is the Titan stapler is clearly a very attractive, standardized way to do a sleeve gastrectomy, but what do you see as the future for the Titan? Is there only really one operation where it can be used, or are there any other operations potentially where it may have a role?
Well, clearly it was designed for a sleeve-like operation or a lateral gastrectomy, but the innovation with it, someone thinking that we'll draw the staple cartridge toward us, is only limited by the imagination of engineers. All they have to do is disconnect it so the hinge can be opened up and put around tissue, and suddenly you can make different sizes, 17 centimeters, 20 centimeters. So I see you'll be able to use this in the future. It's only limited on the engineering funding that's available to create something in addition to this.
Brilliant. And my question to Chris, so this wonderful talk you gave us, I just come from a meeting in Kuwait where they're talking about AI and endoscopy. What is the timeline from when we have this type of new stacker systems from the various companies who do endoscopy stackers, where we have AI functionality to detect lesions? When do you think it's going to become standard of endoscopy care? What time frame are we looking at?
Wow, yeah, that is interesting. So it's gaining a lot of steam, right? So there is now within the ASGE, American Society for Gastrointestinal Endoscopy, which is the US's kind of main endoscopy society, there is now a separate sub-society that's kind of independent almost, but still under the same structure, that focuses only on AI. And their main agenda is exactly this, is to figure out, we know it gives better results, but it's expensive. So how do we start kind of enforcing it in some way that's reasonable? And it's highly contested. But they're worried about isolating many of the members, yet by saying you need to buy this because your patients aren't being treated as well as they could be. We don't want to isolate people that can't afford it. So, but we need to start doing it because it clearly is better for outcomes. And you diagnose lesions just earlier, and it's better on many fronts. So I think that I can't answer it right now, but there's a meeting actually in the summer focusing on that question, and I think that there's a real push for it, and they need to work with insurers and the government, I think, to help support the financial aspects of it. But I think it's really important, and we're going to see those things probably in the next 2 to 3 years, where we have some guidelines and some requirements, at least a plan to phase them in over time.
Great, thank you so much. So we'll take more questions in about 10-15 minutes. And Professor Aminian, if you could kindly give your presentation if all is well.
Okay. Can we have my presentations? Okay, let's move on. In my disclosure, some of these companies supported our research, but they probably won't be any relevance for the prediction in 10 years from now. So just briefly, stay with me, the SELECT trial. So you probably have heard about the SELECT. Novo Nordisk spent $1 billion to do the SELECT trial. So 15,000 patients with obesity were randomized to 2 groups. They were followed for 4 years. One group received semaglutide 2.4 milligram, the other group received placebo. So the difference, you see the weight loss, the weight at baseline was about 100 kilogram, and patient on the intervention group lost about 9 kilogram, and they were able to maintain that. So that 9 kilogram weight loss that came with semaglutide over the course of 4 years could reduce the risk of cardiovascular event, heart attack, stroke by 20%. But look at the curve in the bottom. The difference, the separation between the two curves was narrow, extremely narrow. So you need to magnify that to see them actually. Without magnification, the curves are going parallel. So, but since they had a 15,000 patient sample size, that turned out to be statistically significant. So now look at the gap between the SELECT trial and the outcome that we get from bariatric surgery. So look at the gap between the two. So obviously the y-axis is different. That one is from 0 to 100, this one is 0 to 50, but still you see the gap much larger. So if you want to compare bariatric surgery versus semaglutide in 2025, so relative risk reduction for heart attack, stroke, and dying is about 20% in SELECT trial. Totality of the data that we have with bariatric surgery is about 50% risk reduction. But relative risk reduction is meaningless. So if you look at the absolute risk reduction, about 1.5% versus, again, about 10% with bariatric surgery. So number needed to treat to prevent one MACE based on the absolute risk reduction. So with the semaglutide, we need to treat 66 patients to prevent one death, heart attack, or stroke. With bariatric surgery, we need to treat 10 to 15 patients to prevent one death, heart attack, and a stroke. And then let's look at the cost. So in 2025 in the United States, to prevent one death or one heart attack and a stroke with semaglutide, you need to treat 66 patients over the course of 4 years. So that would cost about $3 million. So we have to spend $3 million to prevent one death. With bariatric surgery in a place like Cleveland Clinic, which is very expensive, going to take about $30,000 to do the gastric bypass or a sleeve. If we spend $300,000, we can prevent one death, heart attack, or a stroke. So the question, if you have $3 million, you want to save one life or you want to save 10 lives? So I would rather saving 10 lives. But that's for in 2025. We know that medication is going to get better, going to be more affordable, going to be stronger. But as of today, although these medications are effective, we shouldn't forget that bariatric surgery is much more effective and much safer, not much safer, much affordable. In a larger scale, you can treat more patients with a lower cost. Obviously, medications get better over time and get stronger and getting closer to the efficacy of bariatric surgery. You see in the past 10 years, there was a sharp rise in their efficacy, and that's going to continue until 2035. So the other concept that I wanted to talk to you before giving you my prediction about the future is the individual response to the weight loss interventions. So you always see this graph. So this is a Cleveland Clinic experience the past 10 years or so, 7,000, 8,000 patients who had bypass on a sleeve. You see their data over the 4 years, and this is the average data of all those patients who had surgery with us. So bypass patient lost a bit, 5-10% more than the sleeve patients. Both were durable, but this is meaningless. Because when we see the patient in the clinic, this is not applicable to the patient that I'm going to have next week in my clinic or Osama going to have next week in his clinic. Because this is the average of 6,000 patients. But if I plot every single of those patients, their weight here, you see that they're all over the place. Some of those patients didn't lose any weight with a gastric bypass. And some of those patients, the bottom, lost 60% of their weight after gastric bypass. So that's our lack of understanding of the responders versus no responders. So we have a sleeve, so we can do it with multiple staples or with the Titan stapler, do it, doesn't matter. We don't know who's going to respond, who's not going to respond. So Dr. Nemiri is going to do gastric bypass for 200 patients every year, the same procedure, but he doesn't know which one going to be above or which going to lose more weight. So that's the problem that we have in the field. So we need to have, and we will have, a way to predict how much weight people are going to lose with any of the intervention that we have with any of the medication. if I had a tool that I could predict that these folks only going to lose 10% of their weight, why should I provide gastric bypass or sleeve gastrectomy, waste patient time, mind time, resources to do the bariatric surgery for those patients? It wouldn't make sense. It wouldn't make sense at all to put them at the risk of the surgery just for 5% or 10% weight loss. So by 2035, if I had a crystal ball, I would imagine that overall revisional surgery is going to decrease because medication going to be more affordable, going to be stronger. That's one reason. And here is the IFSO consensus statement from last year, graded as a grade A with 92% consensus among the IFSO experts, that for patients with recurrent weight gain, treatment with available AOMs should be considered before revisional surgery. So the IFSO consensus, who mostly were surgeons, agreed that if the patient had a bariatric surgery in the past and had recurrent weight gain, they should try AOMs before considering revisional surgery. So that's one reason. Medication will become stronger and more accessible over time. And then the second, we can provide the best appropriate procedure to the patients that can lower the risk of weight gain or inadequate weight loss to improve their outcomes. So for these two reasons, I think overall revisional surgery is going to decrease in the next 10 years because we're going to be wiser in our procedure selection for the first surgery when we have more accurate tools. So in terms of the procedure-specific surgical revision, talking about the gastric bypass, I think that's significantly going to decrease the revisional surgery after bypass because we don't have any good, safe, effective revisional procedure after gastric bypass. In our experience in the past few years in Cleveland Clinic, so we convert them to the distal bypass with a total alimentary limb of 400 centimeter. And with that one, when we collected our data, we're going to publish that soon, conversion of bypass to distal bypass, Dr. Nemiri, with a total alimentary limb of 400 centimeter, we could only get 10% additional weight loss. So you can get 10% additional weight loss with adding semaglutide, tirzepatide, or other AOMs. So it's not worth the risk. So I think in future, AOM endoscopic procedure will take over distal bypass or revisional procedures after the gastric bypass. My last slide, procedure specific revisions after the sleeve gastrectomy. I think after the sleeve also, in 10 years from now, revisional surgery is going to slightly decrease because of the AOM, and then we have personalized approach. Then we're not going to offer a sleeve to the people that we know that not going to lose that much weight. Here is the data from the BARIATRIC that you have seen several times in this meeting. So almost all these patients had the sleeve gastrectomy, still had obesity. They were placed on liraglutide and they lost about 8% of their weight. That was only with liraglutide. So imagine you put the patient on a stronger medication than liraglutide. You're probably patient going to lose more weight with that. And then I think the conversion to single anastomosis procedures like SADI or OAGB going to increase after the sleeve patients, for the sleeve patients in the next 10 years or so. And this is my last slide. So again, here's our experience, Cleveland Clinic, people who had a sleeve gastrectomy the past 15 years and still had obesity. Some of them underwent gastric bypass, some of them underwent SADI. And as you see here, in the first year after conversion, both groups lost about 20% of their weight. But following them up to 3 years, SADI patients were able to maintain the weight loss, but gastric bypass patients, after year 1, they started gaining weight back. So again, this one is also under peer review. But again, I think sleeve patients, conversion to SADI, going to stay a viable choice for the next 10 or 15 years. Thank you very much.
Thank you very much, Ali. There's actually one more talk before we move on to the questions. So it gives me great pleasure to invite Dr. Mahdi Hussein Al-Bandar to give a presentation on a rare complication, gastric volvulus after fundoplication leading to ischemia. Dr. Mahdi.
Thank you very much for inviting me to such a conference and symposium. Thank you for the scientific committee and the organizing committee for having me today. And we have a very rare presentation of a gastric volvulus intrathoracic component after fundoplication. I will go brief and short for this patient. He is a Yemeni patient. He's 35-year-old. And he had shortness of breath in the presentation and fundoplication 2 years back. No other previous surgeries, and the patient, he has in distress. He was almost unstable, drowsy, dehydrated, tachycardic. He brought by his colleague. We started resuscitations. We placed the NGT, but it was not successfully inserted. It was difficulty in inserting the NGT. And then we did the ATLS protocol, chest X-ray, and we found large ossification of the left side of the pneumothorax, showing a pneumothorax. As you could see here, we inserted the chest tube and decompression was done. We did a CT scan and it showed the complete intrathoracic gastric volvulus, completely occupying the left side of the chest. So we decided to do the urgent scope, and we found a twist as it's shown in A and P with the complete or picture of ischemia. So we decided to take him to OR. Play the video, please. Can you play the video? So I could see here, there is the omentum, the greater curvature, the colon, and the entire part of the stomach inside a very small hole of the hiatal opening. So I thought the hiatal opening is large enough to accommodate all of this part of the stomach, colon, omentum, but surprisingly, it was a very small. The quality of the video is not that good though. A very small window of the hiatal hernia or the stomach, the stomach inside the chest. So we decided to take the triangular ligament first to expose the area. And then I tried to go up anterior and then go posterior, try to get a window and to deliver that part of the stomach and colon out of the chest. Unfortunately, it was difficult, really difficult to go, and I'm trying to dragging the stomach out. I could not. You see, I'm just dragging out, but the tissue is hardly attacking inside. So I decided to make a window in the diaphragm. However, I don't want to make it wide to, I was stuck later on to close the defect. So I tried to be wise, open a window in the diaphragm, trying to go anterior, posterior, but again, the tissue is highly attacked and adheres to the area of hiatal opening. You can fasten the video, please. And then what I decided to go inside the pleural cavity. So that now I am inside the pleural cavity. I wake a window, put the camera inside the pleura, and I found the fundus ischemic, as you could see here, completely ischemic stomach. So I dragged the fundus from inside pleura out. And this is the only way I could take the stomach out of the pleural cavity. So I took it out from the pleura, grabbing the fundus, and take it slowly. I was too high. So finally, I got the entire stomach easily, grabbing the fundus first, out from the pleural cavity. So you can move on in the video, please. Go into the next video, please. Now, because I know. Yeah, next slide. So this is the stomach, how it looks like after resection. So this is one report in the literature. I haven't seen any reported intrathoracic gastric volvulus ischemia, complete ischemia. So next. This is the division. This is supposed to be before the picture. Anyway, next slide, please. Move on. So we published a paper about this data, about this video, and we did the literature review. Crossing the literature, I found only 14 articles found gastric valvulus after fundoplication. However, none of them documented gastric ischemia of an intrathoracic component. So I will show you these literatures. In the literature, one of them showing gastropexy, so they reduced the stomach and they did gastropexy. In the other studies, they did hiatal repair with gastropexy, and they did not report any gastric ischemia. And one of them only has, 3 of them, they have laparoscopic approach. So this is support of gastric ischemia. Briefly about the gastric valvulus, I know the time is short, so I'm trying to do my best to make it short as possible. So this is potentially lethal, as you know, and it comes more than 180 degree that causing a twist of the stomach and then ischemia. And majority of the time it is intra-abdominal, not intrathoracic. And this is the picture how it looks like in the endoscopy. It's been firstly described by Perty in 1866 in the autopsy. However, during the surgery was diagnosed by Berg et al. In 1896. And he's the guy who presented the first established diagnosis. So the incidence in the 50s, majority of the time, and been recorded as well in the pediatric age group, and less than 1 year of age, 20% of the time, and there is no show of mortality of more than 60% of the time with the evidence of ischemia, or tried as well-known criteria to diagnose a gastric valvulus, which is the ability to insert the gastric tube, pain, and retching vomiting. So you could see here inserting the NGT was impossible and coiling up in the chest. And we'll go briefly about the etiology and categorization of gastric valvulus. The etiology is either the primary or secondary, and when it comes to the primary, it's mainly to the gastric attachment. And here are the gastric attachment. We'll come to the picture here to make it fast and edible. We have the gastrohepatic, gastrophrenic, gastrosplenic, and gastrocolic. Whenever you lose these attachments, then you have high risk of gastric valvulus. Meaning cases of fundoplication or sleeve gastrectomy would have to have a primary cause of gastric valvulus. The secondary causes, if you have something around the stomach, like diaphragm or spleen. So if you have in this, for example, if you have any diaphragmatic defect, then this could be considered secondary causes of gastric valvulus. Okay? Then the classification of gastric valvulus. Now we categorize it upon the reasons and upon the rotations. So rotations, we have 3 rotations: organoaxial, mesenteroaxial, and combined type. When it comes to the organoaxial type, then you will see, you will draw a line between the gastroesophageal junction and the pylorus. And here, the greater curvature will flip over superiorly and making a twist. And this is very common in sleeve gastrectomies. Okay? When it comes to the, I'm flipping the slides to go to the axis, and this is how it comes. The mesenteroaxial exactly making V-shape like, meeting the pyloric to the gastroesophageal junction, making a V-shape, so it causes ischemia at the middle of the stomach. The third type is a combined type between the organoaxial and mesenteroaxial type. So on, we go to the management, resuscitation in GTs, and associated protocol of the ATLS protocols. And the aim of the surgery, reduction of the valvulus, prevention of recurrence, and repairing of predisposing factor like hiatal hernia or attachment to the gastric attachment that we mentioned earlier. Options, we have 2 options. By the Tanner operations, if you have no gastric ischemia, then you have the options to repair and fix the stomach. And the other guy who names Oplis operations, and here I conclude my slides, laparoscopic procedure versus open, literature are lacking, however it is safe and feasible. Thank you very much for the audience for listening.
So we have about 5-6 minutes for questions to all 4 speakers. So if anyone in the audience has any questions or any of the moderators, please feel free. Dr. Billy, Dr. Thompson, Dr. Minion, and Dr. Bunda are all here. So if anyone has any questions, feel free.
Dr. Mahdi, I want to ask you regarding, because you have done a good literature review maybe in gastric volvulus. My question is regarding the gastric volvulus in obese patient. You have a patient with obesity and he has a chronic gastric volvulus.
Okay.
What kind of bariatric procedure you are going to offer him? Patient with chronic gastric volvulus, and he's seeking a bariatric surgery. But he is,
problem,
he is...
Upon my experience, I didn't have an experience with the gastric volvulus chronic gastric volvulus. But by recommendation, gastric volvulus chronic, in the literature, what they do, by the accommodation of toner operation, they do the repair of the hiatal hernia and fixing the stomach. If the patient obese, then he would come to the, in my opinion, in my mental opinion, if we do sleeve, he will have more risk of gall volvulus. Then gastric bypass with fixation is the best option for him. I think, in my opinion. But it's never been, it's not documented in the literature.
Anybody has any opinion regarding patient with gastric volvulus and he's seeking bariatric surgery? What are the options?
And for me, this is my single experience of intrathoracic gastric volvulus ischemia. So it was challenging to go into the pleural cavity. I could not go in. But luckily, alhamdulillah, we got through and we pulled the fundus outside.
Dr. Thompson? Dr. Thompson? Dr. Thompson? What is your approach in detecting Barrett post-sleeve gastrectomy? Are you applying the same guidelines that for those who are at risk for Barrett, or you treat those post-sleeve gastrectomy differently, or based on the symptoms? To my knowledge, there are no guidelines in the States in detecting Barrett post-sleeve.
Yeah, that's a great point. What's the etiology of it? Clearly, there's got to be something different about it, right? Because it's so frequent after sleeve. But is it more benign? Does it have we don't know. What's the course like, right? Is it due to the bile reflux? What's really the cause of this thing? And, you know, a lot of times the diaphragm is I think that, you know, we survey it certainly very aggressively, but I think we need time before we can make any decisions on what the best course of action is. You know, do you want to convert it to a bypass? Do you want to do something else when you start seeing this? Right now, it seems fairly benign, so there's no dramatic recommendations other than sticking with the same surveillance that we have, but the high end of the surveillance options we have for standard Barrett's esophagus. And we can certainly do, you know, Bar-X ablation procedures of the underlying Barrett's. We can remove using ESD or EMR any areas of neoplasia. But the question is beyond that, you know, do you do something else to fix the underlying problem? And we just don't have enough data yet.
Dr. Christopher, another question regarding what do you think about what you call learning curve? Dr. Chris, again.
Learning curve.
What about, yes, did you consider as a learning curve for AI as a long curve or and to apply it safely on the clinical practice? I mean, how is safe to apply the AI in clinical practice? And what about the learning curve of IA and the clinical practice?
Yeah, I think it's going to be really impactful, honestly, especially as more surgeons, especially more senior surgeons that haven't done a lot of endoscopy maybe and they want to get back into it. They want to take care of their own patients. Maybe they want to start doing therapeutic endoscopic procedures. I think AI is going to be really helpful in coaching them through it. We're seeing this in all sorts of studies. Endoscopic ultrasound is one of the hardest things to learn right now, right? And I talked in an earlier lecture how we're using endoscopic ultrasound to do gene therapy, where we're injecting adeno-associated viruses into the tail of the pancreas, you know, to have the beta cells produce their own GLP-1. EUS is pretty difficult. But we're finding that if you have AI-enabled EUS that's giving you instructions on how to perform it as you do it, you can actually take novices that never did it before. They just have some rudimentary endoscopic experience, so we're using first-year fellows in one of the studies as an example. And they're able to do a complete endoscopic ultrasound evaluation. And injecting something in the tail of the pancreas is a lot easier than doing a full examination of the pancreas and other structures. So what we're seeing is that AI, even for complex, very difficult procedures, it is definitely enabling people that don't do it on a regular basis, or that perhaps never really even were exposed to these in training. So I do think AI is going to be very impactful in that regard, and I think in particular it's going to help bariatric surgeons feel more comfortable doing endoscopies when they know they're not going to miss something like a tiny little neoplasm in the stomach or something, right? Because it's going to show them that very directly. So I think it'll be very enabling, and I think that the systems are already kind of available for colonoscopy, and I think in very short term you're going to start seeing them being used in the foregut as well.
Well, thank you so much to all the keynote lecturers. We're just, for the purpose of time and to stay on time for this session, we're going to move on to the video session. I'd like to firstly thank the moderators of the keynote session, Dr. Sami and Dr. Sama. I'd like to invite to chair this session Professor Ayad Al-Khatani and Professor Ali Aminian, if you could kindly take a seat. And I'd like to also invite the panel. The title of this session is something I've seen in my practice as training senior residents, and it's entitled The Skilled Bariatric Surgeon Unfamiliar with Skilled Handling of the Diaphragmatic Hiatus. So what I've noticed is that there's a lot of senior residents who are very good at doing Roux-en-Ys or sleeves and even attendings, but they're not too comfortable if, say, the stomach is herniated into the chest, and how to deal with that and then do the gastric bypass with a sleeve. So that's the purpose of this session. I'd like to invite to the front to sit on the chairs Dr. Helmuth Billy, Professor Mario Musella, Dr. Ahmed Al-Gharzi, Professor Phil Shower, Professor Atif Inam, Professor Marco Raffaelli, Dr. Issam Bataya, Dr. Amir Al-Darazi, Dr. Haitham Fawal, Dr. Muhammad Abu Zaid, and if Dr. Bunder could also join us after that wonderful presentation, be very grateful. So if you could kindly please take a seat on both sets of chairs. Good. So this is okay. So what we're going to do first is I'm going to show you two videos. They're both associated with aortic injury during hiatal hernia dissection. We're going to play both the videos, and then we're going to ask the panel to comment after being chaired by Dr. Ali, Professor Ali, and Ayad. So if you could play the first video, this is a patient having a hiatal hernia dissection, and this is the technique this particular surgeon uses. It's a very old video, but has a lot of lessons. So he's using the scissors to dissect out the hiatus, and he has a huge problem. So the patient was converted to open, and the outcome wasn't good. So that's the first video. We're going to play the second video, and then we'll start the discussion. So if you could kindly play the second video. The second video is a patient who's having a mesh repair hiatus hernia, and during the suturing of the mesh, there is an aortic injury. So we'll just play the second video now.
This is the same patient, huh?
No, no. Yes, it's the same surgeon. Same surgeon, yeah. But this patient did do well, was rescued. So that's all I wanted you to see from this video. And I hand over to Professor Ayad and Professor Ali to chair the session with our panel. Oh, which one? The first one? Is it possible to replay the videos? Because they're too separate, we can't re-loop the whole thing. But we'll keep them going continuously.
Well, what can I say? So it's really heartbreaking, sad for the patients. There are obviously technical issues with those dissections and suturing, but let's start with the panel from maybe Marco gonna start. Just have brief comments, less than a minute, each of you guys. I mean, the surgeon shouldn't be there, but yeah, let's get started. Marco, what do you think?
But is the anatomy clear for everybody?
The quality of the video is not so good for sure, but there are some technical issues. There is no vision of any structure. In the first one, we some way see the aorta, but there is no good exposure. It was the same in the second video. This is the first issue. We have to have a good exposure to perform a good operation. This is the first comment I can do.
Okay, Helmut.
I think he's using a scissor, and I'm a little uncomfortable with two things, the scissor and why are we dissecting there? I see the aorta and I'd like to stay away. Just one little side branch is all it takes to get into a lot of trouble.
Well, what can I say? Yes, basically it's the same comment Helmut was doing. Possibly is a little bit dangerous playing with scissors so close to the aorta. It's just a technical point. I don't know. If you have prepared the pillars, both the left and the right pillar, and you're going to repair, I don't understand why the surgeon has gone so close to the aorta.
Yeah, I mean, why is sweeping on the aorta? We're not dissecting the aorta. Surgeon's supposed to fix the hernia, not reduce the aorta.
Yeah, exactly my point. When you're dissecting in the hiatus, you go from caudal to cephalic. If you're freeing up the esophagus, you don't rack with the scissor like this. This is what was being done. You see here? He's poking it like this here. I don't remember this maneuver in freeing up esophagus anywhere written in the textbooks or taught by the seniors. So this is the problem he did. And one thing which already said that he probably had a bad vision, but I can't justify this movement to the bad optics. This is definitely a never event and a technical failure.
Yeah.
I think, yeah, go ahead, Phil.
Yeah, I was going to say, number one, the quality of the video was so poor, the surgeon has no business doing a delicate dissection with video quality that poor. And this must have been 10 or 15, 20 years ago, maybe? Yeah. Number two, I'll just reinforce what all the surgeons said. The surgeon has no business to have a sharp, dangerous instrument, a 10 millimeter scissors up there. This should be a blunt dissection through anatomic planes. You don't need sharp dissection above the hiatus. Number three, the surgeon was lost in the anatomy. There's no reason to do a posterior dissection near the aorta in this area. So this was a disaster waiting to happen. It could have been prevented, unfortunately. Did the patient survive? The first patient died. Yeah, that's a shame.
Okay, and then, so let's have some comments on the suturing of the second case. So that deep stitch that probably got into the aorta. Can we talk about that from?
Sorry, can you? So it's
Should I?
quite clear that the suture was very, very deep. I mean, this is one of the commonest areas where you injure the aorta, especially in the left, near the left cross, because that's the area where the aorta is the closest to the diaphragm. In that area, like either use other methods or just suture superficial or try to avoid it. Just a literature review of aortic injuries during Nissen fundoplications. The majority occur because of access, so these are either trocar injuries or needle injuries, versus needle injuries. But when you talk about the actual procedure, there are around 4 to 5 cases that are reported in the literature. 2 of those cases ended up with mortalities, despite the fact that the surgeon intraoperatively recognized that there is bleeding. They started looking, they did not find anything. Patient went to the ward, bled to death. Post-mortem studies showed that was a missed aortic injury. The lesson from this is, once there is something like this and you don't have the technical ability to fix it, you need to go to a thoracotomy. Call your vascular surgeon. Try to control the bleeding. Call for help. Don't just say, hey, I didn't find any bleeding in the abdomen, end of story. No, call a thoracic surgeon. Probably do a thoracotomy because you really want to save the patient, because the mortality rate is 50%, according to the literature review that I've conducted.
Very good. Yeah, I mean, no reason to have those deep stitches. Many surgeons only put the glue there and that's going to fix the mesh. So
but this was 15 years ago.
Yeah, maybe glue was not available there. But I mean, just a couple of shallow stitches should be enough to fix the mesh. The way that the mesh works, it's going to stuck there and the adhesion going to form. So no reason to make those deep stitches. Any comments on any of the videos?
Aortic injury, you should know how to prevent. I think technically he has an issue. He gone with the needle right angle, deep. It is clearly, we have to admit this, as it is clearly deep, more than what is required. And he did not maintain the traction properly. And he was depending in sharp and blunt dissection, without knowing the anatomy properly. So in practice, in my simple practice, usually I dissect the hiatus starting from the right side. I keep traction of the gastroesophageal junction up with the assistant. I make it maintained and steady up. And then I ask the anesthetist to place a bougie inside. So I will dissect at the phrenoesophageal membrane exactly along the crust and down to the bougie. Exactly down to the bougie. So I know I will not perforate the esophagus and I won't go deep to the aorta. Sometimes you would have adhesion, especially in radiosurgery. You will find adhesion between the esophagus and the crust and the recurrent nerves, as well as the aorta. So we have to really know, lifting the gastroesophageal junction up, making it plain slowly, step by step, you would avoid this catastrophic injury, because this is unavoidable death, in my opinion. Those patients might die before the thoracic surgeon comes in.
So we agree, Mohammed, maybe for the last question, saving. Now we agree the technique itself is definitely should not happen, and it is doing it in a different way. It should not be also as just trying.
In the university, also senior residents did the same problem, but usually it was with the optical trocar or the vascular surgeon. You can't do anything until the vascular surgeon is in the room. So our policy in the university, if you have an aortic injury, if it's even small aortic injury, you have to compress, put lots of gauzes, open and compress, and wait till the vascular surgeon is coming. Usually the vascular surgeons are available.
Immediate opening and controlling bleeding and call for help.
You don't have to try.
You don't need to try. Abu Karim?
Usually operating in the hiatus revision especially is not easy, and there is certain landmarks that we should not go beyond. For me, the right crust, we should not go on the right side of the right crust not to injure the cava, and on the left we should not go that posterior in order not to injure the aorta. I agree with Muhammad and Amir, we should help. This is, I believe, what should be done.
Samh, you are a vascular surgeon.
They did exactly what you said, is they have to stop everything, recognize the injury, back, open, back, put your gauze in and get the grasper and
keep it there. Okay.
It while the other surgeon is opening the abdomen. Press till the anesthesia will have problems. He has to start putting big lines, cross-match 6 units or all the fresh frozen plasma.
You will
hiatus
open
every
the
day.
diaphragm, or you open the chest?
And then you have to call the vascular surgeon. Vascular surgeon, I come in.
You are a vascular surgeon. Tell us what will you do.
So I assist right away. I take a look. If I can get access, well, depends on the level. If I can access at the diaphragm, I'll go into the diaphragm. And I think I assisted some people with these injuries here in the room. If I can't, right away I do a resuscitative thoracotomy, get the proximal clamp, and then fix the injury. If we do that very early and quickly, patients survive. If we don't, and we keep first fussing around, like the first patient, and we don't recognize it, patient dies. This is a very high aortic injury.
Yes, go ahead.
Just a word of caution. I mean, number one, because here we assume that we know it's an aortic injury. Usually the scenario is you just get the gush of blood. You know it's a major vessel injury. You don't know what it is. One of the most important issues to exclude IVC injuries, because these are going to be fatal. And if you start playing with the wall, it's a thin wall, you will actually make it
cause more.
Yeah. Exactly. Another caution is what you mentioned about how to control it laparoscopically. The moment there is any instability, vital signs, it really needs to be converted to open. I mean, this is not.
No, you are converting to open, but until you need to put something there, Osama. You put something there until you reach there.
Absolutely. But we really need to exclude IVC injuries if you're not sure.
Abdurrahman, you said something?
Very interesting videos. Just two comments. So, at the risk of showing my old age, in 2004, at WashU, there was a rule whenever there's a difficult hiatal case, they will have a thoracic tray in between the rooms in the clean area. So I asked one of our attendings, why do we do that? So at the end of the day, he gave me a VCR tape. It was the entire case, this case. So, yes, this exact case. So this is just the edited version. The dissection included cutting. This happened in Illinois, this case. Second comment, Antonio Torres told me about a case where he was called in the room because an experienced surgeon was doing a mesh repair at the hiatus, and they were noticing some oozing. But it wasn't really significant, a little bit of oozing. And he said he asked them to cut the sutures and remove the mesh, and the patient had an aortic injury. They had a small. So I think these things, you might think they never happen. They really could happen.
Absolutely. Phil?
Yeah, I was going to say a lot of talk about the potential for artificial intelligence, and I think in the future, perhaps this is an area that could help us to help prevent such catastrophic injuries. On that first case, there should have been alarms going off, that the tip of the instrument was way close to a critical structure. So maybe the promise of AI will be able to help surgeons, prevent catastrophic injuries like this, or perhaps, bile duct injuries, by warning, the surgeon that, he or she is too close to a critical structure.
Absolutely. Yes, Osama.
Do you think we should, at least for the juniors, we should tell them what is the safest way to approach the hiatus? I think that should be fundamental, I think, in this case. Telling them, well, you should stay on the crust. You're dissecting the crust of the stomach rather than dissecting the crura or the esophagus, because that's how you stay away from it. And then you just honking as you approach the pleura to avoid injuring the pleura. But also, the one other thing is whenever someone wants to do something that he has not done before, to call in for someone to be a proctor or a mentor for him in the case, that would have helped, I'm sure. Maybe at that time there were no mentors. We were all learning, right?
So Sam, if I can just make a comment about the first case, because I watched the video at length.
Yes.
The problem of the surgeon was, whenever we approach the hiatus from the left, you usually lift the esophagus with your left hand, right? Up, and then dissect. In this case, the esophagus was not lifted, so the esophagus was sitting down, and he was dissecting without lifting the esophagus. I mean, the important thing for, like the comment you made is, whenever you're dissecting the esophagus, one hand has to be lifting it up underneath the vagus nerve. So you've identified the esophagus and the vagus, and then with the other hand, like Phil said, it's gentle, blunt dissection. Tips together, spreads apart. simple, just clip together, spread apart.
Okay, so I guess we have to conclude. Last things from Dr. Shah.
Yeah, I have a question. Do we know what the clinical outcome, the first patient died, the second patient was okay, do we know?
What happened?
And
died?
then,
Both of them died or no?
No,
One died and one survived.
the second patient survived.
okay, and my other question is,
Survival rate.
what was the legal result? Was the first patient, there must have been a lawsuit.
Is in prison now.
I don't know about I don't know about that aspect. The surgeon who gave them to me just told me the outcomes of the first one being not good and the second one being that patient survived. I don't know the legal ramifications.
But I appreciate the surgeons to share these cases. It's learning process, learning tool for the new surgeons that they can see something disastrous and catastrophic can happen in the OR. The young surgeons always see the cases go smoothly, but if you get lost, something like that can happen that can kill patients. So I appreciate Harris and the IBC
Nobody
team
commented on where the mesh was. Do you agree where the mesh was in this case?
And to be sure, Harris was not the surgeon, right, Harris?
No.
Okay.
Okay.
I think I was at
For you,
medical school
Harris,
then.
we finished the session.
Okay. Well, I'd firstly like to thank SASMBS for this very kind invitation to have this 65th IBC symposium. And again, to all the speakers, the lecturers, the panelists, the chairs, moderators, and to all the audience who have stayed so late to hear and learn, hopefully learn from this. And again, thank you so much to you all. Thank you.
Thank you, Harris. And thanks for everybody here.
Thank you.
And if you can, Dr.
Now we'll
Osama, tell the people in terms of the... what time?
So now I think we can go directly to the buses, right? 8 o'clock? Okay, so we'll give people until 8. So the buses will depart at 8.
No, but
And then
I think
tomorrow we will hold...
Osama, they send in the group at 8, is it? They will leave from here at 8.
At 8, yeah.
So the bus will leave at 8 from the gate of the hotel. And we'll be there, inshallah, on time.
So tell them what you got.
Excuse me, guys. Just a fast announcement. Excuse me, guys. Fast announcement. If